So,
So we are good to go.
mute. And yaar boss Krishna.
Alok sir, we can start.
Yes, I'm starting. My dear, my very respected teachers, Professor Dr. Kiti Samal, who is the inaugurator for the today's program and also for the entire NUCD 10th edition. My teacher, Professor Tripathi, my senior, Professor Vijay Mishra, my dear colleague, Alok and Jayant. This is a great day when we are going to celebrate and inaugurate just now the 10th edition of the National Update on Clinical Diabetes. Dear friends, this is a program par excellence where we discuss clinical diabetes, absolutely threadbare, very interactive session. I'll come back to the program in a minute, but in a nutshell, I must mention this is one of the most interactive program which starts with a context setting, theme talk by two leaders in the field, followed by a lively interview with another expert in the field, followed by another talk, and then a panel discussion for 45 minutes with a question answer. The most interactive session, and I have seen this has been adopted by ADIR program in Delhi and many other programs. So dear friends, 10 is a good occult number, is a Dashandi, is a Dashak, and with this auspicious 10th edition of the meeting, may I hand over the meeting for the Ganesh Bandhana and the inauguration by Professor Kiti Samal. Then Alok will speak few words. Then I'll come back again if need be. Yes. Can we have the Ganesh Bandhana and the lighting the lamps, Stuti?
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Now I will request Professor Kiti Samal, our esteemed teacher, and Professor Niranjan Tripathi, our esteemed teacher, to kindly inaugurate the conference and give their blessings for the conference. Alok, please take over and invite them.
Samal, sir, with due respect and regard, it will be my honor and pleasure, our honor and pleasure, sir, if you speak few words regarding NUCD and your life experience on diabetes.
I'll take 1 minute to introduce our teacher, Professor Kitish Chandra Samal. He's one of the earliest MD, DM from no less a place than PGI Chandigarh, one of the earliest. He has been a great endocrinologist, diabetologist, and metabolic physician, still active. He has been our teacher who established the department in the Kotak Medical College and also in the Berhampur Medical College. And his contribution in many areas, but mostly in the pancreatic diabetes, diabetes and heart, lean diabetes, in many areas is absolutely fabulous. To the country where thousands of people have joined us, I seek the blessings of our teacher, Professor Kithis Samal. And as Alok said, with due respect and pranams, we request you, sir, to formally inaugurate with your blessings and say a few words. Sir, you are muted, sir. Can we unmute? Yes, yes.
I have been here in this field for last 50 years.
Good. It's a half a century. Great honor, sir.
Last 50 years. I feel very old in this field.
No, not old, sir. Young. 50 years young.
No. Diabetes update means there are two special points. There should be very early diagnosis to prevent complications and have good management. Now, diabetes have been subdivided into many types, like T1DM, T2DM, MMDM, then many subtypes like pregnancy diabetes, neonatal diabetes, so many types. Now, that means all fields should include the modern treatment in the clinical diabetes. And treatment should include the newer drugs and old drugs. Now, treatment again varied. Some people prefer insulin from the beginning. Some people prefer the oral anti-diabetic. Some prefer oral and insulin. And in the oral, there could be a single drug treatment, could be double drug treatment. Now there are importantly 3 drug treatments. So these are the points to ponder in this meeting and add the newer drugs which are in the field. And best is combination of drugs. Now, last point is the future of diabetes. Now the concept has come, diabetes is gradually disappearing in some parts of the world. Remission of diabetes, which was honored in my younger days. Now people have shown that many diabetes patients have improved completely and gone out of diabetes. Now with this context, the update meeting should have discussion to have more number of remission of diabetes than treat diabetes. And the take-home message should be early diagnosis and early treatment, which will prevent complications. Which will prevent complications in future. And when there is a complication, there are a lot of problems. New drugs which have come up, they are good and strong enough, and just to try and see that they are doing that. Now, many other things are to be told. Now, short meeting, I would like to say that diabetes is a never-ending problem. Never-ending problem. There are many who are managing in this country without testing the blood sugar. Now, in my younger days, glycosylated hemoglobin and HbA1c are not being done. Now it is rampantly done. So now you will do the blood sugar or HbA1c alone. Now many doctors I am seeing, they are doing only the HbA1c and treating. And there are many who are treating to the 2 blood sugar reports and 3 blood sugar reports. Now the meeting should decide which one is important, either HbA1c or only blood sugar report, or both. With these words, I wish best of luck to the discussion and a good take-home message. Thank you, Ashok.
I request Alok to take over and invite Professor Tripathi. Now, before that, it's my great honor and pleasure to also invite my dear friend, Dr. Bansi Bhai, as the guest of honor. I also invite Dr. Vijay Mishra, my senior, Dr. Shishir Mahapatra, Dr. Lalit Meher, Dr. Abhay Shahu, and my dear friend Prasant, my classmate, and everybody who has been invited to the inaugural function. Alok, please take over. Alok, please take over. I also invite, Jayant is one of the core committee member of the entire organization. Jayant. Alok?
Alok sir.
Alok, any problem? Stuti? A minute, otherwise join. I think for interest of time, I'll request Jayant to kindly invite Professor Niranjan Tripathi, our dear teacher, to co-inaugurate and
Good morning, everyone. Most respected Professor Ashok Das sir, Professor Kitish Shamal sir, and Professor Niranjan Tripathi sir, and Professor Dr. Bijay Mishra here, and my good friend Mansi Bhai, and I see Mr. Yashovan Das is also has joined the inauguration, and we have the galaxy of speakers and the guests will be joining very soon. It's a pleasure this morning again starting the 10th NUCD, as Professor Das has already told, and Professor Samal has given his blessings as the inaugurator, as the chief guest, as the mentor to all of us. And year after year, we have watched how science has changed, and we have involved everyone, and we have proceeded ahead. So I congratulate Dr. Alok Kanungo, Professor Ashok Das, and whole team, and all of you who have encouraged us for this good scientific meet. And as our scientific chairman, Professor Das, has already told, it's a novel structure of presentations, debates, and panel discussions, which gives a new message at the end. So with this, I invite Professor Niranjan Tripathi, who is not only a well-wisher since beginning, but he has been a pillar of the medical fraternity, not only in Odisha, in the whole country. Professor Tripathi for a few words.
At the earliest, I will pray Lord Jagannath for this great meeting and also to bless Alok so that he succeeds in his vision of getting total diabetes-free Odisha. So let us all pray Lord Jagannath. As you know, the great Parikrama Prakalpa is going, and there is entire Odisha is now full of Jagannath Bhakti and Jagannath slogans, and let us all pray in the beginning of the meeting. I will recite a slok. You please hold your hands together, put your hands together so that we can pray to Lord Jagannath to bless us to get this meeting as the best one so far, which has been for last 10 years educating people of Odisha. Niladro Sankha Madhye Satadala Kamale Ratna Singha Sanastang Ratnalankara Jutang Navaghana Ruchirang Sanjutang Chagrajena Bhamaya Bhamabhage Rathacharana Jugadan Brahma Rudrendra Vandyang Vedanang Saramishang Swajana Parivrutam Brahmadaru Smarami. This is a family slok for Lord Jagannath, who is the Lord of universe. He will take care of us and make us to tide over all the crises ahead. Namaskar. I must pay my homage to Padma Shri Vinod Kanungo, Professor Vibhuti Bhushan Tripathi, Professor R.K. Das, who are no more because they have gone for their heavenly abode, and they are the early mentors of this NUCD and also Alok and all of us. So we must pray homage at the onset for this, their great blessing to shower on us. As you know, I will just recite ICMR India 2023 data. This says prevalence of diabetes is 101 million in our country, 136 million pre-diabetic, 254 million generalized obesity, 351 million abdominal obesity, and 3 and 4 factors are also major cause of type 2 diabetes in the latter age. So virtually India is a tip of iceberg. The people we are seeing as diabetes, they are only a tip. And the major part of the diabetes and undiagnosed diabetes, pre-diabetes and would-be diabetes, they are submerged in the Pacific Ocean. Just like great Titanic which has just burst open in the Pacific Atlantic Ocean. Similarly, diabetes is bursting up in India as the major killer now with all its complications. So in 2020, there were 463 million diabetes in the world and 77 millions. During 2 years or 1 year, they have added 33 million from 77 million to 101 million now. So it is going in the virtually geometric progression. So when a disease grows in geometric progression and the treatment goes in arithmetic progression, there will be a lot of gap. So NUCD is doing human wonders because diabetes is growing because of industrialization, because of migration to the urban city, because of rising per capita spending power, because of the culture of eating out, insulin resistance, genetic predisposition. All this makes India and Southeast Asia now the capital of diabetes of the world. So even in our states, there are states like Goa, that where the diabetes is up to 26 to 30%. In Puducherry, in Kerala, it is 24 to 28%. So naturally, 1/3 of people are now suffering from diabetes in all these states. But in UP, with so much of population, their diabetes is 4.6%. So naturally, our lifestyle plays a very important part. NUCD, which is for last 10 years doing education, and Alok in particular, who is instrumental in establishing Kanungo specialties of diabetes, has done wonderful work since 2009, and single-handed he has fought diabetes tooth and nail, and he assembles almost all top doctor diabetologists of the country to discuss threadbare the problems we face and the treatment we should take on. And we are glad that one of our close friend, mentor, and friend, philosopher, and guide, Professor K.C. Samal, told that what is the way we can tide over diabetes. But actually, in my lifetime, I see we can tide over. I am fairly old because I am in 60 years of practice now. So naturally, my life is short. But I think with modern drugs, with the modern approach, your newer medicines coming so soon, we will tide over diabetes. And government is taking enough steps so that these metabolic diseases will be diagnosed at the early stage. And as we are hearing often, the diabetes will be done away with, and there will be death knell to diabetes. We pray, we hope, and we pray the divine power of Lord Jagannath to bestow his blessings so that diabetes can be controlled. So friends, with these words, I am for Alok, and I have blessings for Dr. Jayant, and my regards for Vijay, and my respect for Professor K.C. Samal, and all the mentors of Alok who have stimulated him to take this job from his studenthood, from MBBS stage, who has not done any government job, and doing this type of work, which is propagating his knowledge on diabetes through Odisha, acting locally and in India, and also at the international faculty. He is doing a great job, and with his Kanungo Institute of Diabetes Facilities, he will be tied over most of these problems and will shine like a bright star in future. Namaskar.
Thank you, sir. Thank you very much for these very prophetic words and the wonderful statistics latest. Thank you very much, sir, for your blessings, and also soliciting blessing of Lord Jagannath. So we have 10 minutes left for the inauguration. I'll request Alok to give his brief remarks. Then our guest of honor, Dr. Bansi Sabu, and then Alok will, then we will have other speakers speaking few words, and then we'll conclude the inauguration. Over to Alok.
Thank you, Professor Das, Professor Samal, Professor Niranjan Tripathi, Dr. Bansi Sabu, and all my seniors and colleagues and juniors. It's a great pleasure to have the 10th NUCD. I still remember I was going from Bhubaneswar to Cuttack, and this idea came to my mind, and I immediately called Professor Niranjan Tripathi from the road. Sir, can we have a national update on clinical diabetes? Now, what are you talking? I told, yes, clinical diabetes. Now, that is a wonderful idea. Go ahead. And same year, I went to Professor Samal and talked to Professor Ashok Das, Jayant and others, and we created a team and we started. By God's grace, it has really picked up. This is the only national conference from the state. So we are proud to have it every year, year on year, and who's who in diabetes come here. And we are thankful to all our patrons, those who have supported us all these years, like US Vitamin. He has been a main supporter for this academic event without any tags attached. So Novo Nordics, Sanofi, and many other companies like your Glenmark and others are also there, like Abbott and others. So all the friends are there, and I thank all of them for their genuine support. I'll take 1 minute more. Professor Ashok Das has been instrumental in planning this program year on year. Almost every day at 10:30 p.m. we meet. Jayant is busy up to that time. So after that, we do the scientific committee meeting, rounds and rounds and rounds. And without any hesitation, Ashok Bhai has showered his love and affection for us. We are thankful to you, Professor Das. And everybody else, my colleagues, Konwar, Jayasri, Abhay, Sambit, everybody has been helping Kishore. Whomsoever I have asked for help have unconditionally helped us. So the Endocrine Society, Physician Society, RSSDI, everybody is with us. And this will be a 2 days program. Excellent topics have been there about which Professor Das will say. I'll request after this from 10:30 to 11, we'll offer our tribute to the greatest teacher of teachers, Professor R.K. Das, who is no more this year. Last year he left us. So I will request all of you to stay back and join that program from 10:30 onwards. Not now. So I request Dr. Bansi Sabu to say a few words, then back to Professor Das.
My dear friend, Dr. Alok Anugo, first of all, congratulations for this 10th edition of NUCD, a first national update on a clinical diabetes. My very, very dear friend, Dr. Jayant Panda, who is the organizer of this meeting along with Dr. Alok Anugo. My respected teachers, Dr. Ashok Kumar Das sir, Pranam. It's always pleasure to have you at any meeting and to have your blessings. We have respected Dr. Samal sir, Dr. Tripathi Saab and Dr. Mishra from Odisha and our other good friends of Odisha, where we are going to have our Diabetes India meeting in next 2 weeks. Dr. Alok Anugo is doing this meeting since last almost 10 years, and many of these meetings I have attended physically also when he was doing physically, and during last 3-4 years, we are attending this regularly meeting on a national update on a clinical diabetes. What is to me is surprising that even after so many CMEs and educational program across the country in last 25 years, as number of persons with diabetes are increasing, but the average A1C of diabetic patient is not improving. I mean, they are still under uncontrolled. Even we are doing so many meetings and so many educational programs. This clinical update meeting is very much required because most of the time in the CME and educational program, which we are running across the country, sometimes they are more research oriented and may not be clinician be inclined to attend these programs regularly. So I congratulate Dr. Karungo to think of delegates that doing a program only for a clinical diabetes that can improve their patients' care and improve the overall A1C for their patients. This time I like the idea of Dr. Alok Karungo because he has taken an interview of mine on a continuous glucose monitoring, that how we should use the CGM in our clinical practice. So it's a new way of doing a continuous medical education program rather than a simple monologue sort of a talk. It's like a dialogue, discussion, and to understand the disease in a much better way. So not simply showing like slides, which is a very normal way of doing a continuous medical education program in our country. So I really congratulate the newer ideas which had come in the mind of Dr. Alok Kanungo. I am sure Dr. Ashok Kumar Das and Dr. Jayant Panda had given their blessings as well as their ideas that how we should do every year something innovative as far as scientific program is concerned. I give my all the best wishes as a IDF Southeast Asia chair elect to this meeting, and this is meeting which is going to be attended by thousands of doctors, not only from Odisha or eastern part of India, but from all across the country. And I am sure now these meetings will also attract the doctors, particularly online meetings will attract the doctors from other Southeast Asian countries also, because it's much easier for them to attend. So I mean, we should have continue some of the meetings which can be done as a physically, where some doctors can attend physically, and some meetings should continue on an online platform where we can attract more doctors from neighboring countries also. Thank you very much for inviting me and giving me an opportunity in inauguration function. Thank you, sir.
Thank you, Bhante. Thank you so much for attending this. Professor Jayant Panda.
I have spoken few words, but just to complete the list, I see Madam Professor Arkedash, who has joined, and son of Professor Arkedash, Shobhan Das has joined. So soon after this program, we have a memoriam of Professor Arkedash, my teacher, my mentor, and who was a out of the world clinician that will take over. And I have already thanked all of you for the love extended and the participation in this program. And I am hopeful this 2 days program with best of the agenda will go on successful. Thanking you all.
Professor Ashok Das to conclude. Vijay Mishra, sir, one line, few lines.
Sir, Vijay sir, 1 minute, please.
Thank you, Professor Das, Dr. Kanungo, and my respect to Professor K.C. Samal, Dr. Banshi Sabu, and Dr. Jayant Panda, and Niranjan Tripathi sir, all my teachers, all my colleagues, and all the faculty members and delegates. So it is a great honor for me to be here, and I wish all success to the 10th edition of NUCD and the scientific program by the scientific chairman, Dr. Das, and the team has done the exceedingly well job, and which will benefit the clinicians for day-to-day practice. So I wish all success. Thank you.
Professor Ashok Das to conclude.
I think, dear friends, before I conclude, I'll just say one word, as has been expressed by Professor Samal, Professor Tripathi, Professor Jayant and Alok, and also our senior doctor, Professor Vijay Mishra. I must tell you that this program stand out different from other programs. You may ask me in what way. The topics that have been selected, the contribution of Alok has been great. He has selected new topics. They have been never discussed earlier. Like we are discussing today, metabolic healthy obesity. We'll be discussing regarding the AOM, anti-obesity medications as applied to India. We have a full session on the impact of diabetes and the cognitive dysfunction and the nervous system. We have topics which takes care of the complications in different way. We have Dr. Subrat Acharya, the authority, talking to us on NASH. We have Dr. Nitin Kapoor, who is the authority on obesity in the world from Australia, and CMC Vellore talking on obesity. We have oral anti-diabetic drugs. We have the newer drugs, GLP-1RA. We have the issue what Professor Samal and Professor Tripathi said, the LO, lifestyle modification, a full session on the exercise in diabetes. And we have all types of drugs, starting from basal insulin to all other insulin, starting from the all oral drugs, old and new. And you know, the most important part, we're also discussing the latest technology Delivering technology in diabetes, a very unique session, and also very important, we have never discussed before, the muscle disease in diabetes, sarcopenia and its congeners, and the bone disease in diabetes by no less a person than Sanjay Badada, Dr. Nikhil Tandon, and also our Dr. Owen Kishore Behera, and Dr. Rakesh Shah, the president of the ESI. Dear friends, I just told this to say that this program is unique, and you will derive lot of take-home points from, because it's an interactive session. During the question-answer session, please post your questions on the chat box, which we'll take up. Apart from the questions we have already collected, with these words, I seek your indulgence to conclude the inaugural function. My sincere pranams and thanks to Professor Samal, Professor Tripathi, and all the other seniors. Dear friends, I'll stop here and hand over to Dr. Alok for the next session in memoriam of one of our professor, Professor Raj Kishore Das, to whom this year's NUCD is dedicated. Alok.
Thank you, Professor Das. Thank you very much for the inaugural function. At the end of the inaugural function, it's my duty and privilege to thank some of the good hearts in Indian pharma industry, like US Vitamins, Sanofi, Novo Nordisk, Eris, Glenmark, Abbott, Medley, Dr. Kanun Ghosh Diabetes Center, and Kids Hospital for sponsoring this program. So I thank all of them, particularly Farida ma'am from USB, and Vikrant Sotria from Novo Nordisk, and Sanofi, and all other companies. So dear friends, thank you very much. Now it's a very noble duty to pay our homage to the teacher of teachers of doctors, Professor R.K. Das, my guru, my mentor, my maker, my philosopher, my guide, and whatnot. He has held my hand when I was a toddler in medicine, and he taught me how to walk and run. No words will complete my regards for him, my dedication for him. I knew him when I was in class 4, and in 1966 class, I was invited to his Kitu's birthday, his son Jasavanta Das, and from that day, he is my relation. I know him very well. Much before that also, 1964, when my mother fell sick with melena, Professor R.K. Das, the then just postgraduate passed medicine specialist, came and saw her in our Nimchodi house. From that day, I have my regards for him as a doctor, as a clinician. And in 1981, when I started practice, it was from his clinic only. And the history is very long. He has been my mentor. He has been mentor to many. He's unique in teaching clinical medicine, is par excellent. He goes to the basic point, and his basic thought was always, when you are examining a patient, always come to a conclusion. Never say, this may be this may be that. You have to say, what is this, and nothing else. And that was possibly the main focus of his clinical diagnosis. The way people say Bidhan Rai, our Raghu Sahu, and then R.K. Das, they could smell diseases. Professor R.K. Das was an ardent one disciple of Professor Raghu Sahu, who was the legend of Odia doctors and Odia treatments. And Professor Nisamani Nanda was a very strong clinician who was the teacher of Professor R.K. Das. He taught him everything in clinical medicine. Sir always tells me, if Nisamani Babu was not there, I would not have learned so many things. He was born in a village called Mangalpur of Nemala, the Achyutananda Gadi, in 21/9/1935. And he left us on 11/9/2023. We are all near his bedside. And he joined SCB Medical College. He passed at 1958, then joined as a blood bank officer, then post-graduation 1963. Then his two children were born, Mami and Kitu. Mami is the wife of present Reserve Bank Governor Shaktikant Das, who is his son-in-law, Professor R.K. Das, and Kitu or Jaswanta Das is the secretary of Katak Club, and he's a great economist and financial advisor. And Nuabu or Kirti Nuabu, because R.K. Das is my elder brother, so Nuabu has been a support to all of us since then, from the childhood, and she is the stone or the foundation of all these things that happened with Professor R.K. Das. Otherwise, he could not have become such a successful person. My regards to Kirti Nuabu, who is present here, and to Professor R.K. Das. I would like Professor Das' marriage was in 1961, and he took voluntary retirement 2 years before his actual retirement age because of something he didn't like with the government. That is another important aspect, that Professor Das is so headstrong. He has never bent down before anybody. If he believes something, he sticks to it. And whether it is relation, family, or profession, he is a headstrong person, and he is justified. Most of the decisions are absolutely justified and correct. So he has those either liking 100% or not liking 0, that attitude personality. So thank you everybody. Professor Ashok Das, I hand over to you for your homage.
Friends, I am speechless and wordless. He was my teacher, my mentor. I'll just mention 3 things. One is his astute clinical acumen. I brought a patient having little bit of reeling of the head. He looked at the eyes and said, Ashok, can't you see the nystagmus? You know, his way of looking at the patients was absolutely fabulous. And he taught us clinical medicine, and his classes were one of the best classes in medicine. Dear friends, he was friend, philosopher, and guide. He guided us in our career. And I must tell you, he has treated numerous people from Odisha. A small festival used to start near his house. Till his last day, people used to come by car, cycle, bullock cart, a small mela in front of his house from 4 o'clock early in the morning. He was so popular a doctor and so popular a clinician. But what has struck me most is his balancing in life. He was also a sports person. You must have seen him with the shorts and banyan going for the tennis. You must have seen him going for the morning walk. Absolutely fit, entire life, and absolutely clear spoken and absolutely clear knowledge about medicine. Dear friends, I will remain quiet and silent, because in silence is the greatest respect. Sir, we bow down before you and solicit your love and blessings, that we can learn from you all that you have shown before us as a light and a candle enkindles another light. You have enkindled the light of clinical medicine in all of us. I'll stay silent, and that is my greatest respect to you, sir. To say a few
Yeah. Actually, I'm sorry, I got a call from Dr. Manos Barua. His mother fell down and got a fracture, so he's on the way to hospital, and he may not be present during his session. So, regarding Professor R.K. Das, I was listening Alok sir, I was listening Ashok sir, and all who are here in the panel, and they know Professor R.K. Das in and out. and those who are listening to us and not very close with him, for them I'll again tell few things. Professor Das and Dr. Kanungo has already touched upon what I have learned from his personality. The first thing, as already told, his compassion for a common man. Here in Odisha, he was popularly known as Tinga Raju Das. They were telling TRD. That is because he was shouting at people. He was very possessive in his advice, in his suggestion. But at the back end, besides that approach, behind that loud voice, there was a very soft corner we have seen. And if a patient was coming and telling that I don't have my mother, he was going out of the way to help him out to get over from his problem, because he had realized losing mother from a early day of life. And for a common man, somebody was getting a pan, somebody was getting a fish, and I've seen people putting their homage in large scale when Sir passed away, remembering those old days, how he was in touch with a common man and interacting with them and looking into their problem. So it's not true that he was very strict, very possessive and very angry man. I'll not accept it. But out of love, people are calling him, and he had a very, very soft heart and a feeling for a common man. That is number one. Every doctor should have that. Besides the knowledge, besides the position, besides the social respect, we should be able to listen a common man, a person who is in need, and we have to keep our conscience alive in us. My lesson number one from my mentor. The second one that I learned from him, already told by Professor Das, is very sharp clinical sense. He had no much investigations with him. He was not advising A to Z, CT scan, MRI, markers, antigen, antibody. No, he was a old-timer clinician and a physician who was banking upon his clinical sense only. And it was so sharp. He'll see the patient and tell it's a filariasis, it's a amoebiasis, it's a abdominal sepsis, it's a motor neuron disease. So this was just while patient was walking down to him, like book words, he was uttering the diagnosis. I have met him many often, and he has never compromised with his clinical sense. He has never advised a battery of tests to his patients. He has completed his prescription with his clinical diagnosis, the right person for clinical medicine to be adored. That art is getting rare nowadays. We are not getting that clinical sense. People are gradually banking upon the investigations and workups, and many people are advised like that. So such a person with a very compassionate heart, very acute clinical sense is more required for the society than his family or than his friends. So I believe he was a towering medical personality, not only in Odisha, in the country, and all those who know him in the country and in the state and the world have given his tribute. We have lost a personality who was for the science, who was for the people, who was for the students. Family is definitely at loss. So I pay my tribute and request Professor Dash and Dr. Kanungo that in NUCD we can introduce a Professor R.K. Das Memorial Oration in clinical diabetes, because ours is a clinical organization and he was a clinician par excellence. In his tribute, we have done in past also, we can do this oration in Sir's name in clinical diabetes. With this,
Sure.
I rest my speech.
Thank you, Jayant. We have already decided that next year onwards, our gold medal oration, Professor R.K. Das oration on clinical diabetes will be there, and the best of the people who are best in clinical medicine will be invited to deliver that year after year. So it is my honor, and I feel that Mrs. Das should speak few lines and encourage the juniors.
नमस्कार
Mrs. Kirti Das. Namaskar.
ସମସ୍ତେ ତ ସବୁ କଥା କହିଲେ ମୁଁ ଆଉ କଣ କହିବି ମୁଁ କହେ ମୋର ସ୍ପିଚ ନାହିଁ କହିବାକୁ କଣ କହିବି ସବୁ କଥା ଶୁଣିକି ତ ମତେ ବତେ ସବୁ ତ ଶୁଣିଲି ସମସ୍ତେ ଭଲ ଠିକ କହିଲେ ଆଉ କଣ କରିବି ଏତେ ଟେକିଲେ ଏତେ ଭଲ କହିଲେ ଆମେ ଏତେ ଲୁଜ କଲୁ ନା ସେଇଟା ତ ବଡ କଥା ଠିକ ଅଛି ଆଉ ବେଶୀ ମୁଁ କିଛି କହିପାରିବିନି ସମସ୍ତଙ୍କୁ ବହୁତ ଧନ୍ୟବାଦ
ମ୍ୟାଡାମ ସାର୍
Aye.
ଆପଣଙ୍କ ଭିତରେ ଅଛନ୍ତି ସାର୍ଙ୍କର ଆଖିର ଜ୍ୟୋତି ତାଙ୍କର ନିଶ୍ୱାସ ଆମ ଭିତରେ ଅଛି ମ୍ୟାଡାମ sir cannot leave us we are feeling him concrete and definite and for eternity sir will be amidst us sir will live in us in our service to the patient madam ଆମ ସମସ୍ତ ଭୂମିଷ୍ଠ ପ୍ରଣାମ madam
Kitu, would you like to speak few lines? Mr. Yashwanta Das would like to see the new generation. Everybody would like to see you. Please wish the doctors.
they unmute कर दियो yes
Good morning, all the senior doctors. All of you have great respect towards my father. I'm glad to know that. And I would only emphasize that he was a doctor for the common man, as Professor Jayant Panda told. So he would always tell me that these people have come in distress. So I'll not burden them with anything, any tests and everything. Whatever knowledge God has given me, I'll try to cure them. So he is a just man with a lot of principle. He never bent in front of everyone who was unjust. Thank you very much.
Thank you. It is a really happy and sad moment for all of us. I was like a son to him. So thank you, Kitu. Thank you, Mami, Sakti, and Noabu. No amount of words will satisfy him. He will live within us, and we'll see that he lives within the next generations to come. A clinician must survive. During my long association with him, he will tell me, look at this patient, see, examine his abdomen. What do you find? Sir, liver is 3 fingers. Then what? Spleen is how much? Like that, he will continue to say, and that he always tells 3 things. That Alok, if anybody calls you in emergency, never say no, because he is in distress. And in those days, there was no casualty, ICU, all those facilities were there. He was also attending the night calls. Then second thing is, never think one patient is similar or example of another patient. They are different. Examine them, find the cause and treat them. That is a very golden rule. And he also insists that Do not prioritize people on the base of their positions, richness, or other things. Patients are equal. All patients are equal, and they have to wait if they are not very serious. So don't bypass people and see the rich people in the presence of poor. That was his golden rules, and he followed it. He kept his head high till the last moment. Never. In Apollo Hospital, when he was there, he was instructing the sisters, the doctors, that do this way. So he was so conscious about his health, about the clinical medicine. I would like to thank Dr. P.K. Sahu, Prasant Kumar Sahu and his team, those who have taken enough care of Professor Das during last 2-3 years. In emergency, whenever we approached them, they were all out to help us. So he is a person who is to be thanked. I thank everybody, even Trilochan, the fisherman who comes regularly and still cries that Odisha has lost a person who will not be available for centuries again. So he has touched lives. Professor R.K. Das has touched lives, many lives across the country. That is why from Bengal, people were coming and waiting in his doorstep from 3 a.m. onwards. So that is his stature. He was happy with his life, very happy with his achievements, and he was never a dissatisfied person. And that is his greatness. So, Professor Bijay Misra, sir, few lines. Hello? Ashok Das?
Yes,
Can
I'm
you hear
here.
me?
Vijay Babu, unmute. Can you unmute and say one
Yes,
word?
yes.
Yes.
So, thank you, Dr. Karango. Professor Das was our beloved teacher and the teacher of teachers, and his clinical teaching at bedside is superb. And he is a complete man. He has excelled in all spheres of life and an ideal person. And they always, as already been told, that some people tell that he's very angry, but he's one of the very affectionate person. In Bhubaneswar, actually his brother-in-law Narottam Babu's function, because I was connected with Narottam Babu, I have always, he advises me many things because we meet sometimes there. So he's a great person. So my tribute to Professor R.K. Das. He will be there. I am thankful to Dr. Kanungo for his announcement on a memorial lecture. Thank you. I thank everybody for this. Thank you.
Thank you, Vijay Babu. Thank you. We have, if anybody else wants to pay his tribute, we have a couple of minutes, sir.
Niranjan sir. Niranjan sir will speak.
Niranjan sir.
Dear friends, Professor Das is a friend, philosopher, teacher, and guide for me. He is the person who made me a physician out of an orthopedic surgeon. I was reading orthopedics in Delhi University and has completed few months. When he met me at SC Medical College corridor, he told me, why don't you join medicine? I am waiting for you, and you have gone and get yourself admitted in Delhi. Don't go there, just discontinue that, come, there is a vacancy in medicine, and you just take a seat here. In those days, the admission in medicine postgraduate was not that cumbersome as it is today. There are a lot of vacancies, and one can take up any brand of postgraduate branch whenever they wanted. Even people used to get 3-4 postgraduate subjects at a time, and they chose one when they joined this subject. With that, my endeavors with medicine started with him, and I was posted in his ward, and he gave me my postgraduate thesis. He guided me throughout all my postgraduate years. And when the examination came, he had to go to Pondicherry for his, because his son-in-law was there in Chennai as a secretary and he had certain work there. He cancelled it because there was examination for me. He waited. And when the result came that I have passed in that examination, out of 15, only 3 people passed. When he knew that I have passed, he congratulated me and then he went for Pondicherry with his family. So that is Professor R.K. Das to me, because I just consider him a part of my body, because he is, whenever the distance we kept, but he was always in my heart, always my brain, and always I admired him, his personality, his way he talks, the way he carries himself, and the way he conducts himself, and the way he cares the patient. Whenever any patient in his ward was not properly investigated or worked out, when the diagnosis was not written 24 hours, he will shout at the house physician, he will shout at the postgraduate student, the nurse, and everybody who are working there, and will see that the diagnosis is done and basic investigations, clinical investigations are done within 24 hours in the admission of the patient. That was Professor R.K. Das. Full of sympathy, full of empathy, full of care, and full of clinical nurture. And also, he doesn't give many words for a diagnosis. He's, as Alok told, he is simply, there is one diagnosis and one differential diagnosis or 2 differential diagnoses. He doesn't dwell on differential diagnosis. And he so clearly emphasizes his diagnosis that doesn't come any differential diagnosis, and the diagnosis cleans. Because most of us, because he was our assistant professor in those days in a postgraduate, where Professor Aklananda Soding was our professor, Professor Keynote was there as a registrar, and I was a postgraduate student, and all of them know how Professor R.K. Das was. So, because of his simplicity, because of his truthfulness, because of his straightforwardness, all the nurses and all the 4th class employees and the support staff, they used to become alert because Professor R.K. Das is coming. When there was any discrepancy in management of patient, or there was indiscipline in the world, or there was uncleanness, if the bathrooms are not clear, and he will shout at the person who is responsible for that. He will call the warden, he will call the person who is in care of those bathrooms and shout at. So everybody was afraid of him, and everybody was careful about him, and every student was careful that he answers his questions. And if he doesn't answer, he simply growls and makes a face so that the person gets extremely nervous. So he is the person I personally like all through my life, and with his death, I have support system of mine has been lost forever. And I love him because he's a erudite scholar. I respect him because he's a erudite scholar. And I, from my core of my heart, I pray that Lord Jagannath will take care of him because he has not done harm to any patient, because that is our Charakas oath, that we do no harm to any patient, whoever comes to for your care. He has never done any harm by wrong diagnosis to his patients. Long live the legacy of Professor R.K. Das.
Thank you, sir.
Thank you, sir. It is, if we can, be a living demonstration of all that has been said. Physician par excellence, teacher par excellence, a human being full of love and compassion, oriented toward the patients and students. And you know, the wonderful thing, as you rightly said, classless society, he believes, and his dedication for the patient. Let this be the guiding principle of our lives, and he's a living demonstration, and we must be a part of it. With these words, dear friends, with Alok's permission, can we conclude this in memoriam session?
Yes, we will conclude on the last announcement,
Yes.
Ashok Bhai.
Yes.
By next NUCD,
Yes.
we'll publish a book on Professor R.K. Das, the clinician, and
Sure.
it will be edited. You will be the chief editor, and I will be joining you.
I
and
love
we'll
to. I love
complete
to.
this book, and that will be an that will be really a tribute to him, and it will be given to all doctors across the country and state. And I pay my regards to ma'am, Noabu, and the family for being there. And Ashok bhai, please conclude. We are 2 minutes late.
Thank you, dear friends. With sincere pranams to our sir, Professor R.K. Das, we conclude this session. Dear friends, we'll start our scientific program. It's my great honor and pleasure to see my co-chair, Professor Bharat Panigrahi, being here. Sir, thank you, Bharat. You are here. I can see the you can see his credentials put here. He's not retired. Nobody's. I mean, he is absolutely in the top of the world. We have people who are in the session have already joined. So let us start the session right away. As I told you, all the session has a context setting only for 5 minutes, followed by a talk on a lead talk. And this context setting will be done by me and Professor Bharat. Will be taking 2.5 minutes each. We have Professor Sunil Gupta to speak to us about the metabolic healthy obesity, fact or fiction. Sunil is already here, has joined. We have Professor Brice Makkar. Brice Makkar is the president of Obesity Society of India and is the president of the RSSDI, and he is a great person. He is here to speak to us. Can new treatment for obesity and early diabetes replace bariatric surgery? A very thought-provoking talk. And followed by that, there's an interview with Dr. Nitin Kapoor, the head of endocrine metabolism diabetes at CMC Vellore, famous Christian Medical College Vellore. And followed by, there'll be 40 minutes of panel discussion, which will be led by me and Bharat. And please put your questions in the chat box. With this, dear friends, I will just give a very brief introduction to say obesity today is a rising global health concern. That is a risk factor for NCD. It has been rightly said, and that is our paper in the Epicon in Delhi, that obesity is the focus, is the shadow, and greatly ingrained in all NCD, be it diabetes, be it hypertension, be it cardiovascular disease, be it cancer, and anything. It is the starting point. Number two, it is also important to note, it is one of the most important cause of cardiovascular stroke. Even for the kidney disease, it is one of the most important issues. Dear friends, the disease you name, like non-alcoholic steatohepatitis, obesity is the main cause. And excess fat deposit in the abdomen is referred to as abdominal obesity, and the subcutaneous tissue as the peripheral obesity. We are thin fat Indians that we discussed today. And before I hand over to Bharat for a very brief comment, I must tell you that obesity is the most important contemporary challenge. And we have tried our best to give you the persons who will be speaking about it, who have worked a lot. Sunil was the organizing chairman, scientific chairman of the Obesity India Conference 2023 at Nagpur. We have Brice Makkar, I told you, the president of the RO, Society of Obesity for India, and lot of work he has done. Nitin Kapoor is an icon of obesity work, and we have wonderful people who will be joining in the panel discussion. Over to Professor Bharat for a brief comment.
Thank you, Professor Das, and good morning to all. So we have with us the doyens of obesity, like Dr. Sunil Gupta, Dr. Brice Makkar, and Dr. Nitin Kapoor. So friends, as already Professor Das has told, so obesity is itself a disease, and we all know, and there is many relapses also, even if it's controlled. So it's a mother of so many diseases, metabolic, physical, psychological, so many problems with obesity. And as we have already known, diabetes management is not only glycemic management, also management of obesity. So the two primary targets of treatment of diabetes is both glycemic management as well as obesity management. So obesity comes at the top. If you see what are the primary targets, there are two targets. That is obesity, that is weight management, as well as glycemic management. So these are the two targets beyond the other factors also. So now as rightly, all the topics has been chosen. So Dr. Sunil will be talking about metabolic healthy obesity. All of us know there is metabolic healthy. There is many controversies whether to treat or not to treat. But there are many publications are there. There is no term such as metabolic healthy obesity should be there. So Dr. Sunil Gupta will be talking about all these, what is the fat restriction, and Dr. Bijmakar, he will be talking about the new treatment for obesity. Earlier, there are many new treatments nowadays. And also, Dr. Nitin Kapoor will be talking about clinical aspect anti-diabetic drugs. So these are the things we'll be discussing. I think Professor Das has already described how to move. So with this, I again congratulate all the speakers. I invite Dr. Sunil Gupta to start his talk.
Sunil is the president and the chairman of the Sunil's Diabetes Research Center. And over to Sunil. Sunil, all is yours.
Thank you very much, Dr. A.K. Das, sir, and Dr. Panigrahi. And I'll just take maybe 10 seconds for uploading my slides. Hopefully, they are visible.
Yes.
And I'll just make it full screen.
Dr. Sunil conducted a recent conference of All India Association for Advancing Research in Obesity in Nagpur, which was a landmark conference where many guidelines were formulated, and we took a big step ahead. So getting him for our program is a good fortune, and wish all of you will get metabolically healthy obesity factor fusion from him. You can start, Dr.
Thank you very much. Thank you, Dr. Jayant, and thank you once again. There's no conflict of interest for this particular talk. Thank you very much, Dr. A.K. Das, Dr. Alok Kanongo, Dr. Jayant Panda, and the team of NUCD for this honor. Without wasting much of the time, let me have very little introduction of maybe 1 or 2 minutes. That's 1970, the global obesity prevalence has nearly tripled in adult since last almost 4 to 5 decades. And it has become an epidemic now. It contributes to reduced life expectancy of around 20 years. And obesity pandemic may create an multiple health burden for the society, which Dr. A.K. Das has just alluded to. As far as India is concerned, we have a few of the areas where we have very high prevalence of obesity, almost more than 50%, which includes some part of the Andhra Pradesh, Tamil Nadu, and some north and northeast region. Maybe not northeast, but Orissa, Maharashtra, Telangana, Karnataka, maybe in the second space. I don't want to go into detail of causes of consequences, but certainly it is the sedentary lifestyle, environmental factor, genetic predisposition, and lifestyle disease, like lifestyle reasons, like might be calorie intake or maybe high calorie, high fat diet, which all leads to insulin resistance, dyslipidemia, hypertension, diabetes, NAFLD, sleep apnea, cardiovascular disease, cancers, osteoarthritis. I feel the list is still incomplete. Almost each and every organ of the body can be affected through obesity. We also are aware about the thin fat Indian concept that we look thin, but we are visceral. We have visceral obesity, and despite having a low BMI, we are having a good amount of central obesity, and this becomes an atherogenic risk factor for the population. And this category also comes in sometimes into as a different category of obesity. So Asian Indians are phenotypically thin fat, and they have thin fat obesity. They have central obesity with high waist hip ratio. They have small body size, yet high fat body percentage. Central obesity, greater body fat for any given BMI versus Caucasians. They are more prone to have high triglycerides, hyperinsulinemia, and greater insulin resistance. And there are multiple publications on these lines. Now, when we talk about this particular category, we have thin from outside and fat on inside. That is what is the important category we have. We have on extreme right is normal lean patients. You have normal weight central obesity, and you have metabolically obese but normal weight. And on the second in the category is metabolically obese people. So they are obese, but they are metabolically healthy. And this is what is my talk to cover how does the metabolically healthy people, are they better, are they don't have any risk, or are they have equal risk but a slow progression, and what is the reason behind it? So how do we define metabolically healthy obesity? Is a concept derived from the clinical observation that there is a subgroup of patients where obesity do not exhibit the cardiometabolic abnormalities. So we do see people who are obese. We have high BMI, maybe more than sometimes 30. We don't have a cutoff for Asians for metabolic healthy people at this moment of time, and there is lack of consensus across. So still we take 30, but we can certainly go for 27 as we have a cutoff of our own population from 23 to 25 and 25 to 27. For metabolically healthy people, the prevalence is around 10 to 30%, and it varies from different population. And it is also being quoted to be a transient phenotype rather than a permanent phenotype like others. So obesity, it is being defined as a BMI more than 30 plus some of the following cardiometabolic risk factors, which could be fasting triglyceride, which is less than 150, HDL cholesterol in men more than 40, women more than 50, blood pressure is normal, systolic less than 130, diastolic less than 85, and fasting blood glucose less than 100, and the person is not on any of the treatment of dyslipidemia, diabetes, hypertension, and have no cardiovascular disease manifestation. So if some particular obese person with a high BMI of more than 30 have these characteristics, and then they can be called as a metabolically healthy individual or obese people. There are also different food of thought and the recommendation that some of the studies have covered less than 2, because in metabolic syndrome, you keep more than 3 risk factors of central obesity, hypertension, low HDL, high triglyceride, and glucose intolerance. Out of these, if you have less than 2 or less than 2 risk factor, they are also being defined as metabolically healthy individuals. There are so this is the basic criteria which I told you, but there are some advanced criteria. Now they even try to consider the lipid content in the liver, so intrahepatic lipid content and non-alcoholic fatty liver disease, some of the parameters of insulin sensitivity. So this again has been considered. Now these individuals have less ectopic fat storage. They have high leg. I'll just use the laser pointer. Yeah, high leg fat deposition. They have preserved beta cell function and have better cardiovascular risk, fitness. So they are being called as metabolically healthy. So there's another kind of proposition that a protective characteristic of people with metabolically unhealthy versus those who are healthy. And if you see less than 2 metabolic syndrome component, they could be called with low HOMA-IR, so low insulin resistance, no metabolic syndrome component. If you have low metabolic syndrome component and low HOMA-IR, so lower is the risk factors. More you are towards normal obese people. There are various mechanisms which could be responsible for this kind of healthy obese people, they have it's a type 2 diabetes, non-alcoholic fatty liver disease, and hypertension, dyslipidemia at a background, which could be responsible for cardiometabolic risk factors in those who are unhealthy people, and they have chronic energy imbalance, genetic risk factors, increased size of the adipocytes. They have more of ectopic fat in the liver, less fat at the leg, and adipose tissue inflammation. They have adverse signals from the adipokines, metabolites, and immune cells. There could be subclinical inflammation, which again promotes how do we explain metabolically healthy individuals? So the inflammation might be less, which seems to be more in the unhealthy individuals. So MHO individuals exhibit low level of inflammatory markers, which includes CRP, TNF-alpha, IL-6, and the white blood cells. Lean individuals have abundant, sometimes anti-inflammatory adipokines and adiponectin, which again could be, while the obese individual have more pro-inflammatory adipokines, Obese people with type 2 diabetes have elevated inflammatory markers. We know adipose tissue inflammatory markers such as TNF-alpha and IL-6 are elevated in morbidly obese patients. So if you have less inflammatory markers, and that has been observed in patients who have metabolically healthy obesity versus the unhealthy obesity. And then the second concept is adipose tissue expandability hypothesis. And this is a new hypothesis which every one of us should know. Each individual possesses an intrinsic limit on their capacity to store lipid in the adipose tissue. Once this limit is reached, adipose tissue can no longer effectively store lipid, and this is being directed to other organs, more commonly to liver. So adipose tissue mass increases dramatically with obesity. On a cellular level, it leads to both adipocyte hyperplasia and hypertrophy. If not properly supported through the appropriate extracellular matrix remodeling and neovascularization, adipocyte hypertrophy can result in adipocyte stress and the cell death. And this is what is the role of adipose tissue in metabolically healthy obese versus the unhealthy obese. The white adipose tissue is the primary lipid storage organ. It regulates the systemic energy homeostasis by controlling metabolic flexibility and lipid fluxes in the other organs. This white adipose tissue secrete adipokines and regulate energy balance and systemic glucose lipid metabolism within distant target tissues such as liver and muscle. And the prolonged nutrient overload can cause metabolic state, and a state of adipose failure and dysfunction ensures, resulting into the loss of metabolic flexibility. And what this metabolic flexibility is, there's the ability of the body fat to efficiently switch between the different energy sources and adapt to change in nutrient availability and the energy demand. It refers to the body's capacity to shift between the use of glucose and fat as a fuel, depending on the availability of these nutrients. In a metabolically flexible individual, body can effectively switch between the carbohydrate and the fat metabolism, and individuals who lack the metabolic flexibility may have difficulty using the fat as an energy source, leading to reduced endurance, increased fatigue, and increased risk of metabolic diseases like diabetes, obesity, and insulin resistance. Now, what is the natural course of this metabolically healthy obese people? Around 50% of the healthy obese at the baseline were unhealthy obese after 20 years. So in progression, if you see, maybe the progression from the normalcy to obese and unhealthy obesity could be little slow in these individuals because of the decreased inflammation, because of increased flexibility in the adipose tissue. The risk of type 2 diabetes in these individuals is more, and that has been type 2 diabetes and other metabolic risk factors is more in these individuals if you have unhealthy obesity. But if you have healthy obesity, it is associated with substantially lower risk to compared to the unhealthy obese. So if you are unhealthy obese, you are more likely to have metabolic syndrome and diabetes, and then the cardiovascular risk versus the healthy obese people. But still, it does not mean you are as that of normal. If you go through this graph, metabolically healthy lean subjects versus metabolic healthy obese and unhealthy obese, the risk of cardiovascular disease is little high, risk of heart failure is little high, cardiovascular event is little high, and all-cause mortality also seem to be high, and diabetes seems to be again high versus these who are metabolically healthy lean subjects. So risk of cardiovascular disease, events, and type 2 diabetes all-cause mortality seems to be high in these individuals versus the lean, healthy metabolic individuals. Now, how do we apply this to this concept of metabolically healthy obesity in the clinical practice? There's an increased risk of individual with metabolically healthy in obese people for type 2 diabetes, cardiovascular disease, and heart failure as shown you. There's a data about the controversy on the metabolically healthy individuals and the cardiometabolic risk and all-cause mortality. So they have a pooled analysis for 18 studies, 10 years follow-up, 42% greater risk of cardiovascular events. There is no increased risk of mortality. There's a prospective cohort study, 10 years follow-up, no increased risk of cardiovascular disease in elderly population if they are metabolically healthy. Meta-analysis of prospective study of 20 years follow-up, 4 times greater risk of developing type 2 diabetes. So still we have lack in the consistency of various results. And this is again the same data around 5 lakhs people, and ultimately after further analysis and exclusion criteria, around 8,500 were observed for their metabolic status and the inflammatory markers. This is the basics of various metabolically healthy individual, healthy obese, this non-obese, unhealthy non-obese, and unhealthy obese people. And I'll just directly go to the results part. So association between diabetes seems to be higher in even unhealthy obese and even in healthy obese versus the normal normal weight or non-obese individuals. Association between the cardiovascular disease again seems to be when you compare it with unhealthy, seems to be almost similar here, as well as in the little even higher here in the cardiovascular disease respiratory outcome. When it comes to cardiovascular respiratory outcome further, in these individuals, it seems to be almost similar if you see the metabolically healthy obese versus unhealthy obese. For other health outcome, again, the healthy versus unhealthy seems to be more towards the increased risk. Now, cardiovascular metabolic risk. This is again a data from Gawe 2016, around 14,800 patients, and they have classically shown the 3 groups: healthy, suboptimal, and unhealthy. Suboptimal are those who are obese without metabolic risk factors. They are almost on the same line, but much higher than the healthier when it comes to coronary artery disease, stroke, and cardiovascular mortality rate. Even about diabetes, if you compare healthy versus suboptimal healthy versus unhealthy, the suboptimal healthy is nothing but those who are obese or overweight people who does not have any metabolic risk factor also seem to be at a higher risk versus the healthy individuals. And this is again almost on the same line. So do we need to move beyond BMI and should we think further? So we have a proposed clinical staging system of obesity now, and there's a paper which again now come out with considering other factors, not just apart from the obesity and BMI. So if you have a stage 0 obesity, if you don't have any of the medical, mental, and functional abnormality, which goes from stage 1, stage 2, stage 3, and stage 4 with associated comorbidities. So now we have considered it's not only the BMI, but also the functional, mental, and the medical associated comorbidities in these individuals. And this is called as Edmonton Obesity Staging System, EOSS, where different parameters have been considered, and accordingly the obesity should be classified and treated for. And these are the different staging with no risk, and the level of prevention could be from the primordial lifestyle modification, stage 1 behavioral changes, and stage 2 you can go for secondary prevention. Stage 3 is complication, which is significant tertiary prevention, and maybe medical and surgical treatment has been offered. And stage 4, of course, the tertiary prevention. So you have staging. To conclude this my session, the takeaway is many prospective meta-analysis have indicated that people with metabolically healthy obesity are at increased risk of type 2 diabetes as well as cardiovascular disease, heart failure, and some have shown the increased risk of mortality. The recent data indicate that they have higher risk of all-cause mortality, ASCVD risk, heart failure, and respiratory disease. They represent transient phenotype leading to increased risk of ASCVD and all-cause mortality, and usually progress to a metabolic deterioration in years to come. Maybe the progression is little more slower versus the unhealthy obese people. Hence, using MHO is a misleading and should not be used, in my opinion. With this, I stop here. So every person with so-called metabolically healthy obese need to be focused for prevention from the right away from the day of diagnosis, and given the advantage of all anti-obesity measures versus that of the lean, healthy individuals, and as well as versus the unhealthy obese people. And this particular slide.
Thank you very much for this great lecture. We'll come back to the questions. I have got already few questions for you, which has come in the chat box. Now it's my great pleasure and honor to invite a great person who is very simple, Dr. Professor Briz Makkar. Can I have his biodata flashed? I don't need the biodata to read, but I must tell you that Briz Makkar has been the presiding officer in the many aspects of diabetes and obesity. He's the director of the Diabetes Obesity Center, Dr. Makkar Center in New Delhi. He is the president of the RSSDI, had been the honorary secretary of the Obesity Association, and has been member of AAC International. He is the course director for a unique program called ACCD. But what is most important today's lecture, that he's an authority on obesity, and you will see that he makes things very simple. And over to Bridge to speak to us on a very important aspect. Can new treatment for obesity and early treatment for diabetes, new treatment for obesity and early treatment for diabetes, can it replace bariatric surgery? On my own behalf, on behalf of Professor Bharat Panigrai, I invite you, Bridge, to give your oration in next 15-17 minutes.
Thank you, sir. Thank you for very kind words. Good morning, everyone. Dr. Panigrai, sir. At the outset, I must thank Dr. Alok and team NUCD for this great opportunity. So I am going to share my presentation. And as sir just mentioned, I am going to speak on can newer treatments for obesity and early diabetes replace bariatric surgery? Sir, can you see my presentation?
Yes. We can see clearly. Now it is full screen. Please continue.
Okay. So I don't have any disclosure for this presentation. So we know that current strategies for management of diabetes include basically they include dietary advice or dietary behavior, modifications in the lifestyle, increasing physical activity, improving diet, behavior therapy, and if nothing is working, all these are not working, we were thinking of, earlier addition of this. Doesn't seem to be working here. This slide.
Okay. It has come now.
So, and combination with pharmacotherapy. And if it doesn't work, then we go to bariatric surgery. Now, we know that with more and more data coming, that incremental weight loss is associated with greater benefit. So if we are able to achieve 10 to 15% weight loss, we are able to not only put diabetes in remission, we can reduce the cardiovascular risk, we can reduce cardiovascular mortality, we can improve cardiac function, and we can improve the risk of NAFLD also. But the challenge has been the amount of weight loss that we were able to achieve with medical options early. So lifestyle interventions could give us a weight loss in the range of 3 to 8%, which was again not sustainable most of the time. The initial intervention started with gastric band, which gave us weight loss in the range of 15 to 20%. But then we got bariatric surgery, gastric sleeve and gastric bypass, giving us weight reduction going up to almost 1/3 of the total body weight. Now, difference between medical management and surgical management was big. With pharmacotherapy and lifestyle interventions, we were able to achieve about 10 to 12% weight loss at best, while the surgery gave us weight loss going to 30 to 35%. So the gap was very big. That is why bariatric surgery was becoming more and more popular. Another thing is that earlier medications that we used for management of diabetes were associated with significant, risk component or significant adverse events, and therefore they were banned one after the other. And the latest grave in the graveyard was of lorcaserin, which, despite being introduced in the market and despite being shown CV safe, finally showed some increase in the risk of cancer and finally abandoned. Now, the only approved drugs that we have in India are Orlistat. The other FDA-approved drugs are phentermine topiramate combination, naltrexone, bupropion, or liraglutide 3 mg. These were the drugs available till about 2 years back when we started getting new drugs. Now, if you look at the comparative weight loss with these molecules, the best that you could get was what 10% weight loss, anything between 5 to 10% weight loss, and that was the best that we could get, and we had to, then medication had to be continued to sustain it. In addition, there were side effects with these medications also, and tolerance was not very good. Now, then we started getting better molecules which were acting on the GLP-1 receptor, and we started with a new era of GLP-1 receptor agonists in the management of obesity. Now, we know GLP-1 receptor agonists like liraglutide, dulaglutide, we have been using for diabetes, and they have been shown to induce weight loss also because of their central effect in hypothalamus and also by slowing gastric emptying. And the composite benefit of reducing glycemia and weight actually, made them a preferred drug for management of diabetes. And we know most of the people with type 2 diabetes have overweight and obesity. Now we know the GLP-1 effects. They mainly act on the pancreatic beta cell to increase insulin secretion and also suppress glucagon secretion. But at the same time, they have a direct effect in the central or brain GLP-1 receptors by promoting satiety and reducing appetite. And at the same time, they also reduce gastric slow emptying. So with this effect, there is significant reduction in appetite and hunger. So the first prototype that was central acting GLP-1 is liraglutide, which acted on central GLP-1 receptor in the arcuate nucleus, thereby activating the PONC card pathway, stimulating the MC4 receptors and decreasing the appetite. And this was the mechanism of action that worked in people with diabetes and helped in weight loss. So if you look at the initial data with various GLP-1s, the best weight loss that we were getting was in the range of about 4%, 3 to 4% or 3 to 4 kilos of weight loss. Then we had studies with higher dose of liraglutide tested for people with obesity for weight management and not for sugar management. And this program was called scale studies, and liraglutide 3 milligrams was tested in scale obesity, pre-diabetes, scale diabetes, scale, in people with the obesity only and sleep apnea. And scale program showed that liraglutide 3 milligrams could give you a weight reduction going to 6%. This was the best we could get. Then we got semaglutide, and we realized the semaglutide is much better in lowering the energy intake, that means reducing the appetite. And the energy intake lowering effect of semaglutide was almost twice as significant as that of liraglutide. It is again a small molecule and has access to brain and works through the key physiological and well-described satiety and hunger signals. The action involves both the receptors in hypothalamus and brain. And sustained clinical trial program was initially started to assess the semaglutide action and evaluation in people with diabetes. And this is the whole sustained studies which were done in people with diabetes. This was tested as monotherapy versus placebo versus different molecules and in combination with different molecules. And the interesting part was that not only this was more potent in giving a A1C reduction going to the range of 1.5 to 2%. In addition, there was about 5% reduction in the weight. And significantly higher number of people achieved weight loss of more than 5% when they were treated with semaglutide. Then we got oral semaglutide, which is Rybelsus in Indian market, and we got the Pioneer trials, which evaluated oral semaglutide in management of diabetes. And again, in various settings, not only there was significant reduction in the A1C, there was also significant reduction in the weight. And again, with oral semaglutide, most of the studies showed that one could achieve a weight loss of going to 5 kilograms, and more number of patients as compared to those not on semaglutide were able to achieve a weight loss of more than 5%, which is considered significant. So, proportion, this is the slide which is showing the patients achieving a body weight loss of more than 5%. This was, then this was the step from where the further studies took off. Okay. So this led to the further development of semaglutide in STEP program. STEP was basically semaglutide treatment evaluation, people with obesity, and higher dose of semaglutide was tested in management of obesity. So STEP has four trials. Step 1 was for management of weight in obese individuals. Step 2 was in people with diabetes for obesity management. Step 3 was in combination with behavior therapy, and step 4 was the continuation of therapy to sustain weight loss. And interesting thing was all these trials showed that with semaglutide 2.4 milligrams, we could achieve a weight loss of about 17%, which was very, very significant and much better than the other drugs that we were using till that time. And not only that, semaglutide also gave a A1C reduction going in the range of 2 to 2.2%. And people who had more than 10% weight loss had in people with diabetes, they had a A1C reduction going to 2.2%. And the baseline A1C was only 8%. So with this reduction, all these people were having A1C going to about 6 to 5.5 to 6%, which was complete remission of diabetes. Not only that, this also showed benefits beyond weight loss, which included reduction in the blood pressure, improvement in the inflammatory status, better glycemic control, and better quality of life. So step 4 showed that we have to continue therapy to sustain weight loss. If we discontinue therapy, the weight would come back. And it is expected, we have know this from earlier trials with multiple drugs and lifestyle interventions also, that you have to have a sustained therapy in place to induce weight loss and then sustain weight loss. If you look at the side effect profile, except for the GI side effects, there was no major risk. There was no increase in the risk of acute pancreatitis or malignancies in these trials. And the post-hoc analysis showed the safety profile was pretty good, except for the GI upset. So we got semaglutide 2.4 milligram approved worldwide, and we got approval in India also in 2021, though it has not been introduced in Indian market till now. Then we got tirzepatide, which is dual GIP GLP-1 receptor agonist. This basically this molecule is created by combining two components, GIP and GLP-1, through a process called coagulation, and was the first data was presented by Matthias Schaub, who was recently in India, brilliant scientist, and he combined these molecules to give synergy not only in improving weight loss but also in reducing the side effects. So if you look at the GIP receptor mechanism, you will see that it reduces food intake, it also reduces nausea and improves body weight and increases energy expenditure, which are the effects are very much synergistic or complementary to GLP-1 action. And the initial clinical trial data with this molecule showed that people who were treated, people with diabetes who were treated with tirzepatide, not only achieved a A1C reduction going to about 2.4% at higher doses, they also lost weight going to about 12%, 11 to 12%. And this was initially, this was then further studied in SURPASS studies. So SURPASS program was for study of tirzepatide in people with diabetes and different settings. So SURPASS first was monotherapy, SURPASS 2 was versus semaglutide, versus degludec, versus glargine, and so on. And all SURPASS studies showed that if you are using 10 to 15 milligram of tirzepatide, you could achieve a A1C reduction going to about 2.5%. Now imagine if you are having a baseline A1C of about 8.5%, you are going to A1C of 6%, which is remission of diabetes. Not only that, the number of people who were achieving A1C less than 5.7% were in the range of 30 to 60%. And not only that, again, there was significant weight reduction going to about 13% weight loss, 13 to 15% weight loss with tirzepatide 15 milligrams. The side effect profile was similar to other GLP-1 receptor agonists, and this led to further study of tirzepatide in people with obesity in a program called SURMOUNT. And now we have data from SURMOUNT 1, 2, and 3 trials already available. SURMOUNT 1 involved tirzepatide once weekly for management of obesity, and again showed significant reduction in weight going to about 20%, significant reduction going up to about 20 to 20.5%, and almost all patients achieving weight loss of more than 5%, almost 80% achieving more than 10%, almost 70% achieving weight loss of more than 15%. Surmount 3 Surmount data further again, is from Surmount 3 is available now, and again showed not only there is significant 20% or 21% reduction in body weight, higher percentage of people are achieving weight loss, and if you are having ongoing therapy, you are able to sustain weight loss going up to about 25% in people with diabetes at the end of people with obesity at the end of 1 year. Now both semaglutide and tirzepatide are approved, and tirzepatide now is approved for weight loss also in US, but it is not available in India. Then we have, amylin analogs, which is cagrilintide, and we know that amylin is a co-secreted neuropeptide with the insulin, and studies with amylin have shown that it reduces weight. So cagrilintide showed weight loss going to about 10%, and now it is being studied in combination with semaglutide, and studies have shown very promising results going up to about 17 to 20% weight loss. Then this was a new molecule which was data was presented at the ADA meeting last year called retatrutide, and it is a triple agonist. It is a triple hormone agonist which has combination of effects of GIP, GLP-1 and glucagon receptors, and the initial data was presented to assess the efficacy, tolerability and safety of retatrutide for weight management. This was done in people with BMI in the age group of 18 to 75 years, and they excluded people with diabetes from this study. And they studied various doses ranging from 2 milligrams to 12 milligrams. And the interesting thing was at the end of 24 weeks, the people who were on 12 milligrams achieved a weight loss going to about 20%. But if you look at the follow-up data at 48 weeks, the weight loss was about 25%. And the absolute weight change was in the range of about 26 kilos in people who were receiving 12 kgs. Now, other thing is almost 100% people achieved weight loss of more than 5%. 90% achieved more than 10%, 80% achieved more than 15%, almost two-thirds achieved more than 20% weight loss, almost half achieved more than 25% weight loss, and almost quarter achieved more than 30% weight loss. The question is the long-term safety of these molecules. Now we have the semaglutide CV outcome study also in place, and this was a study which looked at the impact safety of semaglutide, injectable semaglutide once weekly added to standard of care in people with obesity. So 3 years follow-up was there, involved more than 17,000 patients. Mean duration of follow-up was 39.8 months, and mean duration of drug exposure was about 35 months. Not only statistically significant, reduction in the risk of CV endpoints, the study showed that injectable semaglutide 2.4 milligram was superior to placebo in terms of reducing CV endpoints, CV death, heart failure endpoints, as well as the 3-point composite. So select trials showed that in patients with pre-existing cardiovascular disease and overweight or obesity, but without diabetes, weekly subcutaneous semaglutide at a dose of 2.4 milligram was superior to placebo, reducing incidence of death from CV causes, non-fatal MI, non-fatal stroke in a median follow-up of about 40 weeks. Now, back to this slide. So earlier we were able to achieve about 12% reduction with at best with pharmacotherapy, but now situation has changed and we are matching the weight reduction achieved by bariatric surgery. So take home is that availability of newer weight management drugs has made it possible to achieve weight loss similar to that achieved by bariatric surgery. And medical management has significant advantages. You don't need surgical skills. You don't need hospitalization. There is no associated mortality whatsoever. In fact, there is a reduction in mortality with medication. There is no surgical infrastructure required. There are no post-op complications. And there is no, kind of limit to resources. It is scalable. Surgery, to scale up surgery, you have to train everybody to do surgery, which is not possible. But to use a medication, it can be, the education be disseminated and, use can be scaled up. So surgery, we know surgery always starts with a basic surgery and then you go to advancements like laparoscopic surgery, and then finally you have achieved robotic surgery, now increasing safety, but still there is mortality. And also one has to remember that end of any invasive therapy is a non-invasive therapy, which is a pill or a capsule right now. And maybe in time to come, it will be something like gene manipulation. So with that, I end my presentation. We are in an era where we are likely to replace bariatric surgery with the medical management.
Thank you, Breeze, for a wonderful lecture. Great lecture. We'll be having question answer in another 15 minutes. May I now request to start the interview with Dr. Nitin Kapoor. So please start the interview. This is Dr. Nitin Kapoor. I told you MD, DM, postdoc fellow at USA and PhD from the Melbourne University. His biodata is superb. And I think I'll not go to details of it, but I must tell you that he is go-to man today for anything on the obesity. Over to RX events to start the interview, please. And I welcome Nita. Nita, hearty welcome to you. Please start. My dear friends and esteemed audience, it's a great day for me when I'm with one of my very esteemed colleague, very young colleague, who is Professor Dr. Nitin Kapoor, MD, DM, of course, MBBS also from the CMC Vellore, the citadel of learning, research in many topics, including endocrinology. And following his DM, he has also spent time where he has PhD in obesity from the genetic and clinical aspects of obesity. So, Nitin, we couldn't have more fit person for this interview than yourself. Today's topic that we are going to discuss is about the anti-obesity medications. Before I start, I like Nitin to give a brief introduction about his views on the huge space that we have today for the obesity and these drugs which have become the order of the day for treatment of overweight, obesity, diabetes plus obesity, and also general obesity. The second point, Nitin, I would like you to touch upon to make the people sensitize how important is this topic, is to say how obesity has been the driver of the entire NCD gamut. Over to you, Nitin. 1 or 2 words about this, then go to interview.
Thank you so much, sir. It's always a privilege and honor to share the platform with you. It is indeed a great pleasure. And talking about obesity with you, sir, as a master, is indeed a great feeling for me. So definitely, as you rightly said, maybe I would say the second point first, obesity being the mother of all NCDs. And this is not new to us. We have learned this over the years through several studies done within India and overseas, that the entire crux of what we call as the crux of metabolic syndrome, if I may, is the visceral adipose tissue and the subsequent insulin resistance that develops from it. So definitely, obesity is important for diabetes, hypertension, dyslipidemia, coronary artery disease, and now the realm is getting even more wider when we talk of the fatty liver disease or the Alzheimer's and so on and so forth. So yes, for all NCDs, obesity is a common denominator. The sad part being it is increasing rapidly. But as you rightly said, the newer medications are showing us a ray of hope in this area of medicine, where a very good pharmacological intervention has emerged over the last decade, and looking forward to talk about it, sir.
Thank you about it. Then we'll directly go. What are the different classes of newer anti-obesity medications, and would you like to list them, classify them? A simple presentation, Nitin.
Sure, sir. So many years we had many drugs that came and went. We used them for a few years, and we realized that they had side effects, and so we had to stop using. But over the last decade or so, we've had GLP-1RAs, which have emerged very rapidly in the last 2 years. This year's ADA meeting, there were so many newer molecules, but as you said, how to classify them? I would classify them pharmacologically based on the receptors they work on. So primarily, yes, there is a class of GLP-1RAs, but more recently, the combinations, that is GLP and GIP receptor agonists, and now the triple agonists, the GLP, GIP, and glucagon agonists are the three broad classes of drugs that we would call in the obesity front. Just very briefly, if I was to name a few of them, so only GLP-1RAs would be drugs like liraglutide, semaglutide, and more recently, even an oral GLP-1RA has come up, orforglipron. Talking about GLP and GIP together, we know it is tirzepatide, and that has been used. And the third category, which is the combination of GLP, GIP, and glucagon, we know the drug is retatrutide. In addition to this, two more drugs that I'd like to mention. One is GLP and glucagon receptor agonist. Sorry, GLP and glucagon receptor agonist, which is called survodutide. And the third one, the last one that I'd like to mention is the combination of GLP-1 with amylin, which is so cagrilintide with semaglutide. So these are 5 classes of drugs: GLP-1RAs, GLP-1 with GIP, GLP-1, GIP, and glucagon, GLP-1 with amylin, GLP-1 with glucagon alone.
Thank you. I think, Nitin, I had the opportunity of listening to Thomas from Germany, from the Munich Institute of Obesity, who has been involved with Eli Lilly with the discovery of the tirzepatide, and also he showed us some data regarding they call it Tristat, or what they call it, the triple combination Tristat, and also did refer to the cagrilintide and the other one, survodutide, that you referred to. Can you just tell us and I like the way you started. All the drugs that came few years back, remember, they had the right-sided heart leaks, remember? And
Correct.
It was so unfortunate. Many of the drugs came, but they could not stand the test of time. But these drugs, so far, so good. I'm sure they will be also lasting long. They have stood the test of time. Now, Nitin, I just want to know, how are the how is their efficacy different if you compare these 5 groups, or you like to compare the main 3 groups? I leave it to you. How do you compare their efficacy, and how their efficacy are different?
Sure, sir. So maybe I will go through the declining order of efficacy. So when we talk of retatrutide, which I mentioned as a triple drug agonist, is currently the most potent anti-obesity drug in trials. That is 24.2% of weight loss. Going further, the double agonist, the tirzepatide.
Again, how much you said? 42.5?
24.2, sir.
24.2.
That is retatrutide. Tirzepatide, a step before, where it is just GLP and GIP, is 22%. Moving further, survodutide, which is GLP and glucagon, about 19%. Semaglutide in different trials, the maximum that we've seen is about 17 to 18%. And the orforglipron, which is an oral GLP-1, has got 15%. So I'm mentioning the most efficacious ones, ranging from 15 to 25%, But nevertheless, in clinical practice, in a patient who's 100 kgs, even 15 kgs is a huge boon.
Great. I think it's great, and the benefits are, unimaginable. I think, Nitin, I'll come back to a very important question. The one which is in our country today very, very used very widely, drugs are sometimes not even available, Nitin, is the oral semaglutide. I just like to know that, why there is a difference in the efficacy of weight loss of this particular molecule, oral semaglutide, about 5% weight loss, whereas injectable up to 15% weight loss. Why is the difference?
Yes, sir. Even though the molecule is same, the main difference is about the way it is administered. So when we're taking the oral semaglutide, it is working predominantly in the portal circulation, very effective for diabetes, causing about 5% weight loss. But when we're talking of obesity, the action that we really want to hit is the hypothalamus, is the appetite. And I think for that, systemic circulation is more important. We don't want the drug to be entrapped in the portal circulation. And that's what the subcutaneous semaglutide goes and hits the hypothalamus. But having said that, I must make a point that higher doses of oral semaglutide are able to reach the hypothalamus. And we've looked at bigger trials using 50 and 25 milligrams of semaglutide in the Pioneer Plus trial and the OSS trial. And we've got 10 to 12% weight loss.
Yeah, I think, Nitin, I'm aware. For my dear friends who have joined us in thousands in numbers, I must tell you that Professor Dr. Nitin Kapoor had been the pioneer in the Pioneer trial, Pioneer 8, Pioneer Plus trial, and he has the unique distinction of even giving this drug in the open trial. So one of the advantages of the open trial, Nitin, is your awareness about the tolerability. So I would like to know that how had been the tolerability of this drug in the Pioneer 8 trial, Pioneer Plus trial, while the drug is of a larger dose, and what has been its effect, any side effect, and the tolerability has been very good. You have told me in the sidelines of many meetings. So like this to discuss with the audience in little detail.
Absolutely, sir. So as you rightly mentioned, in the Pioneer Plus trial, there was no placebo group. So we know that all these patients are getting the active molecule semaglutide. It was 25 and 50 milligrams, or obviously it was gradually increased to these doses. But the kind of weight loss that we've got in all the patients, because all the patients are getting the active drug, is about 10 to 12%. Yes, the results have been published in Lancet a couple of weeks ago. But more importantly, when we use these drugs, I think the important message that we learned, not only from our center, but other sites in India as well, that those patients who tolerate the drug, tolerate it fine from day one. And those patients who are not tolerating it from day one, those are the only patients who really, keep getting away from it. And the dropout rate was just 2 patients out of 15 from our center, but from other centers as well. So I think the adverse reactions are more idiosyncratic, wherein those who don't tolerate it at all, and those who tolerate or have mild side effects, when they are gradually built up, they tackle it well.
Yeah. So how many will really get into this so-called quote unquote? It's not exactly idiosyncratic, but they get into the side effect. Roughly how much? I think quite a few, no? Very few.
About maximum, I would say, so 1 or 2 out of 15.
I think
so
that's
10.
Good. Now, Nitin, there is one more issue that I would like to ask you. I mean, how many people would you say, from your great experience, had non-responders to this drug?
Yes, sir. So I think there is a very nice paper on this, which was published in NEJM and International Journal of Obesity 4 years ago, comparing the efficacy or the response rate of all anti-obesity drugs that we've had from the very beginning. And forever, this number was never above 40 to 50% in terms of responders. This is the first time, both for semaglutide and for tirzepatide, they've quoted the number of 86% responders for semaglutide, 91% responders for tirzepatide. So 9 out of 10 people respond fabulously.
I think that's a great news, very encouraging news. When you refer to old drugs, I don't want to go back to the old drugs, but do you think that the old paper, very old papers in 2001, again in 2008, did attribute some weight loss to metformin? But we knew metformin is weight neutral, not weight losing. What's your just one line comment on the metformin?
So only to use it if there is some dysglycemia which is present. Without dysglycemia for obesity, absolutely no, sir.
Yeah. What is your new drugs? I mean, your comment on the orally start, just a single line comment.
I do use it. A single line comment would be in patients who consume very large amounts of fat. I have patients coming from certain communities who say, doctor, we have no choice, but because of our culture, we have to cook biryani, we have to have that fat. So in those patients who consume maybe 20 to 30% of their calories from fat, it is helpful for them to lose weight.
Great news. I think, Nitin, there's a very important question. What is the role of new gene-targeted medications, like, say, setmelanotide?
Yes, sir. So this is also a very emerging field, especially relevant to our country in India, because we do still see a lot of consanguinity, especially, sir, in our part of the states in Andhra Pradesh and Tamil Nadu, we do see consanguinity still very common. And so definitely these genetic disorders do increase. We did a study in Vellore looking at the genetic patterns of children with morbid obesity and found that 18% of these young onset severely obese children have a genetic mutation. Maybe MC4R was the most common, but even LEP were described. Now, setmelanotide is a specific drug, which is an MC4R agonist. And if you have a patient who's got a mutation positive, this drug in phase 2 and phase 3 trials has shown significant weight loss up to the scale of 20 kgs. So this is getting more into a personalized therapy. If you have a gene, you treat it specifically for that patient. It may not be very common, but for that patient, it makes a whole lot of difference.
Great. I think if I may ask you, I don't want to leave audience not knowing what were the salient features when you had the genetic and the clinical aspects of obesity in your study in Australia, in Melbourne. Just
Right,
one or two line, which will be applicable to us. It was a very high-level thesis, genetic, molecular diagnosis, but what will be applicable? 1 or 2 lines, Nitin.
Sure. So I think the two key messages I'd like to leave here were that when we talk of genetic problems of obesity, our conventional teaching is that patients should have, mental retardation, patients should have deformities, but that's not the case. These patients who we saw who had mutation positivity were actually intelligent people, especially I'm talking of MC4R. They're very tall. They're just severely obese and they have hyperphagia, but they are intelligent and they have no other deformity as such. So I think for the clinician, it is important that not to think of only genetic disorders when we are having, retardation, but severe obesity.
How is the scholastic performance? But that question is irrelevant now from your studies. Good.
Yes, sir. So for these common mutations, no, there are some disorders which have that, but not everybody. So that is one important message that I'd like to leave. And taking that family history, not only finding out who is obese, but what is the age of onset of obesity in the family members is helpful.
Great, Nitin. Great insight. Now, this when you use oral semaglutide, or we'll be using tirzepatide in coming times, these people are also given a lot of other drugs for the comorbidities they have. So what is your message for use of the concomitant use of other drugs beyond this anti-obesity drug? Let's confine to SEMA, oral SEMA and tirza.
So I think that is a very, very important question because many times in clinical practice, these patients are not presenting to us only with obesity. They may have diabetes, they may have blood pressure, sometimes they may have depression, sometimes in children, especially anti-epileptics. So each of these disorders would have their drugs which are either weight neutral, some of them may be helping to lose weight, but many of them are actually weight gaining. Maybe taking a simple example of diabetes, if I have a patient who's on large doses of sulfonylurea, I would like to curtail that and maybe at least put it to either a DPP-4 or if not a DPP-4, then at least an SGLT2 or at least a weight neutral drug rather than giving these weight gaining drugs. Similarly, for epilepsy, I'd like to avoid valproate. Again, for antidepressant, there are so many drugs that are very, very not so good for weight. So on one hand, if you're giving oral semaglutide, you're trying to get the patient to lose weight, but the entire effort is neutralized if you are not taking care of the concomitant medicine. So I would say that is an equally important
point. It's a great message, Cut down issues cut down the antidepressant, gaining weight. And I think a great message. I think we'll treasure it. Now, the one more question, which is of a mundane question, when these people also have to take some time thyroid, thyroid. They have to take pantoprazole and also sometime iron preparation. When the concomitant administration of these drugs, what's your message, Nitin?
Absolutely. So with oral semaglutide, we know that the requirement of thyroxine can come down. But when we talk of the order of drug, I would always prefer to give semaglutide first and then wait for half an hour, 45 minutes, and then give thyroxine. Thyroxine, now more recent literature, can also be given very late at bedtime if the supper was earlier. But yes, so I think semaglutide first, followed by thyroxine. Patient would be happy to know that their thyroxine requirement is coming down when we are using semaglutide. So that is
exactly. And also, as you rightly said, antipotal use in the evening also is a great opportunity. Fantastic. Now, I think, Nitin, I must tell you that we in India celebrate today advent of the new drugs. We have always differentiated between the value and the cost. The value these drugs have added, the treating a disease appropriately is cheaper than costly. But still, Nitin, there's a question which has come from the audience, the cost-benefit ratio. What did you say on this point?
Absolutely. So I think the answer is that we have to look at the bigger picture. If we are just looking at the narrow picture of cost of treatment for 1 month and the quantum of weight loss, we may miss the bigger picture of the way we are able to prevent the larger problems. One ICU stay with an MI or a stroke would just drain out lakhs of rupees. Absolutely. And that would be not even half the cost. But having said that, yes, cost is important. These are drugs that need to be taken long term. But sir, if we go back, say 5 or 10 years, when we had Sitagliptin or when we had GLP-1 they were expensive. And now today we have liraglutide for 1,500 rupees per month. So I think it's a matter of time. And I hope that more and more people will be able to use it.
I'm a very strong believer in that. And you also sit in the DCGI meetings today. So these drugs will be available. And I think it's a great answer that this is cost effective, value adding drugs, and the price versus value. Value always wins. And it will be available. Five minutes for the question answer session. I'll be asking me and Bharat a rapid questions. Can I have Nita? Nita being visible. Nita, can I have you, Nita? What is Nita? Nita, yes. Yeah. The presiding queen of anti-obesity research, clinical care in the country. Nita, my first question to you. Nita, can you tell us, management of obesity in diabetes? Is a diabetes obesity meeting. So I just want to know, focused answer, management of obesity in type 2 diabetes.
Yeah. So management of obesity along the general guidelines, of course, has to be followed. But in diabetes, it poses actually some special challenges because it's not easy to lose weight with diabetes because a person could be on sulfonylureas, maybe Pioglitazone, maybe insulin. It's that much to lose weight. However, fortunately, today we do have drugs that can be used, which are either weight neutral, like the DPP-4 inhibitors, metformin to a certain extent. And we also have, of course, the blockbuster drugs like the GLP-1 receptor agonists and also the SGLT2 inhibitors. So it becomes that much easier to lose weight in a diabetic patient in current times. Of course, all the other things that have to be done for an obese patient, like lifestyle modification, all these things have to be done to the best of our abilities. And so pharmacotherapy and lifestyle modification do remain the mainstay, but use weight-friendly drugs is what I would say, and that would help us more.
Good. I think great answer. Now, in spite of that, what has been the acceptance of anti-obesity medication in your practice, both diabetics and non-diabetics? Acceptance of the AOMs.
The acceptance is a little low because anti-obesity medication, when we talk of either liraglutide or mainly liraglutide, it is injectable and people don't want it. Second problem for acceptance is the cost. So whether you're using liraglutide or oral semaglutide, the problem comes about the cost. Maybe if these drugs were a little cheaper, the acceptance would be higher. However, Another problem for the acceptance is the GI side effects. Of course, we have to educate the patient. They wane over a period of time and they may not be as severe in everyone, but yes, that still remains an issue. And lastly, the concept that to use medication for weight loss, it is still not very acceptable to the lay public. So that is the problem.
Thank you. I think I have a very. I'll come back to you, Nita, with the available time. But I have a great question to ask Dr. Sunil Gupta. Sunil, ultimately, is metabolic healthy obesity a myth?
Yes, sir.
This is a rapid fire question. Yes or no?
Yes, sir. Right. I feel it's just a slowly progressing obesity to a morbid obesity.
Fine. Yes. I think, Sunil, for you, I have few rapid fire questions which are centered around women and obesity, because you have been qualifying in the DIPSI and the women's health. Now, first question: what's the specialty of obesity in women? Single line answer.
Yeah, I feel women with obesity are more prone to have infertility, breast cancer, polycystic ovarian disease, irregular ovulation, stress incontinence, dysmenorrhea. This is common in women versus rest other things are common in both the genders, sir.
Is the prevalence higher?
Yes, sir. It's the prevalence in women may not be higher, but rather they have more brown tissue rather than the white, which is seen in men gender, and the visceral obesity is rather less common in women versus the men.
Yeah. What is the impact of obesity on reproduction? Because many people feel the obesity is a hindrance for reproduction in general.
Yes, sir. In general, as the BMI increases, the risk of GDM increases, risk of infertility increases, and the moment you reduce the weight by almost 5%, the risk of there are a lot of benefits towards the infertility, pregnancy, gestational diabetes risk goes down. So there's definite relationship with increasing BMI with pregnancy, sir.
Good. I think I'll come back to Breeze now. Breeze, is adiposopathy a disease? Breeze, are you there? Breeze?
Yes, sir, I am there.
Breeze, tell us, do you think adiposopathy is a disease? Is a rapid fire question. Quick answer. Adiposopathy is a disease?
Sir, it's a new term which is being used now for sick fat. So I think whatever term we use, we know now that increased deposition of fat. In fact, it is not that we know now. It is known for so many years or maybe decades that excess deposition of fat is a disease, and particularly when it gets deposited in the ectopic sites, it leads to multiple issues.
I think great answer. Over the fat, over the pancreas, over the heart, we know that. Now, why is obesity, single sentence answer, why is treatment of obesity so difficult?
So first thing is, sir, people don't recognize obesity as a disease. People think obesity is, we never actually put obesity definition as a disease. We always defined obesity based on weight. So it is more weight or less weight. We never say obesity is, it's a sugar problem, it's a weight problem. And weight is commonly related to your increased food intake or decreased exercise, or generally stigmatized by, people being lazy, not moving enough, eating unnecessarily. So obesity was never recognized as a disease. It was recognized as more of a condition related to weight, not defined by disease parameters. Second thing was we were a starved society. So as the affluence improved, people started relating obesity to affluence.
Correct.
So it was common to tell that somebody is overweight, he is coming from an affluent family.
Correct. But now it is not
still
so.
We have that notion.
Correct.
So once you don't recognize something as a disease, how will you go for treatment of that disease? Even in today's practice, forget about the patient. In clinicians, person comes for URTI, gets treated for URTI without even mentioned about obesity. Person comes for diabetes management, gets managed for diabetes, but obesity is never, told as a parameter for management.
I get you. I think your last two slides told about the bariatric surgery, and depending on the things you said, what is the future of bariatric surgery? Single line answer.
So, sir, as I mentioned in my last slide, every surgery is there till we have the right pill or right capsule. So, surgery's life is limited by the invention of a proper drug, which is able to give you as good effect as surgery. Try to recall the era of, DU perforations. We used to see duodenal perforations commonly in clinical, in our wards, every surgical ward had DU puffs. And from the cemented in introduction till now, you tell me how many DU puffs we see.
Absolutely correct. List does not figure a vagotomy with, it is gone. Thank you very much. I'll come back to Nitin. Nitin, what is the role of meal replacement?
Yes, sir. So I think meal replacement is another strategy that we can use, because the whole concept being we are able to provide very low calories with good protein, maybe about 20 grams protein and 150 calories. But the biggest advantage being that all the micronutrients that the patient requires, the RD of that could be met in, say, about 1/4 of it in a day in a meal replacement. So patient replaces a meal with these pre-packed replacements, gets 150 calories, so loses weight, but no vitamin deficiencies. In the US, when I was there, they used to give all the 4 meals replaced, and they would come back with 20 kgs weight loss. But I think in the Indian setting, partial meal replacements are okay. These are endorsed by all international and Indian guidelines as well.
Do you believe in the formula foods available by the various agencies?
We have to look at it very carefully, sir. Many of them claim very high results, but I think the basic message there would be you have to look at how many calories and how much protein you're giving, because protein is the one which is giving satiety. A basic principle being 150 calories, 20 grams protein should do well.
Yeah. I have 2 important questions which I couldn't ask you because of lack of time. What is the role of psychiatric evaluation in the management of obesity? Very vital to my mind.
So very, very important question. So we in CMC Vellore, we have a multidisciplinary clinic where psychiatry is part of it. And we published that 30% of patients who actually enter the clinic have an underlying psychological problem. The most common being obviously depression and dysthymia. But given that every modality for obesity management can cause depression, I think it is important to find out what they have at baseline, to find out how they are doing after surgery as well. And I think the role is very, very important.
I think I have got last question for you in this round before the last round. Now, after listening to all this, Nitin, when will you recommend a patient for bariatric surgery?
Right, so definitely we start talking about it much earlier. In the case we keep all the cards on the table, the patient should be aware. It has to be in a staggered approach. Start with lifestyle, patient loses some weight, then comes back, says, doctor, I'm not losing any more. Think of medicines, maybe intragastric devices. And the last would be bariatric surgery. The recommendations for India are very clear, 37.5 kilograms per meter square with no comorbidities and 32.5 kilograms per meter square with comorbidities, having ruled out any underlying psychological or terminal illness. And in children, one other additional thing, they should have achieved their SMR staging, at least standard 4, and achieved their height as well.
Yeah. The last question in this round is that, one of the things that is cited against AOM, and let us be neutral, is about the sarcopenia and the taking away the hedonic pleasure of eating. Your comments on that?
Yes, sir. So sarcopenia needs to be addressed when you are managing obesity very well. And that's the important point where it's only not the medicines for weight loss, but the diet, which is good in protein, as well as the resistance exercises that need to be intervened with the treatment. If we are just giving anti-obesity medications, we have data now from recent drugs that muscle loss is also a part, though it's majority fat loss, muscle mass is also lost, which is definitely not good.
Correct. I think last question of what you mentioned is very, very important, is to ask you told about genetic weight reducing drug. What is the cost today of looking at this monogenic obesity genes?
Yes, sir. So we at Vellore are doing all these genes. We have a 35 gene panel for monogenic causes of obesity, which is done for people with young onset severe obesity. And especially if they have history of consanguinity, the cost for this 35 gene panel is 9,000 rupees. we get the report.
Very affordable. I think I want the audience to please register in the mind. It is 9,035 early onset genetic obesity. Thank you, Nitin. I'll come back to you. I hope your OPD is crowded, but 5 minutes more because I have to leave the forum in time for Sambit and Kanwar. They're appearing in the screen telling me time is getting up, but I will not go 1 minute beyond allotted time. Now, I think I want to ask you, Sunil, a very important question. What are the risks with maternal obesity?
So maternal obesity, there is always a risk of having high risk of GDM. Suppose if someone is overweight, then the risk of having GDM is almost the odds ratio is 2.1. When someone is obese, it's 3.9. When someone is morbidly obese, it's 8.6. Moreover, there is also a risk of hypertension. There is risk of macrosomia in these babies during pregnancy. Also preeclampsia, there's risk of miscarriages, stillbirth after 28 weeks, and early neonatal death and large for gestational age babies. So once you have associated obesity during pregnancy, these risks are higher versus the non-obese or a normal weight person.
Yeah, fantastic. I think, Nita, I have a question for you. Somebody has asked that some diabetics with surgery or weight loss do not remit. What do you think about them? Nita?
Well, there are
some people even with surgery and also with weight reducing drugs do not go into remission of diabetes or do not get into good control. What do you think about them?
Yeah. So these are the people possibly who could be long-standing diabetics, very less insulin reserve, then remission is not possible. However, so to a certain extent they would respond. And surgery, there are more chances of responding even in patients who are diabetic.
Thank you. And the last question to you, Nita, is bariatric surgery a solution for all types of obesity and all the problems of obesity? Nita, am I clear? Is bariatric surgery a solution?
Yes.
Yes, Nita?
Yes. Yes, solution. It's not a uniform solution for everybody. For sure, it is a solution for many, but it is not acceptable to all. It can cause a lot of problems that happen with diabetes and say problems, fatty liver, etc. But it is not a Spanish patient. That is what I would.
Thank you, Nita. I'll just go back to Breeze. Breeze, I don't want to give you data preemptive your publication, but what is the mismatch between the calorie and the weight gain?
Sir, very interesting data. Till now, we have most of the studies have shown that weight gain or obesity is associated with increased intake of calories and all macronutrients early in the course of life or during adulthood also. And there is some data to show that there is increased risk of obesity with consumption of increase in the animal protein as compared to plant protein. There are very few studies which have shown that it may be actually an inverse relationship and people who are consuming more protein may be having lesser body mass index. But very surprisingly, we recently did a body composition analysis and parameters, and we also did the nutrition analysis. The diet 1 week dietary recall was put in a nutrition calculator, and we found that it is otherwise. That people who have BMI less than 23 actually are consuming more calories than people who are more than 23 BMI. And I was very surprised that we are still doing some analytics. And I'm also discussing with some of the people, but data seems very interesting. Let us see, how it shapes up.
Thank you. I think we are awaiting for the data, but there must be role of genetics. Nitin, what do you think? Why the role of genetics or role of something else beyond calories alone? Nitin?
I think two things. One is the amount of energy expenditure, the kind of metabolism the patient has, which can be very different. We always have patients who will say, "Doctor, this person eats so many things, and I don't eat anything. मुझे तो पानी भी घी लग जाता है." A common statement in the OPD. And the second thing would be, yes, there are genes. So weight is said to be the most inheritable trait in human mankind. And when we look at monogenic twins to diagetic, and as we go away, weight has the maximum concordance as the genetics becomes closer. So there's genes and there is energy metabolism or expenditure, which is also important in addition to calories.
Now it is 12:28, and I have no words to thank you all. It has been a veritable morning. Nita, I always call her my little sister, the presiding queen over the obesity area in the country. Nita, thank you very much. And I'd like to have your final word in 15 seconds to the audience. Take home for the audience.
Yeah. My take home for the audience is treat obesity as a disease. Use all the modalities that you have at your disposal. There is no one size that fits all. So lifestyle is important at all stages, but do not shun pharmacotherapy or bariatric surgery whenever it is necessary. You need to go to the next level when you think that things are not working. So we cannot be dogmatic. That is my take on it, that it is a multi-pronged approach.
Sunil, I cannot thank you more. You have been the champion of lifestyle. Hello, diabetes. I have no time to describe you, but the take-home message in the next 10, 15 seconds.
So metabolic, even if you are metabolically healthy, but if you have obesity, it's going to be becoming deteriorate. There will be deterioration in subsequent years, and better we start prevention of further metabolic complication, even if you are metabolically healthy today. So we should be addressing the same aggression as we address the unhealthy obesity. Thank you.
Nitin, I cannot describe your involvement in obesity in India and abroad. And I see a great future for you being in CMC and in the national field. Your message for the masses.
The only one message is that to treat obesity like a chronic disease. So losing weight is easy, maintaining is important, follow-up is the key. So like diabetes, obesity needs long-term treatment.
Thank you. And Breach, the president of the Obesity Society, the president of the RSSDI, and lot of work in obesity. Your final take-home for the audience who have joined, Breach.
Sir, the most important, as Nita mentioned, and of course, the conclusion is that we have to recognize obesity as a disease. Unless we recognize obesity as a disease, we are never going to do justice to this. And as Nitin just mentioned, that obesity is a chronic disease and needs to be addressed like a chronic disease. It needs lifelong therapy.
Absolutely. If you take the ISM in-depth data which you quoted, but both the peripheral abdominal obesity together, it's above 53%. So it has to be addressed as it is. Dear friends, all good things have to come to an end. That's what the Bible says. And this will not stop. We're interim for this particular discussion on obesity. Give a big round of applause for the great people who made this session very memorable. Thank you very, very much. Over to Sambit Kanwar to take over the next session. Thanks to Bharat. Bharat has been great. Bharat, it was great having you. We'll come back to a session again. Now, the impact of diabetes on the brain. We are going to the second session. It is exactly 12:30 now. Impact of diabetes on the brain. May I now invite Sambit, Dr. Kanwar, Chandan Das, and Sambit to take over and invite the others. Over to you, Sambit, exactly in time.
Thank you, sir. Thank you again. A very good afternoon, one and all. And it's always been a pleasure to be part of this wonderful conference, NUCD. And I must thank Ashok Das sir and Alok Kanungo sir for giving again me an opportunity. So it was a wonderful session on obesity. So we are now at the session 2, which is also very, very important. And that is the relationship between diabetes and the nervous system. And friends, as you all know,
that single word, allow me a single word. This is the session of the sessions, very new. And we have people who can really contribute. We have Dr. Kanwar, very early DM from Odisha. and we have Chandan Das, we have Dr. Sunil Narayan, and Arundhati will be joining us shortly. And now over to Samit again. Samit, I must tell you that this is one of the most important sessions people have liked, new and very practical. Over to Samit again. Sorry for the interference.
Absolutely, sir. I think we have a galaxy of speaker from head of the Department of Neurology of JIPMER to Dr. Soumya Darshan, who is a neurologist from Odisha, and then we have psychiatrist. Then we have Dr. Kanwar, Dr. Arundhati, Dr. Vaishali Deshmukh is also joining in the panel. So we have a wonderful session lying ahead. So without wasting much time, I'll request Dr. Chandan Das to kindly introduce the first topic and chair the session.
Thank you very much, Samit.
Chandan sir, you are not audible.
Yeah. Am I not audible? Am I audible now?
Yeah, you are audible now.
Now you are fully audible now.
Yeah, thank you very much, the organizers. And the topic, today's topic, I think is something related to cognitive decline, dysfunction, and diabetes. And cognitive decline is a very common thing in long-standing diabetes and the less investigated topic. Actually, nobody talks about nerves and all. And it's increasingly clear that diabetes and obesity are the two important modifiable risk factors for most of the neurodegenerative disorders, especially most commonly the Alzheimer's. We have a lot of data on that. It may be oxidative state, it may be mitochondrial dysfunction, maybe some neuroinflammation. So let's talk about it. And the topic is how does diabetes cause cognitive decline and what can be done? The speaker is Dr. Soumya Darshan Naik. Soumya is a very eminent neurologist from SCB Medical College, Cuttack. I think he is heading the department in SCB. Dr. Soumya will be, he's a MD and DM. He's an associate professor and HOD Department of Neurology in MKCG. Oh, now he has gone to MKCG. I'm sorry, Soumya. He is a assistant professor in neurology in SCB Medical College. And his area of interest is mostly epileptic disorders, movement disorders, and headache. And he has huge list of major achievements. Like, let's not go into that. Let's give some more time to Soumya to talk about cognitive decline in type 2 diabetes.
Dr. Chandan. There is a small change in the sequence actually, because that was suggested by Dr. Kanwar, because the whole session is on cognitive decline. So we have thought to discuss something on peripheral neuropathy and what would be the best therapy for that. And to speak on that, we have Dr. Soumya Darshan Naik. So over to
painful neuropathy.
Yes, sir, painful neuropathy.
Soumya, all is yours.
Thank you, sir. Am I audible?
Yes. And the slides are visible. Make it full screen.
Are the slides visible?
Yes.
Is that okay?
Yes, it's visible.
So thank you, organizers, especially Ashok sir, Alok sir, Kanwar sir, Jayashree ma'am, and Sambit, and kind words from Dr. Chandan Das. Actually, there was last-minute changes, and I was to speak on cognition, but we have an entire session on cognition. So I'll be touching on painful diabetic peripheral neuropathy. So this is also an interesting area and gray area. Most of you must be seeing a lot of cases of painful diabetic peripheral neuropathy. So with more than 100 million people with painful diabetic peripheral neuropathy, and 50% of the diabetics developing painful diabetic peripheral neuropathy over 5 or 10 years, the data for management is not very robust. Let me be very specific. As we all know that diabetic peripheral neuropathy, what we commonly see in our clinics is a symmetric, length-dependent sensory motor polyneuropathy. This is the most common type, that is the DSSN. But we also see cases of distal symmetric sensory motor polyneuropathy apart from the sensory ones. So these two are the most common, and among the DSSN group, the painful neuropathy occupies a major chunk. At least 50% of cases you see in your clinics of diabetic neuropathy belong to the painful sensory neuropathy group. Not breaching more on the pathophysiology, as you all know, it's an axonopathy due to small vessel vasculopathy, and the pain starts after damage to the small fibers, especially the C fibers. But as time progresses, there's a central mechanism which comes into play. So most of us, as already Dr. Chandan has pointed out, that it's the traffic of the energy into the axons which is halted, be it derangement of mitochondrial production, dysfunction, ATP loss, and it's a distal to proximal degeneration, which follows a time-bound phenomenon which leads to the pathophysiology of painful diabetic peripheral neuropathy. Already, we are discussing this, we have discussed obesity, insulin resistance, but a lot of factors play a major role in shaping diabetic neuropathy as it occurs in the patients. We see hyperglycemia as the root cause, but is it the only cause? No. There are other causes, including dyslipidemia, energy overload, bioenergetic failure. All this need to be taken into account when we are harboring on treating a patient with diabetic neuropathy. So basically, we have two groups of symptoms: those which emanate from the large myelinated nerve fibers and the small nerve fibers. Basically, what we see commonly are symptoms from the small nerve fibers, which include some positive phenomenon and some negative phenomenon. The positive ones are the burning, electric shocks, stabbing, hyperalgesia, and allodynia. The negative symptoms are numbness and cold or soreness. If the large fibers are sequentially involved, then we have poor balance, ataxia, and we have defective vibration and pressure sense. So all this, if you have any symptoms relating to these two types of fibers, you can very well do a focused clinical examination. All of you are busy practitioners in your day-to-day practice, so at least spend 2 to 3 minutes for a neurologic examination. 1 minute for the symptoms, 1 to 2 minutes for the examination, clinical diagnosis. Basically, these are some of the catch symptoms which you should ask your patients to report if they have a burning, electric shock-like, tingling sensation, allodynia, numbness, or a cold soreness. So once these patients present to you, your approach should be a stepwise approach, a targeted history. Try to get the detail of the duration of diabetes, the age group of the patient, any metabolic syndrome, and any social determinants. Also ask about the type of pain, what kind of pain, because that is also a catch. If you have a small fiber neuropathy, you may have burning pain or pricking pain in the feet or hands. And if it's a lancinating or shooting pain, you may well be looking at the radicals or the plexus. Whether it's worse at night, and any symptoms of numbness, poor balance, or weakness. A focused clinical examination, which we will touch upon later. But what is the time when you treat a patient and when you refer to a neurologist? If the symptoms and signs are symmetric, length dependent, glove and stocking pattern, it's a simple distal symmetric sensory or sensory motor neuropathy, very well you treat the patient. But if there are red flags like asymmetry, predominant motor involvement, and if the symptoms are progressing at a fulminant pace, then do refer to a neurologist. One of the important points which we occasionally miss while diagnosing diabetics with peripheral neuropathy is the differentials. If we don't consider other disorders, and even in a diabetic, we may have other diseases which increase the coexistent neuropathy or which require treatment prior to treatment of the diabetic neuropathy. So these are some metabolic diseases, infections, nutritional deficiency. Many studies have shown B12 deficiency and thiamine to be the causes of non-response to drugs or resistance to drugs. CIDP is a great masquerader. Also inquire about drugs, especially alcohol, chemotherapy, and heavy metals, apart from genetic disorders. There are a lot of assessment scales, but I won't go into the details of assessment scales. Most commonly used is the Michigan, and in India, we used a revised neuropathy disability scale. But for general practitioners in a busy clinic, you can rely on the VAS and the NPRS. These are simple pain scales where you ask the patient about the subjective pain, starting from mild, moderate to severe. 1 to 3 is mild, 4 to 6 is moderate, and 7 to 10 is severe. So this is just a screening rating about the severity of pain. Apart from that, you can spend 1 minute in doing a sensory neuropathy examination, especially for small fibers. You use a monofilament or a pin, and you can use a 128 Hertz tuning fork for the large fibers. There are a lot of tests, but just need to highlight that if you are suspecting a neuropathy, and you see that the patient is not amenable to treatment, do refer to a neurologist, get a nerve conduction study done. Nerve conduction gives first-hand information about the status of the motor, sensory, but what it misses are the small fibers and the autonomic nerves. So if you want a detailed examination, you can do a sympathetic skin response, QS-ART. So these are simple things which can be done in the neuro clinics. And if you are referring to an ophthalmologist, do get a corneal confocal microscopy, which has a very high sensitivity in the tune of 85 to 86% in most studies. Apart from that, newer techniques like magnetic resonance neurography and nerve ultrasound and the intraepidermal nerve fiber density estimation are newer modalities for diagnosing these small fiber neuropathies. The goal has to be individualized, especially when you see that there are variations in the various guidelines provided. But all these guidelines had one goal common, that was reduction in pain to the tune of 30 to 50%. That would lead to improvement in daily functioning. There are other questionnaires which ask for quality of life, sleep, and mood. So a 30 to 50% reduction is the initial goal. Do not be over-aggressive and treat till the patient has nil pain. It is very, very difficult to achieve.
Dr. Soumya, we have another 5 minutes left actually.
Okay, we'll go straight into, risk factor reduction. I won't go into the details, but that is important as much as lifestyle modification and non-pharmacologic treatment can be used, especially in resistant cases, including TENS, FREMS, and the spinal cord stimulation. What we will discuss is what the guidelines have to say regarding management of painful neuropathy. So most guidelines have a consensus regarding the tricyclic antidepressants, gabapentinoids, and the SNRIs. But of late, AN is the only guideline which has given first-line recommendation to newer antiepileptics like oxcarbazepine, lamotrigine, lacosamide, and even valproate. Again, the dual mechanisms, opioids, tramadol, propentadol, are recommended as third-line medications for diabetic painful neuropathy. Tricyclics, SNRIs, gabapentinoids are always first line in the treatment. So this is a simple algorithm where you have all the neuropathies, but if you see that the painful neuropathy, you have to have gabapentinoids, anxiolytics, including tricyclics, SNRIs, and if they don't respond, go to the third line or second line treatment. So in a nutshell, these are the first line which we all use: pregabalin, gabapentin, amitriptyline, nortriptyline, and duloxetine. Among the SNRIs, which are second line, are Velna and Desvelna, Tramat, propentadol, and the patches. Third line are the newer group of drugs. So basically, we start with a monotherapy, especially it's either pregabalin or gabapentin. And if the response is not adequate, we add a tricyclic or an SNRI. We'll go to the combination therapy in the next slide. And if the patient has partial effect, now you have to give adequate time for titration, at least 2 to 4 weeks, and you have to look if there is inadequate pain control. This is the time you switch to alternative or go for a combination therapy. So basically, there are 2 studies which I want to highlight. One is the study which was done by the group of the Danish group. And especially this study was the combo TM study, where the maximum monotherapy versus the standard dose combination were found to be equally effective. The next study is an option DM study, which was validated for combination therapy in where monotherapy was suboptimal. Now, you can add 2 to 3 agents, but in real world, we see that there is not much difference if you add pregabalin with a nortriptyline and a methylcobalamin versus a gabapentinoid drug. This was published from the Indian data in December 2023, where they found that pregabalin is slightly more effective But safety-wise, both pregabalin and gabapentin have similar side effect profile. How long do you treat? You need at least 4 to 6 weeks for titration, and the maximum duration of a drug can be from 4 to 6 months. In cases where there is refractory painful neuropathy, you refer to pain specialists, and these are the recommendations: lidocaine, botulinum toxin, spinal cord stimulation, and some newer drugs like sibinetide and tanezumab. So this is the IASP's specific pain group, special group, which has the first, second, and third line recommendations. I won't go into the details of the antidepressants, but duloxetine versus nortriptyline, if you see that you have to weigh the side effect profile, and duloxetine has a better side effect profile compared to nortriptyline. That is the reason for combination, newer combinations with pregabalin. Head-to-head, pregabalin versus gabapentin. Pregabalin is the FDA-approved drug, and it has better efficacy. But side effect profile, gabapentin is the better drug. But the need to titration, you can titrate pregabalin very early, while gabapentin is erratic in titration. But given the side effects, edema is lesser with gabapentin, there is lesser sedation, and also the addiction to gabapentin is lower. Opioids have limited efficacy, so the newer kids on the block are cannabinoids, lamotrigine, topiramate, zonisamide, and lacosamide. These are the new anti-epileptics, but they don't have an FDA recommendation. We need to see how they come up in the future, but we can use them for resistant cases. So summarizing, it is a very common symptom and the patient requires pain relief. Treatment has to be individualized. You have to be very cautious, especially if patient has comorbidities, it's an elderly, or a patient has renal impairment, especially when, or cardiac impairment, especially when you are using tricyclics, or even you are using pregabalin or gabapentin in renal patients. Important that you go for a start with a single drug, preferably pregabalin or gabapentin, add on combination if you have a suboptimal response. Third line drugs are required if the patient is not responding, but it is better you refer to a pain specialist. Neurologist help comes when you have atypical symptoms or signs. And in cases where there are radicular pain or cauda equina involved, then you can use combinations.
Dr.
And
Soumya, it's time.
neurogabalin
Please
is
wrap
the
up in 1 minute.
Yeah. Yes, sir. It's over from my side. Nutraceuticals do have a role. And summarizing, you not only have drugs which are the mainstay for symptomatic treatment, you have to have a combination when there is suboptimal response. Non-pharmacologic behavior has to be taken and risk factors have to be ameliorated. So thank you all for your patient hearing. I end my talk now.
Wonderful presentation, Dr. Soumya, and that was really a very interesting and important topic because day in and day out, we diabetologists, endocrinologists, and physicians deal with this painful diabetic neuropathy. So I think we'll have some discussion during the panel discussion. So we'll straight go to the next session. That is still very interesting, and that's a friendly debate between two of my very close friends. One is Dr. J.B. Kanwar, who is professor and head Department of Endocrinology at IMS in some hospital. He has various publications in different journals, and he's a reviewer of different journals also. And he was founder secretary of Odisha Endocrine Society, and he was co-organizing secretary of FESICON 2018 also. The next is Dr. Arundhati Dasgupta. She's a DM endocrinology and director and consultant endocrinologist at Rudraksha's Super Speciality Care at Siliguri. She's the recipient of A.V. Gandhi Award of 2012, and she does various awareness initiatives in Bengal and has done more than 130 awareness programs, author of many publications, and contributed to several book chapters also. So we'll have a very interesting debate, that is, can good glycemic control prevent brain damage? And for the motion will be by Dr. J.B. Kanwar, and against the motion is by Dr. Arundhati. They have actually recorded the program so that we'll have 1 minute rebuttal from each side after the debate is over. So over to the RX events.
A very good afternoon to all of you. Today the debate is, can good glycemic control prevent brain damage? I will speak against the motion. So first should be the, I think first should be the Arundhati who would speak for the side. You can see Sunil Gavaskar on right hand side. Greatest batsman. Samvit, see, you can see the differences from present.
I think you'll have to present my talk first, my debate, because I'm for the motion and Dr.
Yeah, Arundhati. Hi, Arundhati. So, Alex, event kindly present Dr. Arundhati's talk first, because she will be for the motion.
The debate has already started. Which first?
Debate has already started. Rightly interrupted.
Here we concur. Here we agree.
Which one first? It has started.
For the motion, Dr. Arundhati would be speaking for the motion.
Yeah.
Start Arundhati's presentation, Stuti.
So, good afternoon. I think this is our recording being done for the debate. And my topic that has been assigned is, can good glycemic control prevent brain damage? And I'll be speaking for the motion. So when we talk about the glycemic control and brain damage, there are three questions that need to be answered. Number one, what is the connection between glucose levels in the blood and the brain? Number two, what is the connection between poor glycemic status and the brain? And number three, if there is a connection and it is an inadvertent connection, then does correction of the glycemic status prevent brain damage? So these are the three questions that we need to answer before, talking about does good glycemic control prevent brain damage. The 12th of January, that is yesterday, was celebrated as the birthday of a great philosopher, Swami Vivekananda, and he has told us that the greatest truths are those which are the simplest things in the world. And talking about one of the simplest things in our body, the glucose level and the brain connection. So we know that the human brain represents only 2% of the body weight, but it utilizes almost 1/5 of the total body glucose. I think I can just tell you this sentence and that will be enough to tell us about how important glucose is to the brain. And when we talk about that, when we look at how important it is, not only in terms of the primary source of energy, which it is, definitely it is, because it's taking away that amount of blood glucose and utilizing it for that bit of the body weight composition. But apart from the source of energy, it is also a source, it is also very important in terms of certain regulatory functions. Like, for example, it acts as a substrate for the precursors of neurotransmitters, maintenance of the ionic concentration gradient across. So thereby, it is inevitable that something which is taken up in that amount, which is so important, any kind of dysregulation in the metabolism of that particular molecule will lead to disruption in the functioning of the brain. And thereby, we do see a lot of dysregulation in the brain functions, cognitive impairment, and loss of critical brain functions with the alteration of blood glucose levels. Just to understand, that the glucose is just not merely taken up and, just utilized for energy. You can see these are the various areas where it is acting, specialized centers in the brain, the POMC, the AGARP neurons in the hypothalamus, that is A. B, which is telling us about the neurovascular coupling as the glucose is supplied to the brain, which is metabolism dependent. C, which is telling us about the other metabolites along with glucose being rapidly distributed through a highly coupled metabolic network. D, which is telling us about the how it acts as a source of energy for the neurotransmission. And lastly, when we're talking about the other glucose metabolism enzymes, which are important in terms of controlling cellular survival. What is the connection between hyperglycemia and the brain? Swami Vivekananda has told us that anything that makes you weak physically, intellectually, and spiritually has to be rejected as poison. Hyperglycemia is one of that for the brain. Look at this study, which has told us about how the central nervous system is a conductor which is orchestrating all the metabolic regulations by both hyperglycemia and hypoglycemia. In short, poor glycemic control. When we're talking about brain disruption, we're talking about stroke, number one. Number two, we're also talking about the cognitive dysfunctions and even dementia that can result from alteration in the glycemic status. This is a picture telling us about the functional disabilities that occur when hypo and hyper metabolism of glycemic levels occur at the peripheral level. This is what occurs centrally in the brain. We have seen several studies telling us about, this is one study. Why I have projected this is because we did see that the glucose crosses through the blood-brain barrier. Now, what has been seen in acute as well as chronic hyperglycemia is an alteration in the local cerebral glucose utilization. And what that results in is something we will discuss subsequently. So this capacity to transport glucose is altered during chronic hyperglycemia, and that leads to several disruptions, downstream. This is again telling us about the association between long-term hyperglycemia and insulin resistance with brain atrophy and cognitive decline. We will go ahead and these are other studies telling us about the risks of cognitive impairment and dementia. This is 144 prospective studies. We do know this today for sure that diabetes is related to various kinds of dementia, vascular dementia, as well as Alzheimer's disease. This is again a study which is telling us about the association between late life diabetes status and hyperglycemia with cognitive impairment. This is the Mexican Health and Aging study telling us likewise about the association between HbA1c of more than 8 and worse cognitive performance. The sex-specific association also looked into this and found definite the role of hyper and hypoglycemia in the trend towards Alzheimer's disease and vascular dementia. When we look at pictures from type 1 diabetes, also assessment in terms of the dementia scale, the MMSE, the dementia assessment sheet, all of them faring worse in case of poor glycemic control. If we look at the spatial patterns of the structural brain changes in type 2 diabetes, we do see alteration in the gray matter volumes and better control translating into a lesser loss of gray matter volume, again telling us about the importance of maintaining good glycemic control to prevent these damages across. This is a study telling us about the association of pre-stroke glycemic control with the vascular events during a 1-year follow-up, again emphasizing the detrimental role of hyperglycemia in terms of stroke outcome. Similar study, this is a meta-analysis again telling us about the relationship between the altered glycated hemoglobin, higher glycated hemoglobin resulting in a worser stroke risk. And post-stroke recovery also, it has been seen that glycemic control, this is a meta-analysis of 29 studies, and it did say that of these 22 studies told us that diabetes had a negative effect on the recovery of a person after stroke. Persistent post-stroke hyperglycemia, independent association with the infarct expansion and worse clinical outcome. This is again similar study telling us about the treatment of hyperglycemia having beneficial results in terms of ischemic stroke. This is a randomized pilot trial. If you look at the potential mechanisms, there are various pathways which can explain this association, across the inflammatory pathways, the PKC, the AGE, the ENOS, the TGF. Cannot go into the details, just showing you the pictures which show the association across the various pathways between diabetes, hyperglycemia, and diabetic dementia, about the relation with autophagy, the relation with cognitive impairment, about the alteration in the blood-brain barrier that we were talking about, which compromises the blood-brain barrier leading to memory loss in both type 1 and type 2 diabetes. Again, disruption of blood-brain barrier producing various protein secretion on the cellular microvesicles, again leading to worse cognitive impairment. This is a study which looked at the white matter hyperintensity progression. This is the accordion mind study, again showing us the very, very strong role of hyperglycemia in terms of the changes in the white matter as well. These are the associations with the diabetic stroke and the Alzheimer's disease. Unfortunately, I cannot go into the details of all this, but so many studies, thousands of studies have been done which have told us about the very important role of glycemic status on the brain functioning in terms of vascular functioning, in terms of the cognitive and memory and other spatial functionings as well. Does good glycemic control have its benefits? Now, very importantly, as Swami Vivekananda has told us, that words may lie, but actions will always speak the truth. These are some of the studies that have shown us the reversibility of brain glucose kinetics in type 2 diabetes. This is the cerebral glucose transport capacity that is altered. This is the meta-analysis of 16,000 patients telling us about that intensive glucose control can slow cognitive decline. This is again a study telling us about better inpatient diabetic control, giving us better results in terms of cognitive impairment. This is a systemic review, 13 studies telling us in terms of all these benefits. You can see the benefit favoring the glycemic control. These are also other studies showing us about how glycemic control had a significant effect on cognitive impairment. All the other parameters of cognitive impairment also led to definite shift towards the right, which is favoring glycemic control, intensive glycemic control. These are the pictures from type 1 diabetes, again, effect of glycemic control on cognitive function. These are the intellectual quotient, verbal intellectual quotient, memory, attention. We're looking at the digit symbol substitution, all cognitive functions, definitely all of them telling us that good glycemic control do give good results in type 1 and type 2 diabetic patients, both. This is talking about the improved, better working memory in patients with type 2 diabetes. This is the last study that I'm going to quote, a study which looked at the closed loop insulin delivery system and tried to look at the neurodevelopmental and cognitive outcome in type 1 diabetes. These are the differences seen in the cortical gray matter, white brain gray matter resolution, the group differences in brain structure over time, and the indexes, the perceptual reasoning index, the verbal comprehension index, and the full scale IQ. All in all, telling us that those who are better controlled had definite benefit in terms of neurotypical development during the adolescence. The hybrid closed loop telling us better, giving us better results with the reasoning index, with better glycemic control, of course, and telling us that the alterations in the developing brain in type 1 diabetes might be preventable or reversible with rigorous glucose control. This is a very important statement, so that we at least we definitely agree that there is a strong connection between blood glucose levels and brain functioning, strong connection between poor glycemic status and brain dysfunction, and correction of glycemic status. As I have shown in some of the studies, we can go on and on about the number of studies that have done and shown results to the benefit, so that improvement in glycemic status does prevent brain damage. And lastly, as Swami Vivekananda has said, speaking today on the 12th, that tell the truth boldly, and so be it said, that good glycemic control can and definitely does prevent brain damage. I rest my case here.
So thank you. That was a wonderful talk. So we'll play the next thing by Dr. J.B. Kanwar. So over to RX Events, and then we'll have 1 minute of rebuttal from each side.
A very good afternoon to all of you. Today the debate is, can good glycemic control prevent brain damage? I will speak against the motion. And to start with, you can all recognize two greatest batsmen you have seen in your life. On left-hand side, you can see Sunil Gavaskar. On right-hand side, this is Vivian Richards, two greatest batsmen. And just to see, you can see the differences from present time batsmen, that they are not wearing helmet. And they used to say that you use your mind to protect your brain instead of helmet. But my opponent, she uses the helmet of hyperglycemia to protect the brain. So I do accept what Dr. Nuti said. I do accept that in diabetes, there is higher risk of dementia, particularly vascular and Alzheimer's etiology of about 2 to 3 times higher in diabetes population. But the question is today, the debate is about whether the normal blood sugar can protect. We do understand that hyperglycemia can cause cognitive decline. So if there is increased blood sugar, that is whether that is related to cognitive decline, then if you achieve the normal blood sugar, that would reduce or prevent cognitive decline. So today's question is, does normal blood sugar level can prevent or at least reduce the cognitive decline? So we are not debating that hyperglycemia causing cognitive decline, dementia, Alzheimer's disease. I am not against that. I am saying even if you achieve the normal blood sugar, you are not going to prevent that or reduce cognitive decline. The data comes from the Accord Mind study. Dr. Arundhati has already spoken about that. This is a study of the Accord. As you know, there were 10,000 patients who are in the Accord study, and the aim of this Accord Mind study to whether the restoration of normal blood sugar level in type 2 diabetes can influence the cognitive performance. There were about 3,000 odd patients in Acute study, in about 1,400 in each arm. And they looked this patient at 20 month and 40 month for digital substitution tests, which are has already spoken about this importance of this score. And the result of this study is there is no significant improvement at 40 month in either of the groups. There is no improvement in the cognitive if you intensively treat or you have a standard mode of treatment. So that's to give the idea that the intensive blood sugar control is not protective. So could this be because of the intensive control? It could not have the primary outcome of decreasing cognitive decline. So could this be because of the hypoglycemia? However, in Acute study, those patients who had a history of severe hypoglycemia, they are excluded from this study. So the take-home message from Acute study is that intensive blood glucose lowering should not be undertaken to delay cognitive impairment in elderly patients with long-standing type 2 diabetes. So even if you achieve normal blood sugar, that should not be done to delay the cognitive decline in type 2 diabetes. One of the factors which is related to cognitive decline, whether this is increased blood sugar level or insulin resistance. To find out the answer, this was the study, this is a prospective study from two studies, Prosper study and Rotterdam study. They looked into the in the non-diabetic population. If you in the different quantiles of the fasting blood sugar level, you can see in X-ray in X-axis different quantiles of fasting blood sugar level and different parameters of cognitive decline. They looked at it. They didn't find, even after the follow-up of 5 years, there is no significant improvement in cognitive function. Whatever the fasting blood sugar level, may be higher, may be lower, there is no improvement in the cognitive from this Prosper and Rotterdam study. The conclusion for this Prosper and Rotterdam study is that elevated fasting blood sugar level and insulin resistance has not associated with worse cognitive function in older people without history of diabetes. And they also compared to diabetes, there is no significant difference. And we also know from the Obesity and Addict trial, from the type 1 diabetes patient, if you look at this X-ray, the panel on the right-hand panel, you can see they looked into the 8 domain. In type 1 diabetes, the follow-up type 1 diabetes patient in Addict study, there was no significant change even after the 18 years follow-up type 1 diabetes. There is no change in the whatever the HbA1c level. You can see HbA1c level less than 7.4% or HbA1c 7.4 to 8% or more than 8%. In any of the domain, there was no significant change even after 18 years of follow-up of these type 1 diabetes patients. Neither frequency of severe hypoglycemia nor previous treatment group associated decline in any cognitive domain. That was the result of Obesity and Addict follow-up study. And if you look at the increased risk of stroke, as Dr. Andati was saying, that hypoglycemia causes increased risk of stroke. This is a study which looked into the HbA1c and increased risk of stroke. They looked about 70,000 or type 2 diabetes patient, and when they looked into the incidence of stroke, they found out that the U-shaped relationship between the HbA1c and stroke level. If there is HbA1c is low or HbA1c is high, there is high risk of incident stroke. That means even if you have normal blood sugar level, there is increased risk of stroke in patient with type 2 diabetes. UKPDS study, HbA1c well controlled. You can see on the first panel, you got myocardial infarction, newly diagnosed angina. These are all decreased with the lowering the HbA1c level. But on the right-hand side, you can see the fatal, non-fatal stroke, whether the HbA1c is less than 6.3 or 6.3 to 7.6 or more than 7.6, the hazard ratio remains 1. There is no significant improvement even if you achieve the target HbA1c of less than 6.3. And looking at that, European Stroke Organization, they also recommend that we should not achieve the normal tight glycemic control to improve functional outcome in ischemic stroke as well as hemorrhagic stroke. But the quality of evidence may be low, but the guideline says that you should not have a normal blood sugar to reduce the risk of stroke, both ischemic and stroke. Now, what could protect the neuroprotection? If it is not glucose, then what can protect the glucose? You can see from this picture of the famous strike by Mr. Arvind Kejriwal, which is for 14-day fasting, and the fasting was broken by Anupam Kher, and they And in spite of 14 days of fasting, didn't have any problem. It's because we know that ketones are the alternative source of energy during nutrient deprivation, and the role of ketone body is reviewed in several anti-inflammatory cellular pathways, improving glucose metabolism, insulin actions, and synaptic classes are all been known. Just to end my statement that this is by Albert Cornus in 1842, he says, nobody realized that some people expend tremendous energy merely to be normal, merely to keep everything normal or normal blood sugar level. And all the answer comes from the Bhagavad Gita. Bhagavad Gita also says, Sri Krishna says to Arjuna that Asangyatatmata yoga dusprapya yati me mati Vasyatmana tu yatata sukyo bhaptu mupayata. That means Sri Krishna is saying to Arjuna, you control your mind with meditation to protect your breath. Thank you.
So that was a wonderful debate, actually. So Arundhati has nicely told about how glycemic control is important for cognitive decline, and hyperglycemia and hypoglycemia are important. But you also highlighted very nicely, Conrad sir, that by reducing the blood glucose, probably that effect was not achieved, which was supposed to happen. So finally, 1 minute rebuttal from Arundhati, and then 1 minute by Dr. Kanwar, and then we'll wrap up first.
And it should not be Swami Vivekananda versus Lord Krishna.
Yes, certainly not. So I'll just mention 3-4 points. Firstly, talking about where you started off from, helmets. Just to remind you that 25% of the accidents and deaths in our country occur in people who do not wear helmets while riding the bike across normal roads. And here we are talking about riding the bike of life across a topsy-turvy road. So when you have the helmet, you wear the helmet, definitely. You would not want to go without protection. Number one. Number two, regarding the studies that you have quoted, you yourself have said that it is a U-shaped curve. I'm talking about good glycemic control. And good glycemic control does not mean hypoglycemia. It means good glycemic control within target range. So indeed, the results were seen in a U pattern. We do not want hypo, we do not want hyper. We want it within the range where you yourself showed that, yes, it does give good results. The third study that you said talked about people with fasting glucose in people who did not have diabetes. Well, let them go ahead and do whatever they like. People who do not have diabetes need not control their glycemic levels. I'm only concerned about people who have diabetes in this debate right now. And the last point, whether the ketones did anything to the brain of Arvind Kejriwal, well, I'll leave it up to you to decide. Whether it did a permanent benefit or a permanent damage, let anybody in this hall, in this room decide. I'll leave that open for you.
I to answer that, I need to use a helmet.
So you agree that you need to wear the
yeah,
helmet.
but you cannot.
I think he has agreed.
You cannot win a debate against a lady, of course. But as you mentioned that U-shaped stroke, that the study was done, that the primary prevention or primary benefit come from the HbA1c from 7.5 to 8%. So it's not normal blood sugar. So if it is getting normal, there is increased risk of stroke. That's also being accepted by the European Society of Stroke, which says that increases, you should not have a tight glucose control. And we do understand that hyperglycemia causes all my macrovascular complications, but we do not have much data actually in as far as myocardial infarction or stroke are concerned about the good glycemic control can prevent or reduce those things. So few of the data Dr. Arundhati shows about the type 1 diabetes reducing and what is the best data, the EDIC trial over 1,500 type 1 diabetes where they are followed for 18 years. They didn't obviously found out any improvement in cognitive decline. So definitely I would say that you should always avoid hyperglycemia, but having normal hyperglycemia do not expect to have some effect on the cognition or a good effect on the stroke.
So thank you.
Sambit, you have to summarize because before the debate started, we are confused. Now we are confused at a higher level. So, so you give us some sort of a message.
Yes, sir. I think it's very true that both hyperglycemia and hypoglycemia can lead to cognitive decline. And I also agree to the fact and the data shown by Dr. Kanwar that a good glycemic control may not translate into that effect. So I just remember one theory which applies to every aspects of diabetes is the individualization. So individualized glycemic control is going to help both in elderly and also in all spectrum of age.
Congrats to both beautifully done.
Absolutely.
Please stay back for the question answer. Thank you, Arundhati. Thank you, J.B. Kanwar. Thank you.
So they're there in the panel discussion. So now we'll just quickly run to a very interesting interview by, I've done the interview, I have interviewed Dr. Sunil Narayan sir, who is an esteemed neurologist, and he's actually the professor and head of neurology at JIPMER, and he's MD-DM PhD, very nice gentleman, and within 20 minutes of our discussion, it was really eye-opener for all of us. So without wasting much time, I'll ask RX7 to play the interview. So a very good afternoon, one and all. And at the outset, I must thank the organizer of National Update of Clinical Diabetes, especially Dr. Alok Kanango sir and Dr. Ashok Das sir for giving this opportunity. And today the symposium theme is brain and diabetes. And we all know that the brain has so many links with diabetes, starting from the ominous octet what DeFronzo has told. Out of the 8 factors, one is the biochemical or the neurological abnormalities is one of the component. Plus, we also know that diabetes per se can lead to various oxidative stress. The insulin resistance can lead to a lot of inflammation, and that can affect the neurological symptom. Apart from the typical diabetic neuropathy, which we always read. So to discuss on that, we have the next 15 minutes where we'll have a candid talk with a very famous personality in the field of neurology. And it is my utmost privilege to introduce Dr. Sunil Narayan sir, who is a doyen in neurology, and he's MD-DM and is currently professor and head of neurology and the stroke program of the prestigious JIPMER Pondicherry. He's also the chairman of the stroke subsection of Indian Academy of Neurology, and he has got many awards to his credit, and you can see in his slides in due course of time. So without wasting much time, I'll just start the candid discussion, and it would be without slides. So we'll just have a discussion actually how diabetes has got its effect on neurocognitive disorders. So sir, a very good afternoon. And the first thing which I wanted to ask is that how does diabetes cause different cognitive decline? So what's your opinion on that?
Yeah. See, the disease diabetes really undercuts the very source of all our energy source of all our activities. That is, human beings are primarily dependent upon the glucose molecules and, of course, the ATP and other molecules which directly provide that final energy source. But if there is a condition such as diabetes, which undercuts the very metabolism of carbohydrates, especially the way the glucose regulation happens in the body, definitely and directly interferes with the energy supply. And of all the various organs in the human body, the organ which consumes maximum amount of glucose, oxygen, or even blood flow is human brain. If you take the blood flow or oxygen consumption per weight, it is the organ. And this is understandable because it is the brain is the human brain is the most evolved of any machinery in the entire universe, to at least to our knowledge. So all working system needs energy, and a disease like diabetes, which interferes with this energy production and its regulation, invariably interferes the functioning of the brain and neurons. And just like any other system, it affects directly when there is low sugar like hypoglycemia, or very high sugar like hyperglycemia, and also because of the chronic effects of dysregulated glucose pathways, dysregulated citric acid cycle pathways, mitochondrial energy, bioenergetic mechanisms. All these mechanisms are disrupted, especially the long-standing diabetes, and just like any other system, brain is also affected, not only secondarily through other pathways, but also primarily. We will go into that as we discuss how exactly this happens. We can't hear you.
Yes, sir. Yes, sir. Yes, sir. Sorry for that. So, in that context, actually, as you have rightly told, that brain requires glucose for its functioning, and we know that glucose is an important fuel for brain. So, what are the types of or the incidence of neurodegenerative diseases that affect diabetes? So, what are the spectrum of neurodegenerative diseases?
I think if you look at the commonest kind of neurodegenerative disease which is affected or by diabetes, it would probably come down to the vascular dementias, just because the vascular diseases are extremely common, and though hypertension itself is also a very important cause of small vessel disease and even large vessel disease through atherosclerosis and other mechanisms. The role of diabetes in producing vascular diseases, especially the lacunar strokes, the various white matter degenerations, which happens, which slows down the entire cognitive process. But if you look at by the sheer amount, this will be the commonest condition. But even the next common cause of dementia, probably if you look at the world over, is what we generally call it as Alzheimer's disease, a condition which probably has got very important genetic underpinnings, because there are genetic mechanisms which predispose the person to develop what is called the deposits of beta amyloid and tau proteins, and the more microscopically visible structures like neurofibrillary tangles, which interfere with the neuron-to-neuron communications, the neurotransmitter production, and also the new sprouting of dendrites from the neuronal cells, and even the energy supply of the neurons through the supportive glia. All these are interfered with in a long-standing diabetes, which we call the condition called as type 3 diabetes. And this kind of a diabetic status first leads to the production of amylins, which is closely linked to the beta amyloid we see in Alzheimer's disease. So there is a direct relationship between the long-standing diabetes and the predisposition of and the development of Alzheimer's disease in somebody who is already predisposed to develop Alzheimer's dementia. So there is an acceleration process. We all now know that Alzheimer's disease is multifactorial. Just like our ancient saints in India and our ancient Ayurveda physicians told, the prakriti of a person determines what kind of disease they develop. So there is a genetic predisposition nowadays to every cause, every disease, and the risk factors and the acute precipitating causes are all can modify these basic genetic predisposition to diseases, and amyloidosis is the Alzheimer's disease is no exception. And here, diabetes is one of the most important risk factor and a predisposing condition to develop Alzheimer's disease in someone who is already having a latent Alzheimer's disease or is genetically prone to develop Alzheimer's disease.
Right, sir. I think that's a very good concept you have told, and you have also rightly mentioned that there is an entity which is known as the type 3 diabetes, and we call Alzheimer's as type 3 diabetes because diabetes is one of the most important predisposing factor and also a risk factor for this kind of neurodegenerative disease like Alzheimer's disease. So coming to another question which always comes to an endocrinologist's mind and also a diabetologist's mind is that what is the role of insulin and insulin resistance? So there are concept of insulin inside the brain and insulin resistance in the brain. So how does it affect the neurocognitive functions?
Yeah, it's very interesting that after so many years of our knowledge and our familiarity with this molecule ever since the time of that Nobel-winning discovery of this molecule, the total knowledge about insulin even today remains enigmatic. See, the people think that if we control diabetes very well, including some of the latest mechanism of treatment by intranasal insulin, etc., you could somehow slow down the development of Alzheimer's disease, especially in murine experiments. But at the same time, there is also a very strong school of thought. Insulin and pro-insulin can also could even be a kind of a culprit where simply by increasing the insulin, it does not always help the process. It could even harm and can even lead to the progress of many of these degenerative diseases and metabolic syndromes. So even though huge amount of research is going on, this is still a gold mine. We are yet to know whether how we can use insulin molecule in the best possible way, in the best controlled way in any given scenario to not only to control diabetes, but also to prevent and manage in someone who has already developed dementia, including Alzheimer's and multivascular dementias, leave alone the other causes of dementia. For example, diabetic renal failure can produce uremic encephalopathy and chronic dialysis, dementia, etc. So there are a huge number of ways we can control. And is insulin always a savior? Well, we now know that's not the case. We do know that insulin is double-edged weapon, and we have to come out with a finer or more refined forms of this molecule, which can do more help than harm. So that is where the research stands now, as far as I have understood it. It's a very challenging area even now.
Absolutely, sir. So this is a very controversial and topic, but it's challenging to see whether insulin is going to help or it's going to do more harm. And insulin resistance is the predominant factor in this kind of neurodegenerative disorders. Sir, we all know that a good glycemic control actually benefits the reduction of the microvascular complications like retinopathy, nephropathy, and neuropathy, and to some extent macrovascular complications also. But what's your opinion about whether a good glycemic control can actually lead to a better cognitive outcomes or a better outcome in this neurodegenerative disorder? So what's your opinion, sir?
And there is absolutely no doubt in the fact that an excellent long-term glycemic control and also prevention of any kind of excesses like hypoglycemic and hyperglycemic episodes, these can definitely, unequivocally reduce the any ongoing damage to the microvascular system, to the large vessel health, and also to the direct brain cell injuries. So there is no doubt that good glycemic control is always help, irrespective of the role of pro-insulin and insulin on the condition. Glycemic control is of paramount importance. So there is no two questions on that actually.
Right.
Maybe we need other molecule. We have now a huge armamentarium of drugs available to us. That's a great boon, and people are working on it. And I'm sure that the human mind, when challenged, it has no limits. So I'm sure that we will be able to come up with better and better molecules which could provide the best glycemic control as well as the best techniques to decelerate atherosclerosis and lipohydrosis and other vascular damaging mechanism, and also to provide the best bioenergetic at the mitochondrial and at the cellular level, making the transmitter production, the synaptic activities, as well as the new neuronal and dendritic sprouting, and all these mechanisms which helps the brain health maintain as good as possible. So we need to continue to encourage development of better and better molecule with lesser and lesser side effects. Maybe we may have to take a step back from the insulin and look for even more exciting newer molecules.
Thank you, sir. So I think we have another 1 or 2 minutes left, and I don't want to lose the opportunity to ask another very common question actually. So you have told about good glycemic control can actually reduce the neurodegenerative disorder. So as a neurologist, I just wanted to ask or inquire, like, what are the other ways of preventing and treating this neurodegenerative diseases in patients with diabetes? So anything to suggest in the final comments?
Alzheimer's disease, sometimes we call it as you said, the type 3 diabetes, is not the only neurodegenerative disease which is related to diabetes mellitus. In fact, even though there are controversies and people do think that sometimes there is a protective role of the diabetes in ALS. The data by and large suggests that if an ALS person also has diabetes, the chance of his deterioration is worse, because muscle weakness also ensues in diabetes due to other causes. And the same way, conditions like Parkinsonism, where there is autonomic dysfunction in the later stages, again is worsened by diabetes, diabetic neuropathy. And we have even other diseases like Huntington's disease. All these neurodegenerative diseases, the basic problem is the neuronal deaths at the specific areas of the brain and the transmitter deficiencies, and any condition which interferes with the brain's energy metabolism can affect these neurodegenerative diseases in an adverse manner. What else can we do? If you ask that, basically making our system as young as possible by daily sufficient physical activities, daily sufficient relaxation, including good sleep. Sleep especially is very important, because it is during certain stages of the sleep that the lymphatic pathways remove the amyloid and other scavenging mechanisms happen in the brain. So good sleep is important. Good exercise and physical activities are important. And also green leafy vegetables and limited amounts of healthy non-vegetarian food like fish, and consumption of ensuring that you do get a good air to breathe and live in less polluted atmosphere, use clean water as far as possible. So all these principles of healthy living certainly helps to keep the brain also healthy. Brain health is a challenge for not only as physician, but for entire humanity. And when we go green, the direct beneficiary is brain health, and the brain also can influence the other systems of the body, including the endocrine system, in the reverse direction also. So I think we should all go into this principle of promoting the greener ways of living, the healthier ways of living, making the whole human system, including the brain health, and which also for which it's also extremely important to control a major metabolic disease like diabetes, which has got its roots spread all over the human physiological systems.
So thank you, sir. That was an excellent and candid interview with a doyen in neurology, and it's an eye-opener for all of us. So thank you again. So we discussed about the causes of neurodegenerative disorders in diabetes. We discussed about what is type 3 diabetes. Then we discussed what is the role of insulin. And then we discussed how we can prevent and treat this kind of condition. So thank you again, sir, for those wonderful pearls of wisdom. Thank you again.
Sunil, thank you. Yes.
So thank you, sir. So we are now at the last part of the session, and that's very important panel discussion. And we have an excellent panelists over here, and we have Dr. Soumyadarsan Naik, Dr. J.B. Kanwar, Dr. Arundhati Dasgupta, who have already presented their sessions. Apart from that, we have an excellent endocrinologist from the city of Pune, Dr. Vaishali Deshmukh ma'am, and she had actually, good afternoon madam, and it's our honor to have you here, and she had actually done some real research in a different subject altogether, that is mind body medicine, and she has got some good publications on autonomic nervous system and the mood and cognition and all those things. So we'll be having some pearls of wisdom from her. And joining with us is Dr. Surajit also. Dr. Surajit Sahu is a professor in Department of Neuropsychiatry at IMS in some hospital. So we have 5 panelists and we have only 15 minutes left. So we'll be very fast in that. So coming to the first question, we have discussed something with our professor from JIPMER, also the neurologist. So coming to the first question, what are the cognitive impairment associated with diabetes? And can I ask Dr. J.B. Kanwar to tell about that?
Yeah, if you look at the different parameters of cognitive dysfunction occurring in diabetes, primarily involve memory, learning, attention disorders, and mental flexibility and executive function. So, and if you look at the pattern of these cognitive dysfunction in type 1 diabetes and type 2 diabetes are different. In type 1 diabetes, the association with dementia is less clearer, but primarily those cognitive dysfunction involved or the mental flexibility and this the slowing of mental speed. So this is a primary kind of cognitive abnormality occurring in type 1 diabetes. In type 2 diabetes, it primarily involve memory, learning, and executive dysfunction. Executive dysfunctions means like insights into the problem and judging the problem, solving the problem, and changing the bad behavior to new good habits. So these are very important as far as management of diabetes is concerned, because they do not memorize, they have dysfunction in performing this executive function. So these are the kind of cognitive dysfunction occurring in type 2 diabetes and type 1 diabetes.
So absolutely, thank you. So my next question is to Dr. Soumyadarsan. So just wanted to know what are the risk factors for cognitive decline in diabetes. So kindly elaborate on that.
Basically, as we all know that there are a lot of risk factors which lead to cognitive decline. Age is one of the major risk factors. 60 years or more, presence of genetic factors like ApoE, especially the epsilon 4 allele, long duration of diabetes. We have a poor glycemic control, especially high HbA1c status, and a higher fasting glucose level. Now, most studies have also shown that recurrent hypoglycemic episodes can be one of the factors for cognitive decline. As we already, Dr. Narayan has discussed, insulin resistance. Apart from that, there are corroborative risk factors like uncontrolled hypertension, atherosclerotic, cardiovascular disease, dyslipidemia, physical inactivity, and to top it all, depression can be another arm for the cognitive decline in diabetics. I'd also like to add to Dr. Kanwar's debate. I was having a look at that Accord Mind study. Basically, that was done around 2011-12 when they were doing actually volumetric analysis and this digit replacement. So actually for cognitive function assessment, we need comprehensive scales. We usually use the MOCA or the MMSE. And we also have studies where they've used Addenbrooke. So these scales are more comprehensive rather than that digit replacement. And volumetric analysis, prior to volumetric, means after volumetric analysis, we now have functional MRI studies which give a definite indication of actual functional capacity in a diabetic's brain. And that Accord Mind study was basically to distinguish between the glycemic control, strict glycemic control, and I think the regular glycemic control, or which was not very intensive. So basically, hyperglycemia is the basic risk factor for cognitive decline. But again, we require good studies. There's one frontier study from Kerala where they have done this Addenbrooke, and they have seen that there is a significant decline in the cognitive factor. And to top it all these combined comorbidities like uncontrolled hypertension, dyslipidemia, smoking also lead to accelerated cognitive decline. Thank you, Sambit.
Thank you, Dr. Soumya. So, to the next question, I think we have discussed with Dr. Sunil also about the insulin and the insulin resistance. Dr. Arundhati, you have reviewed entirely about the glycemic control, insulin and insulin resistance. So, do you want to highlight anything more on this topic, insulin and insulin resistance?
Just that the initial concept where we thought that insulin, is not important for the brain, that concept has gone, and how we, Sir also spoke about it, that insulin is very important in terms of the other factors, where we know that insulin has a role to play in terms of appetite. It has been seen that insulin receptors are present in these the areas of the hypothalamus which deal with the appetite. And basically in experimental cases where the insulin receptors were removed, it was seen that these rats, they developed hyperphagia and obesity. So thus telling us about the importance of the association between insulin per se and the appetite. It also has a very strong role to play in terms of cognitive dysfunction. And these actions of the insulin are not related to the glucose metabolism. They are per se the action of insulin on the brain. There is a direct association between the other areas also, like, for example, depression. Samit, long back, the treatment of schizophrenia used to be insulin therapy once upon a time. So this was basically, they did not know why they were doing it, but subsequently we came to know about the association with the mood, the cognition, and others. And also insulin, though not directly on the brain, but it has an effect on the peripheral nervous system via the brain, the insulin receptors on the brain. So apart from the glucose metabolism, insulin does have many roles to play in the brain in terms of all these areas of function.
Absolutely. Thank you. My next question is to Dr. Surajit. So, who is a neuropsychiatrist. So, I just wanted to know what are the tests to be done to know that the person is having declining memory. So, what tests we should do?
So actually, when the person goes for this neuropsychiatric manifestation or cognitive decline, actually we should be very much aware of at least 3-4 years before the treatment, because when the patient manifests the disease, at least 3-4 years already lapsed, because this manifestation actually comes very late, and because of this intelligence ability, and person can manage their intellectual deficits, mostly cognitive deficits, by this way. So we should be very much vigilant and sensitive bedside or sensitive clinic side investigations, like already told by Sambadasan. And this is MUCA, Montreal Cognitive Assessment Skill, and also MMSE. This takes around hardly 10 minutes time. With a very busy schedule, also we can go for this, and hardly MMSE, there are 30 questions and 25 questions, and 30 is the full mark. So it takes around maximum 10 minutes. So it is also very easy to ask this question by asking all this orientation and attention calculation. This can be very quickly done, but this is very important that before that, actually, the concept is MCI, very minimal cognitive impairment. Actually, the scale is around 30, but 24 to 30, these people are able to manage these things very early. So we are not able to detect. So this is about prevention. And in the diabetes, basically whatever you see, the insulin is one part most, but you will see that in type 1 diabetes, and non-insulin parts are very problematic in type 2 diabetics. So for that reason, type 2 diabetic people are more presenting cognitive impairment and other things like dementia and other things more than the type 1 diabetes, because type 1 mostly we depend on insulin, in type 2 some other medications, and in type 2 vascular problems are much more. When there is any vascular problem that damages the end arteries of brain, and also very quickly the brain damage, and it goes very slow manner in actually Alzheimer's disease. But added with Alzheimer's, in dementia with vascular disease, it very quickly degenerating these causes. So this diabetes and these causes goes side by side, and these are just sisters like problem. The one is coming, then other sister will come very quickly, and other sister will come very quickly. So like this, they will come very quickly, and with this MUCA, these are all bedside, very quick examination can be done, and this can be done by any of the clinical psychologists if you are busy scheduling, and this takes hardly 10 minutes time.
Thank you. Thank you for highlighting those important tests and how we can do it in our clinical practice. So, moving to a absolutely different topic, I won't tell it's a different topic, but since we are discussing about diabetes and diabetes and the nervous system, so one of the important aspect is autonomic nervous system, and we have Dr. Vaishali Deshmukh. I think ma'am has done some work on ANS also. So just wanted to ask two important questions. What is the effect of diabetes on ANS and its implications? And how is your research on mind health linked to autonomic health? Because you have good publications on that. So kindly highlight it, ma'am.
Yeah, thank you, Dr. Sambit. And basically, we need to understand that diabetes is a bidirectional effect on the brain. So it's like body affecting the brain and brain affecting the body in return. And the common link of this affection goes through the autonomic nervous system, because what we call as wellness and health is actually a center which is focused at the autonomic nervous system, because that's the place where endocrinology integrates with the brain, where hormones come in contact with the brain. And what we see in diabetes, we call diabetes as a metabolic stressor. I'm sure all of us are aware that it's a metabolic stress to the body when one gets glycemia. And any stressor is known to affect the autonomic nervous system because it's a threatening to the homeostasis of the body. So the autonomic nervous system of every diabetic patient senses it, and that is why you get an imbalance in the autonomic nervous system in every diabetic patient. Now, it begins initially with sympathetic overactivation, and this is known to also activate the HPA axis. So it is known to increase the cortisol. So you see that irrespective of whether the patient has psychological stress or no, per se, a metabolic stressor which is threatening the homeostasis is known to affect the HPA axis as well as the sympathetic nervous system. Now we know that sympathetic nervous system as well as the cortisol are toxic to the brain. These are two molecules and two things which are known to cause neurocognitive decline. So as soon as diabetes sets in, we are starting with a neurocognitive decline by a sympathetic overactivation and cortisol excess. So I think that we need to understand that the first job of us as diabetologists or endocrinologists is to get this autonomic nervous system into a good balance. So if we have sympathetic overactivation in our patients, which is the earliest manifestation in every diabetic, we are not really doing good by just getting glycemia under control if we are not paying attention to the autonomic balance. And you see that the commonest cause of mortality in diabetes is linked with the heart. And we know that the commonest cause of cardiac mortality is also not ischemic heart disease, it's just more of arrhythmias. It's more of neurology of the heart. So it is the autonomic nervous system which is more happening or rather more impactful as far as the cardiac morbidity is considered. And I think, unfortunately, that is the earliest abnormality which we can pick up. And we fail to pick up in our practice. And that is why this whole work, which has been designed by us, which focuses on mind-body interventions very early in life, as soon as diabetes sets in. And secondly, we have also designed a machine to diagnose autonomic imbalance at the earliest. So that machine is in the patent now. So I think that with these two techniques, what we have been able to achieve is that we are able to detect the abnormality early. And second thing, with the mind-body interventions, we have been able to rectify this imbalance at an earlier stage. So what mind-body interventions effectively do is they improve the positivity of the brain through counteracting the cortisol and increasing the brain derived BDNF. We know that it's a neuroprotective agent. GABA is no neuroprotective agent. So all the mind-body interventions are known to enhance BDNF, enhance GABA, and that is what we achieve, that we are preventing this neurocognitive decline by starting implementation of mind-body intervention right at the outset when diabetes has set in.
Thank you for those important pearls of wisdom. So, Dr. Kanwar, we have now very less time left. So I'll just ask you and Dr. Arundhati also. So how are you going to manage diabetes with cognitive decline? First, you will tell how you are going to manage. Then Arundhati will tell what are the important drugs which has got some beneficial effect. So over to you.
It's actually a diabetic person having cognitive decline. They have difficulty in self-care. They tend to forget taking oral anti-diabetic agent, tend to forget taking insulin. Even they take insulin, they tend to take the food. And sometimes they have executive dysfunction, so they do not know what to do, how to adjust the dose of insulin, particularly doing exercise. So these are much more practical problems. So many of the times, if you find an elderly person who is, in spite of all the efforts, if the sugars are not controlled, and probably patient having cognitive decline, you can assume maybe have a cognitive decline. And as far as glycemic control is concerned, the best is to give a very simple regimen for this patient, not too very complicated insulin regimen or some long-acting medication, oral medication in a low doses are particularly beneficial. So the best way to achieve this thing is just give a basal insulin in the morning to control the fasting blood sugar and try to control the postprandial blood sugar with non-insulin regimens. Maybe GLP-1 receptor agonists, DP4 inhibitors are good. And even SGLT2, Pioglitazone, those who are having a risk of hypoglycemia. So for postprandial, you can manage with these non-insulin agents.
Sure.
Thank you.
Arundhati, you want to add anything?
Yeah, I think he said it, but just that recently we've also had data about some of the electronic devices which can help in such patients. So last we had a paper which told us about the various like the voice recorders, or something which gives a reminder clock, or you have those watches, you have a vibrating watch which tells you about the time, because these people tend to forget to eat, they tend to forget to take their medicines, and also if possible, if they're put on pumps, then if you could have the closed loop wherein they get the hypo and the hyper beeps, that's for one segment. So at least some proactive measures need to be taken, so that I mean, while it is very important for the caregivers to stay beside them, but it is not always possible. So recently, in fact, I saw some patients who have been initiated on 2-3 patients who have been initiated on these kind of devices, and it has actually helped them. So I think we can go about proactively in helping them decide on the use of these devices now.
Thank you. I think it's very good. So my last question to Dr. Soumyadarsan, and then we'll wrap up. So how do you holistically manage a case of patient with diabetes with cognitive decline?
Absolutely. As we have all seen, it's a team approach, and not only the endocrinologists need to take care of the sugar and other risk factors. There's involvement of the neurologist, especially in risk stratification, when the patient needs caregiver support, especially when he has crossed to stage 2 or stage 3, when there are multiple cognitive domains like memory, execution is involved, there is disexecution, he's unable to perform his daily routine activities. That is the time when he requires caregiver support. He also requires a good nutritional plan. And as Dr. Kanwar has reiterated, that the injectable drugs, insulin, has to be curtailed, because there's always this dementia component coming into play. They don't know how much insulin they are taking. They don't know how much they are eating. So all this may require a caregiver's help. Even daily care has to be taken care of. A physiotherapist, podiatrist will help in doing some regular exercises. Taking care of the gait and balance are also important, because they will be affected by neuropathy. Falls are very common in elderly and especially demented patients. And as Dr. Arundhati rightly pointed out, we need alarm devices. Also, we need devices on the patient, at least on his mobile, so that he does not wander off. And if there is an emergency contact or apps where his trackers, where he can be located, that would be also of great help. And apart from that, all these holistic methods of yoga, pranayam, all these need to be taken care of. And as Vaishali ma'am rightly pointed out, a cardiologist's intervention might be required to look into the diabetic autonomic neuropathy, especially the CAN part, cardiac autonomic part. So it has to be a team approach, basically.
So thank you all. I think it was a very wonderful panel discussion where it discussed about. Yes, sir.
Just one question to the panel. When such patients will travel from you to Soumyadarsan and then to Surajit? Surajit should answer this.
Sir.
Could you hear me?
Yes, sir.
When such patients will travel from us to Soumyadarsan and then to Surajit, or from us to Surajit, like that. That is a very practical aspect.
Sir, actually, this is very important part is that when diabetes is a problem where multiple areas have been involved, because it damages the kidney, the neurological system, the eye, the feet, hand, and also the heart and brain also. So this goes side by side. So actually, So they should be actually normally every year we should like every year the patient is going for cardiological evaluation, neurological evaluation, and also ophthalmological evaluation. They should also go for any cognitive impairment is going on or not. Like I have already told, this a very small questionnaire with this MMSC or MOCA can help that this patient is going to develop this cognitive impairment. And cognitive impairment is on to management mostly, sir, two aspects. One is proper glycemic control. If it is more glycemia, then it is a problem. Then less glycemia, then it is also a problem. Hypoglycemia is problem. Hyperglycemia is problem. So proper glycemic control. Then risks of vascular damage to both the heart and other places and also to the brain to be protected. Whatever the medicine is like it may be actually aspirin, it may be some other drug, whatever the medicine is there, to vascular damage should be restricted or prevented. Then next coming about cognitive impairment. Generally, what we study, because when the patient manifests this cognitive impairment, nearly 3 years or 4 years have been lapsed. Generally, they come at the last stage. There's about dementia and other people, they suffer about 2 to 9 years. If it is vascular dementia, it is stepwise problem is there, and very quickly it goes for damaging this brain. But with Alzheimer, because also the Alzheimer is there is predisposed by also with insulin deficiency. These are all problems go side by side. So generally, at the age of 60, and the patient is developing any of this uh, vascular problem is there, then they should be sent for this evaluation that whether they are actually developing this neurocognitive impairment is there or not. Then we should actually assess whether proper glycemic control is there, proper cardiac control is there, and also other vital organs have been affected or not. Then we go for actually assessing these cognitive functions. Then we go for the proper treatment. And mostly, sir, actually, both this memantine and also donepezil, these actually donepezil in our clinical practice, this helps because it's a low dose always is better than giving high dose at one time. But actually, what happens? The family members refer this patient comparatively in a later stage. When there is a serious condition is there and the person is very much violent, aggressive inside this home, and then the patient is referred to us by the clinicians, and then with this, there's actually no medicine helps in the people. So with that also, already this is told by this non-pharmacological approach by Dr. Kanwar was there, by Dr. He was telling that exercise and rehabilitation of this patient into the proper and walking. Simple walking also helps because it reduces the stress, and also the both the physical and mental stress are being reduced. So these are also non-pharmacological. Diet itself playing also very good role, but this should be at least done to prevent this, because once the disease has been started, then it is difficult to actually prevent it. So prevention is better than the cure.
So, yes, sir. So just one point I would like to add to your question, sir. Once you have any red flags which pertain to memory or any disexecution, especially if the patient is not able to do his day-to-day activities, including taking insulin at proper dose, missing pills, or he comes to you ill-clothed, not taken care of, and if he is presenting to you as stubborn or some behavioral issues, like he's more angry, irritated, anything you see which is beyond normal, you can actually refer for just a cursory checkup to a neurologist or a neuropsychiatrist. So they will do a detailed evaluation. If he's in the MCI stage, they will give adequate medications, as already told by Dr. Surajit sir. And if he has already progressed, then they may require an overall and caregiver attention. So that will be decided after a detailed evaluation. As he has, sir has rightly pointed out, we catch the cases very late. So the onus is on diabetologists to refer as early as possible when the patient is in the MCI stage rather than a full-blown dementia case.
Thank you. Sambit, please conclude.
Yes, sir. I think it was a very excellent panel discussion, and we have excellent panelists on that. So but now we are concluding this symposium. So over to Alok sir and Sukdas sir for the next session.
Thank you.
Thank you.
Thank you, Sambit.
Thank you.
Dear friends, it was an excellent session on diabetes, nervous system and brain. Now we have an interesting session called Modern Therapeutic Approaches. This has been organized by USB, and my co-chair is Dr. Professor Srikant Dhar, who has already joined. He will manage the show. Only one information: Dr. M.P. Barua met with his mother met with an accident and has been hospitalized. So MP is not able to take his talk, which will be done by me. And I will request Srikant to introduce the topic and call Dr. J.J. Mukherjee to be the first speaker. Dr. J.J. Mukherjee will be the first, then S.K. Sharma, and my talk will be the last in this series.
Perfect.
Thank you, sir. Thank you for giving me opportunity again in NUCD, and it is a great show till now, and we have already taken a part in last symposium, which was again a beautiful one. We will go to the next session. As we have already, sir has mentioned, the first talk by Dr. Barua has been shifted for the third toast, and the next talk will be taken by Dr. J.J. Mukherjee. So there is some twist in the numbering in our session. We will invite Dr. J.J. Mukherjee for his talk on dapagliflozin as first-line therapy in the management of diabetes. CV, please. We will invite Dr. J.J. Mukherjee, is a senior consultant in Department of Medicine, Apollo Multi-Speciality, Kolkata, with multiple publications and many chapters to his credit, and which is editor of the Handbook Managing Diabetes and Endocrine Condition, Case-Based Comprehensive Approach. Without much delay, probably we should go for the topic because it is a important one, and as well as very calling the use of SGLT2 dapagliflozin is commonly used by most of the diabetologists. So we should go without much delay for discussion. Over to you, sir.
Hello, good afternoon. Thanks to NUCD 2024 for inviting me for this talk, and in particular, thanks Professor Alok Kanungo for giving me this opportunity. And I have a very exciting topic: dapagliflozin, SGLT2 inhibitors, as the first-line therapy in the management of type 2 diabetes. I am Dr. J.J. Mukherjee from Kolkata. Sorry, I overshot. So let's start with the case with me. A 49-year-old male, IT engineer, smokes 10 cigarettes per day, 120 to 180 ml of alcohol per week, permissible. Obese, detected to have diabetes 3 months ago, HbA1c is 8.6, hypertensive on A2RB and CCB, not well controlled, LDL is 143, on a statin, dose you might take whatever you want to take as the dose, maybe 20 milligrams, no DR, no nephropathy, no peripheral neuropathy, ECG shows an old anterior wall AMI, Q waves from V1 to V3, and a 2D echo requested by his treating physician shows an LVF of 42%, which is ref with reduced ejection fraction. So question is, what are you going to do? How are you going to treat him? How are you going to approach him? Are you going to think about an SGLT2 inhibitor or a metformin or a GLP-1 receptor agonist? Answer is no. You have to think about holistic care first. So for this person, glycemic control, yes, is important, but prior to that, we need to get his blood pressure under control. We get to get the lipids under control. We need to have at least a 2 to 3 minute conversation in our first visit about how obesity is not good with regards to all the metabolic issues that he has. And we have to have a kind of a conversation with him regarding quitting smoking. After we have done that, we need to think about getting the glycemic control. And we cannot do all this on our own. Physician is only 1/4 of the whole treatment armamentarium. We need to have a dietitian if we can, some trainers, motivators, and diabetic nurse educators who will keep reinforcing the education. As you know, majority of the treatment is diabetes, education, education, and education. So now when you've dealt with the hypertension, which is not too difficult, but not easy, once you've taken care of the lipids, once you have talked about obesity, quitting smoking, you start thinking of glycemic management. And when you start thinking of glycemic management, you need to know the pathophysiology. I grew up with the traditional triad with increased hepatic glucose output, decrease in insulin secretion and insulin resistance, and then Defronzo in 2007 in the Banting lecture added a few more, where you have the incretin effect and you have the increased glucose reabsorption, which is called the ominous octet. So whatever treatment we start to give, we need to make sure that we're dealing with this pathophysiological defects. Otherwise, we may not be getting a good outcome in the longer run. So my topic is first line. I mean, this first line, second line, third line is not an outdated concept. Why is it outdated? Let's go through the various standards of care of the American Diabetes Association, which are based on the various ADA ESD guidelines. Now, this is way back in the year 2016, metformin, followed by a second line, a third line, and then a combination injectable therapy. So be it. Come to 2017. Again, they say start with metformin. That's the talk. That should it be metformin or should it be an SGLT2 inhibitor? Then comes dual therapy, metformin plus SU, TZD, DPP4, SGLT2, GLP-1 or insulin, and then go on to triple therapy when you are not able to get glycemic control with dual therapy. Come to 2018, looks the same. Monotherapy, dual therapy, triple therapy. Now, when you come to 2019, things begin to change. Why? Because by now you're getting the data, the EMPA-REG outcome trial, the Canvas trial, that beginning to come into the picture. And now what they do is there's a sudden change now. If you go back here, instead of putting everything in one basket, you're now dividing them into those with established ASCVD or CKD and those without established ASCVD or CKD. And then you're putting them into groups compelling need to minimize hypoglycemia, compelling need to minimize weight gain, and cost is a major issue. But still, in 2019, if you see on the top, it still says first line therapy is metformin and comprehensive lifestyle modification. Don't forget that. Professor Alok Kanungu keeps stressing that, and I agree with him, that lifestyle modification has to be on the top. If you want to believe in this first line, second line, then I think the first line is lifestyle modification. Now let's come to 2020. What happens? Looks almost the same. Again, have you got any organ-specific issue? That's type 2 diabetes with ASCVD, CKD, or heart failure comes in now. But remember, heart failure or CKD are in the same box here now. And they're the same three things. Company need to reduce hypoglycemia, weight gain, or cost is a major issue. Coming to 2020, now if you see heart failure and CKD separate out, because by now more data is coming about SGLT2 and the CKD benefits. So now, instead of in the previous year, where heart failure CKD was in the same column, they're now being teased out into ASCVD, heart failure, and CKD. But on the right-hand side, people who do not have established ASCVD, heart failure, or CKD, they still remain as they are. Hypoglycemia, weight loss, or cost is a major issue. Now you come to the next year. What happens here now? Now here, if you see, first-line therapy still is metformin, but the line has now changed. First-line therapy depends on comorbidities, patient-centered treatment factors, including cost and access considerations, and management needs, and generally still includes metformin. 2021, 2022. Here, the boxes are still the same, ASCVD, but they get a little bit more elaborate now because you're getting more data with SGLT2 and GLP-1 RA. And on the right-hand side, looks more pleasing to the eye. Hypoglycemia, weight loss, and cost is an effect. Now, the use of glucosamine in the management of type 2 diabetes, 2023. Metformin has disappeared from the top. Oh my God. Healthy lifestyle behaviors, diabetes self-management education and support, social determinants of health. And then straight away you're jumping into whether there is ASCVD. And now you see another big box, which is indicators of high risk. Then comes heart failure, CKD. And now if you come on the right-hand side, gone are those subdivisions, whether you want less hypoglycemia, weight gain, or cost is an issue. It all becomes only two columns now. Glycemic management and achievement and maintenance of weight management goals. And the same thing is the latest one, which is the ADA Standards of Care 2024. So what have I said from 2016 to 2024? The ADA Standards of Care, which most of us follow, which are inverted commas evidence-based based on the ADA, ESD, various guidelines, they have now gone up. The first line, second line, third line. So this thing about dapagliflozin should be first line therapy probably a little bit outdated. Why and what we should do, I'll discuss as we go on. So I think what we should do is when you see a person with type 2 diabetes, you need to decide what kind of type 2 diabetes it is. I mean, all type 2 diabetes is not the common garden type 2 diabetes that we treat. Is it a LADA? Is it a type 2 diabetes with insulin deficient? Then the treatment is different. I think we've done all that. And we're not talking about common garden type 2 diabetic patients. So whether they have comorbidities, ASCVD, high risk for ASCVD, heart failure, or CKD. So the same gentleman now, we've taken care of the hypertension, hyperlipidemia, smoke. So it's high risk. Smoking, hypertension, hyperlipidemia, he's got ASCVD, and he's got heart failure. So for him, he's on the left-hand side of the treatment algorithm. He's got ASCVD, he's got indicators of high risk, not by age, but he is obese, he is smoker, he's got dyslipidemia, he's got hypertension, and he's got heart failure, which is compensated because he's walked into your clinic. So here in this situation, either a GLP-1 with proven CVD benefit, in most cases you can't use it because of cost constraints. So the easier option is an SGLT2 inhibitor with proven cardiovascular benefit. Now he's got heart failure, GLP-1 is not here. It's SGLT2 inhibitor. And if he's got CKD, which he doesn't have, then SGLT2 inhibitor score over GLP-1 receptor agonist. So if you think of an SGLT2 inhibitor, the best evidence comes with dapagliflozin and empagliflozin. Kana does not have this broad data with regards to the MACE, CVD, heart failure, and renal outcomes. And ertugliflozin is not available to us. I will not be discussing. This is the DECLARE-TB trial, which showed that you had a statistically significant reduction in CVD, hospital, and heart failure in DECLARE-TB. And then when you sub-analyze the DECLARE-TB data, people who had an MI less than 2 years ago also had a reduction in the 3P MACE, and people with prior MI, which was about 40-odd patients, the people fell into this group. Now, 60% of the people fell into a primary prevention group in the DECLARE-TB trial, which was different from the EMPA-REG and the CANVAS trial, that they only had multiple risk factors. And even here, if you see, they got a benefit with CVD, heart failure, or renal failure. So in this group of patients, people with established atherosclerotic cardiovascular disease, heart failure, renal, CKD, would you be choosing metformin or would you be choosing an SGLT2 inhibitor? And the answer is very simple. If you take metformin as a first-line drug in patients with type 2 diabetes with high CV risk, this is from Dr. Abdesh's article in 2021, there is no evidence in head-to-head trial that suggests metformin is inferior to SGLT2 or GLP-1 reducing CV risk. None of the CVTs were conducted in the absence of metformin. No clear evidence exists that metformin mitigates the benefit, maybe slight, you'll see on the other side. UKPDS 34 showed significant reduction in MI and all-cause death, albeit a small number of 354 patients who got on metformin and the other 354 were not on metformin. But it did show statistically significant reduction in MI and all-cause death mortality. And meta-analysis of real-world studies found significant reduction in CV and all-cause death in patients with CAD. So in people with established CAPD, ASCVD, if you're using metformin, you get this benefit. It's inexpensive, minimal side effects, and many other additional benefits which you have with metformin, like anti-cancer and anti-aging properties. But if we come to the cons are available evidence of CV benefit with metformin. It's class 2A. It's level B evidence, as opposed to SGLT2 and GLP-1, where they have absolutely well-designed cardiovascular outcome trials with class 1 level A evidence. there might be some studies, some meta-analysis have shown that there might be some mitigation of CV benefits, especially of GLP-1 RAs and SGLT2s if they are used with metformin. But this is not sacrosanct. UKPDS 34 that showed benefit in MI and all-cause death metformin had minimal patients with established ASCVD, which I think is not negative. Maybe this is a positive point for metformin. Meta-analysis of RCT found no significant reduction in severe all-cause death. It's exactly opposite to the other side in the meta-analysis. There are a couple of meta-analysis which show benefit, and there are some which do not show benefit. And use of metformin alone might delay the use of these agents and therefore may deprive the anticipated cardiorenal benefit, especially in patients with high CV risk. I mean, so if you look at somebody with type 2 diabetes, like our patient, 49-year-old, who's got heart failure, who's got indicators of high risk, and has also got ASCVD, I mean, you will be choosing an SGLT2 or a GLP-1, obviously, because it's got a class 1 level A evidence. But if you ask me, this is all absolute and unnecessary debate. I mean, I would be using both the agents because metformin also gives me the benefits in this group of patients. So I will use metformin plus an SGLT2 plus also other anti-diabetic agents because you see the HbA1c is 8.6. A metformin, a DPP, and an SGLT2 inhibitor may not get me to my glycemic goal of say 7% in this person. So this thing about which first, which second doesn't make sense. I mean, I would be using both together, and that is what we wrote. And this book is coming out with the next edition very soon. And we wrote that initial combination therapy is the way to go in a person with type 2 diabetes. Certainly in this patient, in the combination, an SGLT2 inhibitor like dapagliflozin or an empagliflozin must be there. Between DAPA and EMPA, nothing much to choose because you already had an AMI, so probably an EMPA may be a better option. But if you only had risk factors without an established AMI, maybe dapagliflozin would have been a better option. So what about the other group? Type 2 diabetic patients who do not have established cardiovascular disease, 32-year-old, IT, non-smoker, type 2 diabetes for 3 months, BP is normal, lipids are controlled, no renal failure, no retinopathy, ECG is normal. So it's falling on this right-hand side group. And here, if you see the guidelines suggest for glycemic management, use drugs with efficacy, high efficacy of glucose lowering, which is probably the GLP-1 receptor agonist and insulin, and SGLT2 inhibitors and metformin both come together into the high efficacy of glucose lowering group. And on the right-hand side for weight, if you see SGLT2 inhibitors are above metformin with regards to weight reduction. And to answer this question, there's a huge group of people, you will recognize many of them who will be attending this conference, who did a meta-analysis on SGLT2 as a first-line anti-hyperglycemic in the management of type 2 diabetes in the context of Indians, a systemic review and consensus. And what they found was impact on HbA1c same, glucose variability probably the same between SGLT2 and metformin. All the yellow boxes, beta cell function, insulin resistance, gut microbiome, impact on weight, impact on BP, impact on lipids, all the same. Some of them have got level A evidence, randomized control trial, some of them have got level C evidence. Where it scores over metformin as first line is CV protection and renal protection. And if you come to combination of SGLT2 or metformin, again, as safe, SGLT2 combination with insulin and decreases insulin requirement, again, is as effective. This is a meta-analysis where this group of people went through all the published literature till date before publishing this article. So if you want to take the cost effectiveness, if it is a Western world, then probably it's different. In Western world, SGLT2 and GLP-1 receptors cost more. But if you come to India, probably the cost difference is still there between metformin and an SGLT2 inhibitor, but probably is not that huge as it is in the Western world. So what they suggested, published very recently, if you can see, just December 2023, just about last month, they are suggesting, this article advocates adopting SGLT inhibitors as a primary treatment choice for treating patients with newly diagnosed type 2 diabetes in India. I don't know how many of you will agree to that. To me, I think it's again an unnecessary debate. I will not be using a single agent, be it metformin or dapagliflozin. I will be using a combination. So use both agents together along with other diabetic and anti-diabetic agents, because with using a metformin and an SGLT2 alone, you may not get glycemic goals. So we need a paradigm shift. We need to use combination therapy, and I would be using metformin together with an SGLT2 inhibitor. GLP-1, if they can afford it, I'll show you what my combination concept is. And this is what we wrote in this chapter in Professor Sadiko's textbook on the chapter on combination therapy, depending on the baseline HbA1c. If it's very high, of course, you have to give insulin. But if it's 7.5 to 9, you would think of triple therapy. And look what we are suggesting: metformin, SGLT2, and GLP-1RA. So yes, SGLT2 inhibitors should be inverted commas first line, but the first line should include a combination of therapy rather than a single drug. But what is the reality? You will find this very, very interesting. This is published in 2021, Diabetes Care. These are the two various large insurance bodies in US, Medicare and Informatics. Look at the 80%, this is 90%. Look at the use of metformin. This is from the year 2013 to 2019. Look at use of metformin, 80 to 84% all throughout 2013 to 2020 is metformin, despite the FDA change for empagliflozin for CV risk reduction, despite FDA label change of liraglutide for cardiovascular protection, and despite ADA endorsement of SGLT2 and GLP-1 as preferred second-line treatment for CVD. Despite all this, if you look, metformin is so high, next still is sulfonylurea. Then is insulin. These are three drugs I used when I was doing my training, and they are still being used so high. So we need a huge paradigm shift in moving from this age-old metformin, sulfonylurea, insulin. Look at how poorly GLP-1 and today's discussion of SGLT2, how poorly they are doing. SGLT2 is this, I can't get my arrow, there it is. The red triangles, how piddly 2% of the people are getting SGLT2 inhibitors. So in the last 1 minute, I would say that when a patient comes to you with type 2 diabetes, don't just think of glycemic control, think of blood pressure control, lipid control, get them off smoking, think about weight. Think about pathophysiology. So don't think about first line, second line, third line. Think of combination therapy from the very beginning and choose the combination well. If there is ASCVD, heart failure, high risk, or CKD, please have a dapagliflozin on board along with your other combination drugs. Metformin can be on board because metformin also gives cardiovascular benefit, as shown in UKPDS, that small trial. People without ASCVD high risk, again, combination therapy and affordability, depending on affordability, metformin GLP-1, metformin SGLT2, and if HbA1c is more than 7.5, metformin SGLT2 and a GLP-1 or a DPP-4. So in conclusion, please think of an SGLT2 inhibitor quite high. Don't think of, I will start SGLT2 one day. You start SGLT2 today if there are no contraindications, and we all know the contraindications. Recurrent UTI, GTI, upper UTI, recurrent UTI, if they have EGFR, probably nowadays less than 20. If there is if this type 1 diabetic, if somebody is in hospital who is restricted on carbohydrates, then you will not be using an SGLT2 inhibitor. With that, I will end my talk, and during the panel discussion, I shall be more than happy to take questions. Thank you.
Thank you, Dr. Mukherjee, for the lucid talk, and we are happy that you have also advocated for metformin as a combination of dapagliflozin and metformin. Probably we'll be knowing about what about sulfonylureas. You have gone more projected more about SGLT2 and metformin, and now we'll be projecting on sulfonylureas by Dr. S.K. Sharma. CV, please.
I have 1 second to welcome Dr. Sharma, who looks young, though he is so senior, like sulfonylurea. So he is the best example of ever glowing sulfonylureas. Welcome, Dr. Sharma, to NUCD.
Thank you, Dr. Kanungo. It's always a pleasure to be in the company of Dr. Kanungo, Dr. Panda, Dr. Das. So I will share my slides. Are they visible?
Not yet.
Not yet, sir.
Not yet. What's the problem? They are not visible. Yeah. Let me see. Now they are visible?
Yes.
Make it full screen, sir.
Yeah. Yeah. So good afternoon, dear friends. I'm thankful to Dr. Kanungo for inviting me. Of course, I am missing the physical meeting here, but we'll be there in Bhubaneswar in short time from now in our Diabetes India meeting. So, dear friends, I will be talking about the modern sulfonylurea with combination of metformin, and what we say is a green swan of oral anti-diabetic drugs. Dr. J.J. Mukherjee beautifully highlighted that it is an era of combination of drugs. And in his second last slide, he highlighted that most of our patients are on metformin or sulfonylurea. So we still have great faith in sulfonylurea. Of course, once we say sulfonylurea, it is modern sulfonylurea like glimepiride. So what is this green swan? So John Elkington introduced the term green swan in the book Green Swans, and the green swans are solutions that take us exponentially towards breakthrough or systemic solutions to global challenges. So modern sulfonylurea like glimepiride is emerging as a green swan of oral anti-diabetic drugs in the management of our type 2 diabetic patients. Why and how? So here you find that it is a guiding light because modern sulfonylurea uses continue to lead in India as well as globally across type 2 diabetic continuum. Incredible speed, early, great and durable glycemic control is achieved with sulfonylurea as compared to most of other oral anti-diabetic drugs. It is having beauty and grace across type 2 diabetic continuum. It is gracefully working in our diabetic patients. We have great trust. So we find that more than 1 lakh doctors from India are having trust on sulfonylurea like modern sulfonylurea glimepiride because of its safety, efficacy, affordability, and it is available and appropriate in its working. Flexibility is also very important because you can prescribe it along with most of other anti-diabetic drugs as well as with insulin. And elegance of its effect, robust experience and evidence with aging gracefully is there. So if you look into history of sulfonylurea, it was discovered by Lobetiers in 1942. Work started, or you can say launch was there in 1956. And then you find that only one problem was there in UGPD, where tolbutamide, which was the first generation sulfonylurea, was linked to increase in myocardial infarction rate. Otherwise, if you see throughout the you can say journey of this sulfonylurea, particularly modern sulfonylurea, you find that in advanced trial, there was a cardiovascular safety with glycoside. European Society of Cardiology study and Carolina study particularly are highlighting that when you are comparing glimepiride to linagliptin, both are showing cardiovascular safe. So, and then recently we had GRADE study and JADE study, that is Joint Asian Diabetes Evidence Studies, which are again highlighting that in South Asia, large number of our patients are on sulfonylurea like glimepiride. So dear friends, era in glucose management is changing. We are evolving from earlier glucocentric approach to cardio-renal risk reduction. And a very important message why Dr. J.J. Mukherjee was that today is an era of combination of drugs. So whenever we have a patient of, let's say, cardiovascular and renal complication, of course, we will prefer to use GLP-1 or SGLT2 inhibitor, but these patients do require additional anti-diabetic drugs like metformin and sulfonylurea, which is modern sulfonylurea. Nowadays, we are not using old, or you can say first generation or second generation sulfonylurea. We are using this third generation glimepiride more commonly. So there is an evolution of management. Earlier, we were targeting only the hyperglycemia, how to bring down HbA1c. And then the second era was that you look at not only HbA1c, but also cardiovascular risk factors, side effect profile of the drugs like hyperglycemia, hypoglycemia and weight gain. And then third era was the organ protection, where we are looking at all these newer drugs. So modern sulfonylurea like glimepiride is having green evidences from India. It has got large number of publications in Indian studies, right from JAPI to Corias to, you will find that it was highlighted as a combination therapy with metformin in our young diabetic patients, elderly diabetic patients, and even fixed dose combination and low dose combination were also studied. So green evidence from India, again, you find that these journals like IJEM, Indian Journal of Endocrinology and Metabolism, and other journals are typically clinically telling us very specifically that these combinations of glimepiride and metformin are very, very useful in the management of our type 2 diabetic patient. There was a debate in IDF in Lisbon in 2022, and the new phase sulfonylurea in the era of new oral anti-diabetic drug was the topic. And they usually highlighted that sulfonylurea may be becoming the ugly duckling of oral anti-diabetic drugs. Is it justified to say that they are ugly duckling? And the results were that no, it was not, because sulfonylureas control glycemic level, reduce my macrovascular and microvascular complications. They are safe, they are highly accessible, affordable, and high patient acceptability. Sulfonylurea continue to be supported by robust long-term evidence. We are using it for the last 20 years or so. Sulfonylurea has important contributes and remain important oral anti-diabetic drug, especially in the context of the global, you can say, resource there. In JADE study, again, if you see the modern sulfonylurea like glimepiride are popular oral anti-diabetic class in South Asian countries. It is providing good glycemic control and safety profile associated with the use of sulfonylurea, support their position as a key treatment options in patients with type 2 diabetic. Here you find that safety of modern sulfonylurea. Earlier, there was some confusion that ischemic preconditioning may be deteriorated by sulfonylurea, but that was happening because of older generation sulfonylurea. Newer generation sulfonylurea like glimepiride will not have any receptor on the mitochondria of the cells, and they are cardiovascular safe, should no longer be a concern when choosing sulfonylurea, especially glimepiride, for our people with type 2 diabetic patients. And here you find that there are so much of evidences, right from ADA, European Journal of Preventive Cardiology, Carolina trial, as we discussed, is very, very important, telling us that it is as safe as linagliptin. Then there was a South Asian Federation of Endocrinology societies are again endorsing the modern sulfonylurea. Then you find that other studies like GRADE is also telling us that it is safe in our patients. The latest shade of green, that is cardiovascular safety, European Society of Cardiology highlighted that there is a significant lower all-cause mortality, cardiovascular mortality, and number of hospitalization and emergency visit of heart failure and hospitalization for acute myocardial infarction or stroke with glimepiride. Long-term continuation of glimepiride use was associated with better survival, fewer hospitalization, and you can say emergency visits to the heart failure. And high dose glimepiride like 2 to 4 milligram is associated with lower cardiovascular mortality. These evidences are coming from European Society of Cardiology. Again, you will find that there are studies which are clearly looking at the cardiovascular safety of sulfonylurea as a second line drug. And here in this study, the objective was to assess the real world cardiovascular safety of sulfonylurea as compared to DPP-4 inhibitors and thiazolidine-dione. And the net results are that second-line sulfonylurea for glucose lowering are unlikely to increase the cardiovascular risk or all-cause mortality. Sulfonylurea are cost-effective and have widespread use and should remain part of the global diabetes treatment portfolio. Here we find that pleiotropic benefits of sulfonylurea are also highlighted. They have well-established shades of green in the form of immunomodulatory, anti-inflammatory effect. So modern sulfonylurea like glimepiride exerts antioxidant, anti-inflammatory effect by decreasing high-sensitive CRP, interleukin-6, interleukin-34, and TNF-alpha level in our patients. Glimepiride improves the insulin sensitivity, increases glycogen synthesis, and inhibits gluconeogenesis. And on right side, you can see that there are emerging shades of green in the form of improving adiponectin level, which is a good hormone in our body, which counteracts metabolic syndrome, and it also improves the testosterone level, because we know that in long-term treatment with diabetes, you have testosterone levels which are reducing. It also reduces triglyceride, total cholesterol, and LDL. and it also reduces VEGF and improves anti-pro-BNP, indicating that there are some benefits rather than any concern. Here in this study, they looked at comparison of dapagliflozin with glimepiride, and they wanted to look at aminopeptidase and interleukin-34. And the conclusion of this study was that both glimepiride and dapagliflozin significantly improved glycemic control and insulin resistance as indicated by HOMA-IR and anti-pro-BNP. And glimepiride has a significant effect on interleukin-34 and not in IRAP. So again, indicating the beneficial effect of glimepiride. So modern sulfonylurea, like glimepiride, is having flexible action. And here we find that used in comorbid conditions, modern sulfonylurea are preferred over conventional sulfonylurea in patients with diabetes and cardiovascular disease. They are having grade A and evidence of level 1. And then you, of course, you find that they are having newly diagnosed long-standing long-standing diabetes. You can use them. Use in special population, combination of this modern sulfonylurea can be seen in elderly patients. Sulfonylurea in combination with other drugs can be used in Ramadan with some modification of time and doses. And in overweight and obese patients, it is also useful in monogenic diabetes, those where we have MODI like MODI 1, MODI 4, MODI 3. These sulfonylureas are very effective. Many times we shift the patient from insulin to these sulfonylureas. And then, of course, type 2 diabetic patient, even when they are elderly, and if you are giving sulfonylurea in milder doses carefully, then they can be tolerated, even patients of 90 years of age. So another important point is that sulfonylureas like glimepiride can be used with most of other anti-diabetic drugs like Pioglitazone, like alpha-glucosidase inhibitors, like SGLT2 inhibitor like DAPA or empagliflozin, etc. And with DPP4 inhibitors also. And even people are using them with insulin therapy. Like most of the time when patients are on basal therapy, they are already on sulfonylurea metformin combination most of the time. And then, of course, when you shift the patient from basal to twice-a-day mixtures, even then many times people are continue to use sulfonylurea with metformin. So the efficacy-wise, if you see clinical evidence and practice-based guidelines of the utility of basal insulin combined oral therapy, that is combination of metformin and glimepiride, here again, they say there is a synergy of action of glimepiride and metformin combination with basal insulin. They reduces hypoglycemia, weight gain, and cardiovascular profile. So combining basal insulin to oral therapy like glimepiride plus metformin appear to be having a very effective, you can say, thing of lowering insulin doses, requiring frequent insulin, you can say insulin injections, and they are also not causing significant weight gain, and they do not cause hypoglycemia here. So emerging, again, green, you can say emerging green, you find that the prevalence of clinical features in MODI patients, as we discussed, that patients who are having monogenic diabetes, like having defects in HNF1 alpha, HNF4 alpha, and ABCC8, these are the monogenic diabetes where patients usually were put on insulin thinking that they are type 1 diabetic patients. But once we go for genetic testing and identify these defects, then we can shift them to sulfonylurea like glimepiride or glibenclamide. So here you find that there is a position of sulfonylurea in current era. This is a review of national and international guidelines, and they say that sulfonylurea continue to play a vital role in the management of our type 2 diabetic patients. Majority of the international and national guidelines reviewed suggest newer sulfonylurea like glimepiride as a second-line drug. And if the patient is not tolerating metformin, sometimes we even give it as a first-line drug. And glimepiride are having efficacious, comparatively less expensive, associated low risk of hypoglycemia, and hence, despite the continued advent of newer glucose-lowering therapy, sulfonylurea may still be the ideal pharmacological treatment choice in our developing countries. And as we discussed earlier also, that today is the era of combination drug. Most of our patients because of progressive nature of diabetes require combinations. So patient may be on SGLT2 or DPP4 inhibitor, but adding sulfonylurea with metformin is a very good options there. So here you find the international guidelines like ADA, IDF, SPED, again highlighting nice guideline. WHO, ESD, and ACE guidelines are again telling us that sulfonylurea are useful drug. You may be using them as a second line or third line agent. Sometimes these patients are not tolerating metformin, so there you can use it as first line drug also, and they can be combined with most of the other anti-diabetic drugs. If you go for another large number of these country-wise guidelines like Canada, Colombia, Australia, etc., Korea, China, and of course in India, RSSDI guidelines, again, all these guidelines are telling us that sulfonylureas are still very important armamentarium in the management of our diabetic patients as a second line agent, as a third line agent. And if the patients are not tolerating metformin, sometimes we use it as a first line agent also. So in this great randomized clinical trial where the aim was to evaluate kidney outcome in the glycemic reduction approaches, and they looked into what is the effect of glimepiride here. So there was no significant difference in kidney outcome, which was observed during the 5 year of follow-up of these patients who are on either DPP4 inhibitors or sulfonylurea or GLP-1 or SGLT2 inhibitor, indicating that all these drugs are very good drugs in this type of patients. Dear friends, there is a concept of maladaptive anabolism and predominant catabolism. So we categorize our patients of diabetes according to whether they are gaining weight, developing obesity, where high insulin resistance is there, or they are losing weight, they are thin, cachectic, and there the main problem is significant insulin deficiency. So here you find that sulfonylurea is acting as a fulcrum. It can be used in other therapies which are anabolism, and those who are catabolic in nature, you can combine sulfonylurea in them and you can get very good results. So it is in the center of the fulcrum. I think this slide was greatly highlighted by Dr. J.J. Mukherjee, but here I want to highlight one thing, that in addition to newer drugs like SGLT2 and GLP-1 receptor agonists, we have to sometimes look at what is the control of our diabetic patients. And in that, if you look at high potency, you find sulfonylurea is mentioned here. Again, in ACE guidelines, you find that these are the patients who are not able to afford costly anti-diabetic drugs, and access to these drugs like Pioglitazone and sulfonylurea are considered to be good because they are economical. So the 7 shades of modern sulfonylureas like glimepiride is that they are having sweeping experiences, sufficiently available, subliminally affordable, superiorly effective, safety is there. They are also cardiovascular safe, splendidly acceptable, and surprisingly researched. So long duration of experience is there. So we must never forget that 80% of people in diabetes are living in lower or middle income countries. We need a medication that are effective, affordable, available, acceptable, and having minimal adverse side effects. And in that scenario, modern sulfonylureas like glimepiride comes in our mind. And important thing is that we have to be using these drugs, starting with a lower dose, gradually increasing, advising the patient dietary modification, and telling him or her that what are the signs and symptoms of hypoglycemia and how to avoid them. So in the end, again, I will repeat the same thing, that the modern sulfonylurea like glimepiride is a green swan of oral anti-diabetic drugs with guiding light, incredible speed, with grace, with great trust, flexibility, and elegance. We can use sulfonylurea like glimepiride in large number of our patients. So let's take a small step towards making the change. Go green planet. And here we have a green drug in the form of modern sulfonylurea. I think I should stop here. Thank you very much. If any questions, I will be happy to answer. Thank you, sir.
Kindly wait for some time. Lot of questions will come.
Okay.
Because the way you have described the sulfonylureas, now they stand a very strong position with the clinicians. So Srikant, you can call me to give a talk.
Thank you, sir. I again invite you after a lucid presentation by Dr. Sharma and defending about sulfonylureas, how they are leading the way in Indian anti-diabetic. Now, Dr. Kanugo, the fulcrum of this NUCD, is going to present. He is a managing director of Kids Hospital and the organism, the backbone, the main strength of this NUCD conference. I invite Dr. Kanungo for the topic of Dr. Barua. This is insulin aspart biosimilar paving the way for the accessible diabetic care. Dr. Kanungo, please.
Thank you, Srikant. Just a minute. I'll just share my screen. We have discussed today by JJ that dapagliflozin has stormed the market. That is just possible because the price was reduced and the innovator like molecule came to the market. Similar thing is going to happen in insulins also, has already happened. These biosimilars of insulin are going to storm the market and get a lot of benefit to the poorer people, those who cannot afford original. And if you look at the insulin story from Joseph von Mering, who recognized that removing a pancreas can cause diabetes. Then Himsworth in 1936 recognized insulin resistance in type 1 diabetes. Benting and Best in 1921, they really discovered insulin, and with MacLeod and others. And David Godel, he used E. coli for the recombinant production of insulin in 1978. So, if you look at the evolution of a therapeutic breakthrough of insulin, you can see from 1922, where a commercial thing was, the first was 1923, commercial insulin was available, until 1990 to 2000, you can see recombinant urine was insulin was in 1980. Then 90 to 2000 saw a lot of changes like insulin, detamir, degludec, all those things started coming. Insulin aspart and new things. And after the new generations started coming now, like IDEG, IGLAR, and other Ultralente, and IDEC Lira, and inhaled insulin have also come. And many things are coming in the future also. And they will change the scenario of insulin use in this country. So like coming are once a weekly insulin, oral insulin, liver preferential insulin, glucose dependent insulin, and beta cell replacement. These things are going to change the way we have been handling the insulin therapy. But here comes a good news. India's unique opportunity and important responsibility as the pharmacy of the world. We can see that a team of very dependable developers and promoters have now started producing the biosimilar of insulin aspart or Novorapid's biosimilar. What is a biosimilar? Providing the 3 A's of insulin like affordability, availability, and accessibility. Access to affordable insulin is critical. Insulin products like insulin glargine, Lispro, aspart play an important role in the treatment of type 1 and type 2 diabetes. Biosimilar and interchangeable biosimilar products have potential to reduce healthcare cost similar to how generic drugs have reduced cost in oral drugs. Biosimilars marketed in the US typically have launched with initial list prices 15% to 35% lower than comparative list prices of reference products. This is very important. So what is a biosimilar? Biosimilar is similar nature to reference product in terms of quality, safety, and efficacy. Biological product is highly similar to reference product. No clinically meaningful differences between the two. Similar biotherapeutic products is a biotherapeutic product that is similar in terms of quality, safety, efficacy, and already licensed, and has been proved by MEA, US FDA, WHO, and DCGI. A similar biologic product is that which is similar in terms of quality, safety, and efficacy as per DCGI. So based on comparability. So requirement for a biosimilar is many. We can touch upon like primary structure, higher order structure, product variants, metabolic activity, immunogenic activity, and purity has to match shoulder to shoulder with the innovator. And if you look at biologics and biosimilars, you can see the manufacturing is almost same in manufacturing, immunogenicity, regulation indications, potential for patent licensing, potential for exclusive period, and potential for interchangeability is there, but licensing biosimilars do not have potential for patent licensing, and potential for exclusivity period is not there with biosimilars, whereas that is 12 years for biologics. Here is a name, very important now in the Indian diabetic scenario: insulin aspart injection, Insuquick, the power of choice, 100% made in India, the first biosimilar insulin aspart in India. 100% indigenous and robust technology, global quality in products, processes, and dossiers, global standard, clinically safe, and efficacy trials. This has passed all. The CGMP production facility is there, good manufacturing practice, strong intellectual property portfolio for value creation. Insuquick or insulin aspart is meeting all these criteria and preconditions. So first biosimilar recombinant insulin aspart was given approval in the year 2021 by DCGI. 2021 it has been approved, but recently it was launched. First biosimilar insulin aspart in India or Insuquick has a fingertip as if thumbnail impression like processes, establishes quality biosimilarity of its products by characterization with fingerprint-like similarity using several advanced technologies recommended by global regulatory authority, like in primary structure, higher order structure, biological, purity, and impurity. Everywhere it is matching, and it is one of the best products now. If you look at the global standard of clinical safety and efficacy trial, GCP compliant and EMA compliant clinical studies, statistically significant and meaningful clinical trial sizes, the pharmacokinetics or PK, it has been compared with Novorapid in orange and Insuquick in blue. And you can see they match shoulder to shoulder everywhere, all as if the same molecule. And also clinical trials pharmacodynamics has been seen, and it has been compared with Novorapid to Insuquick, and you see the pharmacodynamic also is matching so concurrently with Novorapid. So this is a true replacement of Novorapid when needed. The first biosimilar insulin aspart in India, that is Insuquick, is strong IP portfolio for value creation. IP portfolio or patents at Biogenomics, India, PCT, Europe, US, Malaysia, and Singapore. So international intellectual property right and patent cooperation treaty is in place. Innovations covers super vectors for mammalian and microbial expressions, codon optimized gene sequences, protein folding technologies, novel purification and isolation technologies. So, what is the significance of evidence? Residual uncertainty, stepwise approach to generate quality of evidence, and additional clinical studies for establishing product safety and efficacy is still underway. So, you see physiochemical and biological characterization is established, preclinical studies are established, clinical pharmacology PK/PD study is established, and studies are still going on to prove that this is a safe insulin, effective insulin, but still some studies are going on. Stepwise approach for biosimilars development program is always there, like any extensive structural and functional quality determination, biosimilarity, animal toxicologic studies, phase 1 human clinical study like PKPD, phase 3 human clinical study like interim comparative safety and efficacy, and then only marketing authorization is available to market the product. Once these criteria are met and it is proved to be a safe and effective biosimilar, then only the permission is available. As we discussed earlier, structural characterization of insulin aspart, analysis of primary, secondary, tertiary, and quaternary structural attributes using orthogonal spectroscopic tools, and it came out to be successful. Structural analysis of Insuquick has been done in primary structure, secondary structure, quaternary structure, and tertiary structure. And this proves a peptide formed under non-reducing conditions and peptide formed under reducing conditions have been compared, and the molecule has proved to be one of the best till now. These are all little technical diagrams, not we'll discuss later, but it proves that spectra confirms high similarity between BGL ASP and reference product. So spectroscopy and other things have been done, and the reference product and this Insuquick molecule, they prove at par. NMR studies have been concluded like 1D, COSI, TOXI, NOISI, HSQC, spectrum acquired during NMR study for BGL aspart and reference, and the product are identical to each other in solution state at molecules at atom to atom 3-dimensional structural levels. So this is comparable and strongly suggests structural similarity of primary, secondary, and tertiary structures. Physiochemical characterization has been already studied, like impurities have been worked out, and there is very little impurities in this. This is a very, very pure product. And also physiochemical characterization of Insuquick has been studied vastly. Assay content and related impurity content and HMWP content are found to be in compliance with identified biosimilarity limits, which are more stringent than Indian pharmacopoeia specifications. In excipient analysis, phenol, M-cresol, pH, and zinc content are found to be highly similar, but the reference and Insuquick batches in stability studies, Insuquick is stable for 30 months at 2 to 88 degrees centigrade and is found to be highly similar. This is a great study, and this gives a lot of confidence to the clinical physicians to prescribe the product. So biological characterization of recombinant insulin aspart. So this is also there. Insulin bioassays have been proved. It measures affinity of insulin for insulin receptor, measure for phosphorylated insulin receptor, glucose uptake, lipogenesis, inhibition of lipolysis, and mitogenesis cell proliferation have been studied and estimates mitogenic potential in cells, and they have got all good result. In vitro biological characterization of recombinant insulin aspart from biogenomics and originator insulin aspart has been studied, and a paper by Misra et al. They suggest that the binding studies showed that the affinity of BGL aspart was highly comparable to novorapid, insulin receptor, autophosphorylation, glucose uptake, and lipogenesis demonstrated high similarity to the RMP. The mitogenic assay for BGLAS did not show any proliferative effect and was comparable to the RMP. The in vivo bioidentity test showed that BGL aspart is highly similar to the innovator novorapid. So conclusion of in vitro biological assays has been done, and extensive biological characterization demonstrates a high degree of functional similarity between the biosimilar insulin aspart from biogenomics or Insuquick and reference innovators product. These are all detailed studies. Preclinical animal toxicology studies comparatively established in extensive preclinical and animal studies was done. Then product development program took a long process comparatively in human phase 1 PKPD glucose clamp study to show biosimilarity of insulin aspart to reference product. Pharmacokinetics and pharmacodynamics was studied. Phase 3 clinical study design was very robust, and it efficacy, safety, and results were proved. In a 24-week administration of Insuquick and reference product were comparable and equally effective in lowering HbA1c, FPG, PPG, and type 2 diabetes in type 2 diabetes patients. So the study concluded that established similarity in between reference product and BGL aspart in reduction in immunogenicity and neutralizing antibody assay proved absence of neutralizing antibodies in positive clinical samples. So there have been so much publication of Misra et al. In endocrinology and investigations in 2023, which says comparative assessment of immunogenicity of recombinant insulin aspart from biogenetor novorapid in adult patient with type 2 diabetes. Immunogenetic studies for Insuquick has been studied, and the endpoint was to compare immunogenicity of recombinant insulin aspart manufactured by BGL with a reference product by measuring antibodies at baseline, end of 12 weeks, and end of 24 weeks. And the baseline 3 months and 6 months was studied. Quick check for antibodies against insulin aspart. There was no. If key question, are these antibodies neutralizing in short? Do antibodies affect efficacy of drug? So that was found out, and during all those things, it was found it was comparable, and incidence of detectable antibodies was found during visit 8, 21. Patients show immunogenicity immunogenicity, and immunogenic response showed by these patients was very low in terms of antibody titer. So serum samples analyzed for neutralizing antibody assay was studied. During visit 8 and 21, patients show immunogenicity and immunogenic response showed by these patients was very low in terms of antibody use. Average glucose consumption of patients who received reference product as treatment was in range of 80.34 to 83.48, whereas patients who received Insuquick aspart was in the range of 80.27 to 82.63, better result. So these are the two devices that is used, USB pen, straight USB pen. It is a reusable pen. You can put the cartridge of Insuquick and this can be used like any other pen and a reusable pen. And the disposable pen name is Insuquick VD pen, and this can be disposed and it contains the product Insuquick, and this is easy to use. Both the pens are very easy to use. So successful marketing authorization from DCGI, CDSCO as fast biosimilar insulin aspart in India has been obtained. Impact of Insuquick on diabetes management in India is it is more cost effective option, making diabetes management financially acceptable to a wider population, and reduce expenditure on diabetes care due to affordable insulin options. Access to effective and affordable insulin plays a key role in reducing complications associated with diabetes, enhancing the overall public health scenario in India. So, thank you, dear friends. Now we'll go to the panel discussion. So this is a very important panel, and we have so many panelists are there. Dr. Sharma, Dr. JJ Mukherjee, Dr. Bipul Chaudhary, and I should be a panelist also because I was giving a talk. So Dr.
You can't cheat. You can't cheat. You can't be the bowler and the batsman together.
At least when you are there, it is difficult to do anything. So we discussed three important things: dapagliflozin, sulfonylurea, and insulin aspart, that is Insuquick. So I would like to ask to Bipul, welcome to this meeting, that based on your experience, what is your opinion on the efficacy and safety profiles of biosimilar insulin compared to their branded counterparts in long-term diabetes management? And I will like the suggestion from both JJ and Sarmaji.
Good afternoon to all of you. I'm audible, sir?
Yes, yes.
First of all, thank you, Kanungo, sir, for including me in this panel. Regarding biosimilar insulin. So you have already highlighted that it is as good as the original molecule, original aspart. And it is the first time USB has come up with this rapid-acting insulin. But we already have been using long-acting biosimilar molecules for quite some time. So this short-acting new biosimilar aspart will be as efficacious as the original molecule. That is what I feel, and I have used it in very few number of patients only. As of now, I can only say that in due course of time, more data will be able to get. Regarding long-acting biosimilars, yes, it is as good as the original molecule. And I think those who have used it more, they'll be able to give you more insight.
Thank you. JJ, your opinion?
I mean, I have not used much this new product. I mean, but my answer is just like any general answer to any biosimilars. As people was mentioning, we have been using insulin glargine biosimilar for quite some time now. This Insuquick, the shorter acting regular rapid acting insulin is quite new. I mean, the same thing about biosimilar insulin. I mean, when they do a trial, I think the things are very nice, hunky dory. But then in real life, so we will need a little bit more real life data, real world evidence as to how they are, storing the insulin, how it's being transported, how it is being maintained. Because when you are dealing with an innovator insulin, you inverted commas kind of guaranteed that those things will be maintained. So just showing in the trial that they are equipotent, they are getting good glycemic control, similar glycemic control probably is not good enough. But as you said rightly, we all have to use it in some of our patients, and then we will start to gain some more experience and confidence. The only reason to switch from an innovator to a biosimilar is basically cost reduction. Now, I think I missed some part of your talk because I had a very complicated patient I had to dash out. So cost-wise, if you can just tell me how much is the cost difference between the innovator aspart and the biosimilar aspart?
Presently, maybe 20%.
So that's not a huge difference. I mean, of course, people who are say on 60, 80, 100 units of rapid acting insulin, I have some patients on 60, 80 units per day. There probably it might make a difference, but many of our patients are on say 12 or 10 units thrice daily. There I think probably the cost difference is not much. The other thing is we all use aspart in pregnancy. Now I don't know whether how confident you would be in using the biosimilar during pregnancy. I mean, that's an open question to I think all three of you. What is your opinion on that?
Sarmaji?
I think because the immunogenicity was also looked at in this study, so probably there will not be any problem there. So I have started using it in some of my patients. Of course, the experience is very little as compared to the innovator. But I do find good results here, similar results. And the cost-wise, there is some benefit to the patient. And as you rightly highlighted, if the dose is higher, then the cost matters. If it is to be given in young type 1 diabetic patient where you are using 5 units, 10 units, something like that, then the cost is not really matter. But the pen is also of good quality. So the disposable pen as well as the other things are also equal. And this is coming from a good, you can say, pharmaceutical house. So probably we expect good services in the form of maintaining temperature, etc. So our confidence of that pharmaceutical is there for the last many years. So we expect that they will be managing things rightly. Thank you.
I started this Insuquick with my OPD patients first with a lower dose without knowing the potency and other things. I got very good result. Then I started it in using indoors and where we can monitor 7 times, 8 times daily and infusion pumps and even CGMS we use. So we found the molecule is equipotent and rather uh, very effective. In the second day itself glucose is getting controlled. Then we change it to ICU also, and there also we are getting good result. So quite a few experience of course, but in 3 stages I have used it and I am satisfied with the quality. I don't know the safety, not yet. It has to be there, but efficacy is that I can say is very good. So my second question is, uh, what should be the patient education strategies for those transitioning to or starting on biosimilar insulins? Dr. Sharma.
Well, once we are transferring patient from original to the biosimilar, most of the time we are using the similar type of doses because you are just changing the pharmaceutical company and we expect the similar potency wise. So we don't reduce or increase the doses. And then of course, titration is very important. Once you start titrating, then you identify whether patient requires some up titration or down titration. But most of the time we give the same doses. Thank you.
One positive point with this brand is possibly that this company has larger network of
Absolutely.
representatives, chemists, and countrywide. So people will possibly get it at their doorstep or near their house, and that is one hope from this. Like when
Absolutely.
Lupin took over Lilly's products, it was much more available
Yeah.
because of their strong market presence. So that is an
Absolutely.
additional thing in this case.
Many a time
JJ,
our patients, when we write these original product in the smaller village, they are not available. So there is always a phone call that that type of insulin is not available. I hope this will not be there once we have this insulin.
this will be a better available product. Let
Absolutely.
us hope so. JJ, what are the main barriers to adopting newer drugs like dapagliflozin in lower income countries, and how can they be overcome?
Very loaded question. Huh? So the barriers in lower income countries, see, when the innovators came, obvious barrier was number one, cost. I mean, when dapagliflozin, the innovator came, that it cost initially 40 to 50 rupees, and came down to 30 rupees. Same with the empagliflozin. The second thing, as I showed you, if you saw my second last slide, even now in US, the percentage of people who are getting SGLT2 or GLP-1 is a meager 8 to 10%, which is very surprising, despite we have been screaming from the rooftops that you should be using SGLT2 for people with ASCVD, heart failure, etc. So I
As
think
a first line drug.
the second reason I think is probably lack of dissemination of established knowledge. The knowledge is there. I mean, I think one famous person, I forget whose name is, I name some professor, I don't want to, somebody had said that by the time you get a randomized controlled trial data, and by the time that gets converted into day-to-day use, there's a gap of a decade, you see. But a decade has already happened with SGLT2s. It's since 2015, and now we are 2024. Even now, it is so surprising to see such minimal use of SGLT2 inhibitors. I mean, we don't have data from our country. I have a feeling probably we are doing better than US in use of
Definitely.
SGLT2 inhibitors,
Definitely.
because we have the what you call generics, and I think our dissemination of education probably is better than the dissemination of education in US, because I think our CMEs which we do, we penetrate to tier 2, tier 3 cities also. And I'm happy to say, at least in West Bengal, when the patients come to me, I'm quite surprised to see that quite a few of them are on SGLT2 inhibitors. So first reason was cost. Second reason was lack of dissemination of knowledge. And third, I think sometimes GPs hesitate because I think GTI is an issue. No matter how much you want to put it on the carpet, we can't, because it's not 1%, 2%. Quite a fair person people get GTI. And this is one point, if I don't know how many people are listening, I would like to tell people that please mention about GTI, because I have seen people coming with phimosis, living with phimosis for months together while on SGLT2 inhibitor, and then telling that nobody told them that if they had recurrent GTI, they should have stopped this medication. So I think that's probably the other reason. And the fourth reason which prevented GPs from prescribing it was when this noise about euglycemic DKA came. But that I think has probably settled down to quite a large extent now. Dr. Sharma, you want to add something more to this?
Like you said, 2 cases per 10,000 of euglycemic decay is a very low figure. But you are right that probably in Indian context or in our Rajasthan also, we have seen large number of patients are on SGLT2 inhibitor by physicians. And the cause, as you rightly highlighted, maybe a generic version, economical version. And we have so many pharmaceutical companies coming out with these different combinations also. So people are using this combination left in and left right. So that's why a large number of patients are on as compared to West.
Dr. Chaudhary, your opinion, please.
At times, at times I feel the patients, they themselves are happy with good glycemic control. If they are well controlled with some, this is about those with lower income group, I say that if they are well controlled, glycemic control is good with, say, any sulfonylurea and metformin, even if we counsel them, it may be a barrier. It may be a barrier that you will have benefits over a long period of time. The cost will be slightly more than that. But the patient itself, because patients are empowered, we have to take their view also while advising the treatment. So maybe that may be a factor. That is my opinion. Otherwise, all the things have been discussed.
Education of the patient is very important, sir. Once we prescribe these, we have to educate the patient that you will develop these genitourinary problems. So you have to take care of genital hygiene, pelvic hygiene, and take 2 glasses of extra water, something like that. And if you have problem, immediately inform us. These 3 things we are informing. Yeah.
JJ,
yes, sir.
What are the clinical considerations for selecting an SGLT2 inhibitor like DAPA over GLP-1 receptor agonist in individualized patient care?
Sir, see, if it is established atherosclerotic cardiovascular disease, then I think both the molecules have got sufficient data. If you take dapagliflozin, empagliflozin, versus if you take the 3 or 4 GLP-1 RAs, not all of them have got cardiovascular 3P MACE data, but liraglutide, semaglutide, dulaglutide, they have. But if you come to hospitalization due to heart failure, prevention, or treatment of heart failure, now SGLT2 inhibitors are in one of the 4 pillars of treatment for heart failure. Here, SGLT2 inhibitor like dapagliflozin clearly beats GLP-1 RA. I mean, the same amount of data with empagliflozin as well. Now, if you come to CKD, somebody with chronic kidney disease, with proteinuria, without proteinuria, with diabetes, without diabetes, here SGLT2 inhibitors again are definitely much ahead than GLP-1 RAs. With GLP-1 RAs, we have small data, and now probably a big bang data is going to come with semaglutide. That trial has just been stopped early. We don't know what it exactly showed, but must be positive. Otherwise, they wouldn't have stopped the trial earlier. We are waiting for it to be presented. Yeah. But even if it's presented, I don't think SEMA will eat so much into the evidence that SGLT2 has in renal protection. So if you take people, if you take type 2 diabetes, people with heart failure, CKD, or people above the age of 55 with 2 risk factors for ASCVD, the SGLT2 inhibitors will score over GLP-1. But I always, you heard my talk, sir. I always say why A versus B. I think it's A plus B. If somebody can take GLP-1, he can easily take an SGLT2 inhibitor along with. If somebody cannot take a GLP-1, then the debate does not exist. So I think there's no debate between SGLT2 and DPP4. If somebody can take GLP-1, add SGLT2. If they can't take GLP-1, what's the point? They can't take it. So I give SGLT2. Over to you, sir.
Dr. Sharma, how can clinicians effectively manage the dual burden of hyperglycemia and obesity in diabetes care with the current therapeutic options?
Well,
hyperglycemia and obesity.
Yeah. Earlier, our main emphasis was on hyperglycemia, but then we realized that gaining weight will nullify the benefits of good control. And recently, with the GLP-1 receptor agonist and dual agonist now available, and now people are started, you can say, doing research on triple agonist, like adding glucagon also. Large amount of weight loss is there, and that you can say reflect into glucose control also. So we have trials with semaglutide where there is a very good reduction in HbA1c as well as weight. Then tirzepatide is a molecule where you find that large number of patients were having HbA1c to the tune of something like 5.6, 5.7. And they are losing something 10 to 15 kg of weight. And then comes this triple combination, which is again causing something like 15 to 20 kg of weight loss. So now people are arguing that looking into the efficacy of a drug, it should be HbA1c reduction and weight reduction to be looked together. And if added advantage of, let's say, cardiovascular benefit and renal benefit and hospitalization for heart failure benefit, that will be an added advantage, or you can say pleiotropic effects. Thank you.
Diabetes is occurring in 10 to 12% people. Out of them, less than 50% are obese. and we are discussing everything about those 4-5% people. There are so many obese people in the population without diabetes. So how do you think our this discussion is going to help those obese patients?
There are two answers. One is, although our BMI may not be very high, but we are having abdominal obesity or our adiposity is high. Secondly, large number of these drugs are now also used for the weight reduction. So you find that I think most of the utilization of these drugs are in obesity now as compared to diabetes management, because it is now short in West also, because people are not able to get it, because misuse, you can say, or excess use by obese persons are there with these group of drugs.
Dr. Sharma,
Sir.
now there is a lot of discussion about diabetes remission, reversal, and all those things.
Yeah.
And the emerging data also speaks a lot of things about remission. So how can it is going to influence the approach to type 2 diabetes treatment and patient education?
Well, we are now wiser enough to advise in our overweight and obese diabetes who are newly diagnosed or having a short history of diabetes, that if you will reduce your weight by significant caloric restriction, then there is a good chance of reversal of diabetes, because as we look into twin cycle hypothesis, we find that this is the excess of calories which starts the problem. The calories are deposited in the form of fat in liver, and then there is a ectopic fat deposition in tissues like pancreas, and then all the problem of this insulin resistance and decreased insulin secretion occurs. So if direct trial is telling us that if you can significantly reduce the weight by caloric restriction, particularly in overweight or obese patient, newly diagnosed patient in the form of 2 to 4 years or so, and if they can reduce their weight by 15 kg in next, let's say, 3 months or so, the probability of reducing or remission of this diabetes is significantly high. That is important. So now in newly diagnosed patients, we always advise this type of concept. Half of our patients take it, half of them, they say probably they will not be able to tolerate that low calories of 600 calories or so.
Thank you, Dr. Sharma. JJ,
yes, sir.
What are the challenges and opportunities in the management of diabetes in elderly population with the advent of newer drugs? There are a large number of people, 60 plus, 65 plus, and how do you think opportunity and challenges in treating them, their diabetes?
I think up to 75, everything remains same. I won't have any different approach below 75. So above 75 also, then I will go for biological and chronological age. There are people above 75 who are very fit. So by age, I won't. I will go by the frailty, how frail the person is. So the challenges are frail people. They have higher risk of hypoglycemia. They have higher risk of sarcopenia. They are osteoporosis. They have a higher risk of fall. So when you're treating frail elderly people, your main aim is not a very tight glycemic control. HbA1c we relax to 7.5, 8 up to 8.5 we can relax. Second, choose drugs which do not cause too much of weight loss, because most of the times the weight loss which happens is, at least with SGLT2, there is some degree of sarcopenia as well. So if you don't want that. Number three, you don't want to use a drug which can increase the risk of hypoglycemia. So in the elderly people, I would rather choose, and the fourth thing you have to keep in mind is the GFR, you see, because a creatinine of 1.6 in an 85-year-old can mean the GFR is below 30. So you have to calculate the eGFR. So my choice for elderly people would be a metformin if I'm allowed, if GFR is more than 30. With, I would choose probably a DPP4 inhibitor over everything else. Cost is probably not an issue. Then probably I would be happy to use a metformin and a GLP-1 receptor agonist. If they do not have much of a GI effect, I would be rather happy to use a voglibose and an acarbose in this group of people, because there's less hypoglycemia in these people. Sulfonylurea, SGLT2 inhibitors, yes, we can use. But at the age of 85, what am I trying to prevent? What kind of cardiovascular disease or death or renal impairment am I trying to prevent? Because all these trials, if you see, they were minimum 2.5 to 3 years duration when you begin to see those benefits. So my simple answer, go easy, have a relaxed HbA1c reduction, be aware of hypoglycemia, be aware of sarcopenia, be aware of osteoporosis, pioglitazone is out, be aware of renal function. Don't get caught out by a creatinine of 1.8 in a 85-year-old lady where you end up giving metformin. I mean, we can continue. There are so many other aspects of elderly diabetes that we can discuss. These thoughts come to my mind. I think Dr. Bipul or Dr. Sharma want to add something more.
Polypharmacy and drug interaction is another important point there.
And be aware of hyponatremia.
Hyponatremia, yes.
Hyponatremia is one of the biggest killers, and morbidity is very high with elderly people with hyponatremia.
But diabetic drugs do not cause hyponatremia. None of the diabetic drugs will cause it.
SGLT2 has some
diabetic drugs, sulfonylurea. I think
no, sir.
sulfonylurea
SGLT2 will cause natriuresis, but they will not cause hyponatremia per se.
Most of them are having H preparations like hydrochlorothiazide or chlorthalidone, then things deteriorates.
Sir, I feel glimepiride in some patient causes hyponatremia. There are few
those patients stop eating. Some elderly patients stop eating. As a result, they also take less sodium. So that is the cause in such patients. And our last question, because Professor Panda has already come. So, Bipul sir, what strategies be implemented to improve adherence of diabetes medications, particularly with treatments that have to be given more frequently?
First and foremost would be patient education.
Agreed.
If the patient has to be given a frequent medication, they have to be explained why is it given. To have an result, the patient must understand that he has to take medication timely to get the proper result actually. That is one. And basically counseling and frequent, maybe if we give medications which are to be given more frequently like insulin multiple dose, they should be called more frequently also. That is what I...
Thank you. Thank you, dear panelists. Excellent discussion, excellent talks. And what we could learn from this session, that we have a new biosimilar insulin aspart, which will be available with the most important, one of the most pharma company which has access to almost all parts of the country, and it will be affordable. And quality wise, Insuquick comes no inferior to Novorapid, the comparator that has been in multiple studies. It has been proved, and a dose to dose titration is similar. Taking 10 units will take 10 units from this, and hypoglycemia and other factors are all same as the innovator. Dapagliflozin is a drug of choice after the price is reduced. Dapa and its brother sisters like Dapa with Vilda, Dapa with Sita, Dapa with metformin Vilda, Dapa with metformin Sita, and things. They have now a big giant family, and it's so difficult to remember all their names like our cousins. But they are all good products, they are economical, they are cheap and available. And the third thing is our SGLT2 we discussed, and everything that we covered.
Sulfonylurea. You forgot sulfonylurea.
I was remembering that sulfonylurea because I posed that as if I am forgetting. So sulfonylurea is my heart. More than 1 lakh patients are on sulfonylurea. Maybe 1.5 lakh patients are on sulfonylurea in my registry. And I get them the best result that I am getting. They are best in euglycemic effect. There is no side effect. If the driver is driving Mercedes and he is not adequately trained, he will hit the Mercedes. But a small Maruti with a good driver can go safely to Rajasthan and reach Dr. Sharma from Bhubaneswar. So that driving and dose control and management skills are very, very
Education.
important in is a physician's forte, and he can do that. And sulfonylureas are going to stay in India and Indian subcontinent for decades to come, because they are, how many people are still taking downhill when nobody is prescribing? Large number of people. It is the patient that who gets benefit, not the doctors. So if patients, as long as they are benefited, they will continue the product, and doctors will also continue the product.
Absolutely.
So sulfonylurea glimepiride remains the uh, real stronghold in the armamentary of drug management in diabetes. Thank you, dear friends. I was given time up to 3:45, and we have just concluded in 3:45. I thank Dr. Dhar for being my co-chair, and things have taken a nice place. See you next year.
Thank you, sir. Thank you for the
Thank
opportunity.
you.
We had a
Bye.
good time.
Thank you.
Always a pleasure to be with you, sir. Thank you.
Thank you, USB, for organizing this workshop and seminar with a unconditional academic grant. So we are thankful to USB and Team USB. Thank you.
Thank you, sir.
Bye,
Dr.
everyone.
John, please take over your session.
Dr. Vildagliptin has joined. I don't think Dr. Lalatendu Mohanty has joined. So
I saw him.
It's a pleasure
I saw him sometimes back, but
inviting our
he will join. You can
faculties
continue.
for the next important session. First, let me do the context setting. We are very happy that very important aspects of diabetology, like the modern therapeutic approaches, the brain and diabetes, and the obesity, is already covered in these first three sessions. So in session 4, I invite you with a very important aspect of complications. My co-chair, Dr. Lalatendu Mohanty, will be joining soon. We have Dr. P.K. Shahu, who is a very prominent cardiologist of the state and the country, and an excellent speaker on topics related to cardiology, medicine, and around. And without any hesitancy, I tell he is my cardiologist of choice. He is a DM cardiology senior consultant, the interventional cardiologist at present working in the Apollo Hospital, and one of the best interventional hand and the clinical decision is of Dr. P.K. Shahu. So without much delay, because Dr. Shahu is here, we present you Dr. Shahu for the very important topic, how to salvage a diabetic patient with acute myocardial infarction. The stage is yours, Dr. Shahu.
Thank you, Dr. Panda, and thanks to Dr. Alok Kanunga for giving me an opportunity to participate in NUCD. I think my slides are visible?
Yes, sir.
All right.
It's visible.
So, in fact, this topic of this thing, that is how to salvage a patient, it is exactly like this. Mr. Apple has an myocardial infarction. So as a diabetologist or as an endocrinologist, you cannot tell, you have to wait, Mr. Apple, at first I have to call the cardiologist. So we all are physicians, we all deal with diabetes, and naturally the diabetologist has a major role to play because coronary artery disease is a major part of our armamentarium when we treat these patients. So my topic basically is how to salvage a diabetic patient with MI. It is a very basic clinical scenario that supposing a patient with diabetes comes to you or to us, what do we think of and what do we do? Now, this is just I picked up from 2023, this revascular medicine. This is what they've seen between diabetes and non-diabetics, and they have concluded that diabetic patients present with AMI have lower utilization of invasive management, number one. Following the adjustment for baseline characteristics, have worse in-hospital clinical outcomes compared to non-diabetic patients. There are important DM type related differences between type 1 diabetes having overall worse outcomes. So this is a review of 2023 which clearly states that diabetes is really bad so far as coronary artery disease or AMI is concerned. Whatever you see in the red bars, so clearly that the diabetic patients do much worse than the non-diabetic patients so far as clinical outcomes are concerned. Now, when we see the spectrum of coronary artery disease which the patient can present, it will be acute coronary syndrome, it can be STEMI, non-STEMI, or unstable angina. These are the three entities that we come across in a patient who comes to us with acute MI. Now, what is the difference between non-STEMI and STEMI? This is a cross-section of the coronary artery. Partially occluded coronary artery is non-STEMI. Fully occluded coronary artery is STEMI. Very simple. When a patient with non-STEMI comes, you know that part of his artery is still open. But when he comes to STEMI, you know that his artery is totally closed. Now, if you try to go further, you'll see non-STEMI, there is a partial infarction, that is part of the muscle is dead. But in STEMI, the whole muscle gets damaged and necrosed. Now, how do we diagnose non-STEMI? Because it's very important. It is based on three pillars: that's angina, ECG changes, and markers. If the patient has angina and ECG changes with markers being negative, it is unstable angina. But if you've got all the three, that is angina, ECG changes, and markers positive, it is non-STEMI. So this basic concept should be very clear because the treatment of unstable angina, non-STEMI, and STEMI is different. But these are the subset of population who have a partially occluded artery. Now, we know the classical chest pain localization. These are whatever you see in the red is the classical. But peculiarly, the diabetics have various symptoms which do not pertain to all these things. And that is why they do not present with chest pain, they present just with shortness of breath, easy fatigability. And most of the times they feel that it is just gas. It is not gas or heartburn. It is something more than that. So the diagnostic evaluation basically rests on the ECG, the chest X-ray, the blood work, and the echo. Basically, we can do all these three at our end. And then ECG changes are very simple. Anything that you see going downwards in non-ST elevation MI. Anything that you see going upwards is ST elevation MI with the Q wave. So anything down is non-ST elevation MI. Anything up is STEMI. Now, this is the three types of downward changes. It may be downsloping, it may be upsloping, it may be flat. If it is upsloping ST changes, it is not ischemic. If it is downsloping or horizontal, it is ischemic. So this is the first difference that you should see on your ECG of a diabetic patient. Very important. The downsloping is something your ominous sign. The horizontal escalation is ominous. Upsloping, you can just exclude it and send the patient back home. For example, as I told you, non-STEMI, you get a partially occluded artery. You see everything is going down. Either T is going down, ST is going down, everything is going down. Now, when it's ST elevation, you see the artery is totally occluded. So everything goes up. So it is very easy to diagnose the patient based on the ECG changes. And these are what very remarkable changes which you'll get in the ECG. Now, do not be fooled if the ECG is normal in a diabetic. Do repeat ECGs after half an hour, 1 hour if the patient is complaining of chest pain. In the meantime, you'll get your blood parameters done and then you'll know, because 40% of the cases of AMI, the ECG is inconclusive. So please, this is a word of caution. You have to be very careful. Now, next, what we come is the chest X-ray. Why the chest X-ray is done is to rule out maybe a pneumothorax, maybe some other cause of pain. So you have to rule it. Then we go to what we call the blood workout. And the most important are the cardiac injury markers. Now, what are the cardiac injury markers? The earliest cardiac injury marker is the myloxyperoxidase, which is done then the myoglobin, then the troponin separate, then the CKMB comes. So this is a sequence which has to be followed. And nowadays we are doing tests which also tells us that is the IMA, the ischemic proteins, which are the earliest within as early as 0 hour you can get it. And as muscle death occurs, the troponin increases, the CKCKM increases, but this is up to 12 hours. So now we are trying to have a trend to see how we can pick up these patients with these markers as early as possible. The last one, of course, is the echo, which will give you an idea whether there is regional wall motion or not, and based on it, you can diagnose. So the diagnosis is very simple, but we have to remember you have to act fast because time is muscle. And once the MI takes place, the clock starts clicking, and the only role of the cardiologist is to open the artery, what we call as the open artery hypothesis. Now, as I differentiate two subsets, the unstable angina and non-STEMI MI versus STEMI, the treatment of both is same, excepting that in unstable angina or non-STEMI, you give heparin or low molecular heparin to keep it patent, but here you have to give a thrombolytic, either do it mechanically or you do it pharmacologically. You have to give antiplatelets, you have to give pain relief, you have to give antilipids, you have to give beta blockers, you have to AC, ARB, RD, whatever is to be given. This is the only point of difference in the two differences. Now, why do we give heparin? You see, we have got two types of thrombus. One is a white thrombus, where there is more of platelets. That's a red thrombus, which is more of RBCs. White thrombus occurs in non-distillation MI or unstable angina. Red thrombus occurs in STEMI. So that is why you thrombolize these patients. But here, because it's a platelet-rich thrombus, this crux is on giving antiplatelets and heparin. So this should be very clear about the treatment, and the ECG can only guide you how the treatment should be. So in non-STEMI, you get more of platelets. In STEMI, you get more of RBCs. Now, how do we salvage a MI in patients? First is the antiplatelet choice. Next, we decide whether to thrombolize versus a primary angioplasty. Whether what is the current status of the ancillary drugs, statins, AC inhibitors, ARBs, RD, beta blockers, and what should be the diabetes management? These are the four top headlines on which I'll be talking. Coming to antiplatelet choice, we know we started with aspirin and now are with ticagrelor since 2012. And this ticagrelor is one of the most potent drugs, and we have to start off with a dual antiplatelet, either aspirin 325 or clopidogrel 300 bolus along with 75 milligram OD to continue, or with prasugrel 6 tablets, 60 milligram and 10 OD. And if you're using ticagrelor, give 180 milligram bolus and then give 180 milligram daily. So this regimen is universally accepted and is the most important thing, excepting that when you use ticagrelor, down titrate your aspirin to 75 and do not give 150. Next, as we know, an apple a day keeps the doctor away. Similarly, an aspirin a day used to keep the doctor away previously. But now, as we see, the most commonly used or misused drug is this aspirin. There has been a lot of criticism, and now as cardiologists, we are moving away from this aspirin protocol to protocols where we don't have to use aspirin, because 40% of our patients we have seen are resistant to aspirin. So possibly we are giving drugs which should not be given because the patients are resistant. So be careful at aspirin because your patient may be resistant to it. So is aspirin having a dead end? Mostly yes, because we are moving only to a single antiplatelet and aspirin is taking a backstage. Then clopidogrel came, then prasugrel came, and ticagrelor. It was the good, the better, and the best. Now, why clopidogrel is not good? Because we have seen around 30% of patients of diabetes especially are resistant to clopidogrel now. It is only ticagrelor, one drug, or prasugrel, which is a very potent drug. We have certain contraindications which are very potent and they're useful. And the best part of ticagrelor is age is just a number. You can start from 15 years to 80 years. So there's no age. Prasugrel has age indications, etc., but definitely there's no age bar for this in ticagrelor. And if you have to see whether you're using unstable anginas, non-STEMI, AMI, what is the antiplatelet? It is ticagrelor because it is one size which fits all. So you don't have to think about it. Just load 2 tablets of ticagrelor in any diabetic patient where you're thinking that the patient is having a coronary disease or an AMI, it does work. Do not stick to aspirin or clopidogrel anymore. So if you tell what is the king Khan among all these 3 grels, there's definitely ticagrelor, which is scores much over the other 2. Now, I come to thrombolysis versus primary angioplasty. Now, when I think of thrombolysis, you will see the Brownell's first edition. What we used to do, we used to just keep the patient, give oxygen, vasodilators, morphine. 30-day mortality, 30% patients used to die. This was 1960s. Then as we moved to coronary care units, we moved to cardiac massages, we used to defibrillators, almost a 15% decrease in mortality within 30 days. Hats off to this gentleman who started thinking about this. Then we moved on to what we call as the era of revascularization, where fibrinolysis was done, systemic fibrinolysis was done way back in 1976, and patients started thinking of giving nitroglycerin and streptokinase intracoronary. Those were the days when we were doing our DM, and we used to see that our professors used to ask us to give streptokinase intracoronary. Results were quite horrendous, and definitely we have seen that age. So you have to remember, time is myocardium and time is outcome. The earlier you reach the hospital, once you suspect it, it is the most important thing. Now, why is it that it is important? Once you see what happens, within 20 minutes, within 1 hour, within 2 hours, the muscle starts dying. So our main aim as physicians or cardiologists or diabetics is send the patient early so that the artery can be opened up so you can limit the infarct size and improve the LV function. Now, whether fibrinolysis angioplasty, definitely if you see, if it is in the first 3 hours of chest pain, thrombolysis has got a much better role than primary PCI. But beyond 3 years, it is primary PCI or angioplasty which has got a major role rather than thrombolysis. So if your patient is in a periphery area where you have got chest pain within 3 hours, please thrombolyze them. The task of the cardiologist is much easier. Much of LV function is preserved. Now, what is this primary angioplasty and thrombolysis? Very simple. If your drain gets clogged, you either put a mechanical medical solution to it, that is, you give a thrombolysis to it, or you give a mechanical solution, you just take him to the cath lab and you open up the artery. It is as simple as that. So, but it is better to go for a medical solution if you are away from any of the PCI capable centers. For example, what thrombolytic has to be used? We have seen the first generation, the streptokinase urokinase, where our infusion used to take place. Then the second generation came, and finally the third generation, we are in retroplase of tenecteplase, where you can thrombolyze the patient while the patient is being shifted in the ambulance. A double dose or a single dose has to be given over 15 minutes, and the job is over. It is as simple as better. And nowadays, we mostly promote to our physicians, to everyone, that give this drug because it's approximately 15 to 20,000 cost, and the patient does a lot of benefit. Now, what is this primary angioplasty? You just quickly wheel the patient to the cath lab, balloon it out, put a stent, and see that the flow is restored. So we have clear-cut evidence that between these two, thrombolysis and PCI, definitely primary angioplasty is the best, and that has been proved in 23 randomized trials that death was much lesser when you took the patient to a PCI center and did it as early as possible. And the most interesting is that if you are using a third generation thrombolytic, you can take the patient up within 3 hours of your thrombolysis and you can open up the artery. So basically, angioplasty or opening of the artery is coronary firefighting. So as soon as the STs start elevating, you have to fight to open up this artery. So primary angioplasty, there's an end of controversy versus thrombolysis. Thrombolysis is only for the peripheral centers or the clot-busting drugs, or angioplasty is the choice which has to be given to every patient. Now, if you go along further, you see the mantra should be try to reach within the golden hour, try to thrombolyze as possible because we know time is muscle. Now, this is the sequence of primary angioplasty. Patient has chest pain, immediately you see that the ECG is okay, do not have a diagnostic delay, see the ECG, do the markers immediately, send it to a tertiary care center capable, and try to open up the artery. So this should be as fast as possible. What we tell as hospital to balloon time, it should be 90 minutes. Hospital to needle time for your thrombolysis should be maximum 30 minutes, and we keep on telling, but this is the total ischemia time, and we have to reduce it as far as possible. So all trials have showed that definitely angioplasty is much better so far as 30-day mortality, and the fight between thrombolysis and primary angioplasty is over. Now it is best that within 90 minutes, you can get the patient to the cath lab, open up the artery, the job is done. But what are the issues in primary India? Transportation, finance, PCI capable centers, Availability of trained personnel 24/7, online surgical backup. We do not look for a surgical backup these days because angioplasty has become very safe. The main cause of delay our diabetic patients do is they tell that first denial of symptoms. No, it's not angina. Oh, it's just some gas. Please do not ignore the symptoms. It is that we have to see that the delay is lessened and you may err on the wrong side rather than doing this thing. Next are traffic. You see in the metros and all other cities, the traffic's like this, but heart attacks don't obey traffic rules. You have to bypass them. For example, if I am practicing in somewhere in Bhubaneswar and you can see a patient from Kendujhar or Nuapada or Nabarangpur cannot travel to Bhubaneswar or Cuttack where most of the cath labs are there. This is my state where I am speaking of it. So that is why we tell that if it is in Nuapada or in Kendujhar or in Nabarangpur, please thrombolize the patient and then start shifting. Do not do injustice to the patient because Bhubaneswar might be quite far off, might take 3-4 hours to reach. So it is not necessary that you have to be sure that, no, I'll send the patient, don't shirk off the responsibility, you should thrombolize the patient. Sometimes when the patient comes to the hospital, people start saying, why are you shifting to the cath lab so early? Because they have to be taught what are the benefits. Now, what is the benefit? If you see the time as it proceeds, the heart starts dilating and exactly the ejection fraction starts falling. And that is why we have to revascularize the artery as fast as possible. Because if you don't revascularize, it is a dead muscle and there is heart failure with reduced ejection fraction. And we are talking about, as I heard in the previous session, about SGLT2 inhibitors, so many good drugs coming up, but we cannot revert it back to the 60%. So teamwork, non-availability, the cardiologist might be sleeping, enjoying on leave, on vacation. It is a family choice. I don't want to come at night and to do the case. There should be 24/7 services as we provide that any time in the night the patient comes, we will do an angioplasty. Believe me, last 20 years, I have not thrombolized a patient for MI. Even if it's middle of the night, I believe that it is angioplasty which helps. Now, 75% of the hospitals in our country, they have the non-habilitative members for 24/7. The question is, I'm not there. Let's put the medicine, keep it overnight. By next morning, the LV function is bad. For example, this is a 52-year-old diabetic coming in the dead of the night. As you can see, it is somewhere around 11 p.m. You can see the artery is totally occluded. The arrows are totally occluded. And then you see the angioplasty has been done, 2 stents has been put, and how the artery is open. So this is the beauty of angioplasty, where you can immediately work on it, suck the thrombus, and just give a good result. Now, what is the dictum? Should we, supposing the patient has multivessel disease and is diabetes, should we open up all the vessels or should we open only the vessel which is infarcted? Multivessel angioplasty in STEMI is too tempting. Always people think that, all right, let us open this vessel, 2 other vessels, let's open it. That is a wrong dictum. Only open the vessel which is causing the culprit, unless the patient is in cardiogenic shock. So open only the culprit is the immediate solution. Later on, you can do the other, this thing that is other vessels can be opened up. So this is some message that should go, that we should not be too aggressive and we should not be opening up everything. So the story of angioplasty starts that it is like a relay race, where you see the patient comes with a chest pain, and then after the patient comes with chest pain, in the relay race, he comes on a car, he comes to the hospital, to the emergency, then the doctor sees in the emergency, then speeds up the team, and the team starts working, taking to the cath lab, and then the angioplasty is done. But this is a very long process. The process should be like this. Directly chest pain patient comes and, sorry, there's some problem. Directly the chest pain comes, directly the patient is in the ambulance, the patient is wheeled directly into the emergency, from the emergency goes to the cath lab. We have to cut short all these methodologies so that we shift directly from the emergency to the cath lab, and that is the protocol in my hospital. No blood test, nothing, ECG is enough for diagnosis, no ambulances, nothing is to be done. So there's some problem there. So this is to be done. Now, no emergency anywhere, directly into the cath lab, and that is how we improve it. The third choice is that what are the ancillary drugs to be given? Statins. You see, give the highest dose statins. What you see, the patient with the highest dose statins, as you see in the red marks, are the patients which had the least events and the long-term cardiovascular outcomes were good. Next, Whether early beta blocker therapy should be given? Yes, early beta blocker therapy should be in STEMI because it has good results. But the question comes that should we go on giving beta blockers long enough? In August 2023, the article, first we realized that it is not necessary to give beta blockers in all patients unless they have LV dysfunction or there is tachycardia. At maximum, you can give to 3 years. Beyond 3 years, you stop the beta blockers. But this is a review of 2023, which clearly states in patients only with reduced ejection fraction heart failure, you continue beta blocker therapy, and ongoing clinical trials have shown that there is no benefit on continuing beta blockers for long when the patient has got a normal ejection fraction post-thrombolysis or post-MI. So 1 year outcome clearly stated that without LV systolic dysfunction, you need not continue the beta blockers, you stop it. The judgment is clearly out that beta blockers has to be stopped. So next we go ahead and we think of what about ARNI, because ARNI is coming in a big way. Previously used to say that we have to debate between AC inverse and ARNI. The Paradise MI trial have clearly stated that if you start early ARNI, the ejection fraction improves as quickly as 1 year, and you see how the graph starts diverting and coronary revascularization, non-fatal MI, and death was much lesser if you use ARNI earlier. The last one, diabetes management, because I am speaking in a forum of NUCD where to speak something about glycemic control. Don't be too aggressive in the MI patient. Try to keep the blood sugars at the moderate level. Don't try to be chasing the blood sugars. It is not correct. And intensive diabetes control, a systemic review as appeared in 2023. I'm just quoting the recent articles. They clearly stated that doing an aggressive control of diabetes and MI does not benefit in the long run. Be very judicious. Next, because we are in the era of SGLT2 inhibition, do we start it early? This is a 2023 review in cardiovascular medicine, which clearly stated that you can start in-hospital SGLT2 inhibitors in these patients. That has been shown to have a good benefit on the patients. And if the NT-proBNP is high, this surrogate marker is high, you have to give them, you give more benefit to your patient. Then what about combining GLP-1 receptor agonists with SGLT2 inhibitors? It is very safe. You can combine it in hospital when the patient has got a MI. This is also an article from 2020. It's going to be published in 2024. Not yet published. It's a pre-publication that I'm showing you that the combination therapy of cardiovascular and acute MI, it was an observational study in 500 patients, but they showed that is very safe and can be combined because we are in the age of SGLT inhibitors, GLP-1 receptor agonists, and that is where we stand today. So what is my take-home message? Early revascularization. Reach the hospital early after your diagnosis. If you're at a periphery center, thrombolize. If you're PCI capable center, do a PCI. Proper antiplatelet choice, only one antiplatelet, ticagrelor, because aspirin resistance, clopidogrel resistance is there. So if you give prasugrel, the patient cannot be taken it for surgery. Ticagrelor is best, and nowadays cangrelor is available. You're using it a lot. The effect is only 3 hours, and after the patient is fit for surgery. Thrombolysis versus PAMI, the choice is depending whether the patient can be thrombolized, go for a third generation thrombolytic, and if the patient can reach fast, thrombolize, and then reach to a primary angioplasty center where it can be done. Next, culprit vessel versus PCI, culprit vessel open, and use of ancillary drugs, as I mentioned, has to be done. So that is how you salvage a diabetic patient with AMI. So it is said that humanity's greatest advances are not in its discoveries, but in how those discoveries are applied. This is what Bill Gates has shown. We have enough evidence, we have enough discoveries done. Now we should apply it in real life so our patients are benefited. Thank you very much for the patient hearing.
Thank you, Dr. Prashant,
yes.
For an excellent talk on salvaging a patient of diabetes with acute myocardial infarction. And sorry for joining in delay, a bit delay because of technical issues. And we all know Dr. Prashant Sahu, the leading cardiologist of Bhubaneswar, and he has a lot of credits to his credit in his long illustrious career. And thank you, sir, for giving us an overall view of how to manage a patient of AMI with diabetes. Thank you, sir.
Excellent presentation. As usual, best of the slides, clear message, and how a distant center at Koraput or Malkangiri will do, how a nearby center will do, and how we'll prioritize the taking patient directly from casualty to cath lab, and how when to thrombolize, and then which antiplatelet and what is the blood glucose. So diabetes and AMI, managing a case, has been very well covered. I'm sure there'll be questions in the group chat box and also in the panel. I thank Dr. Shahu for the lucid presentation, and I request her to just wait a little. By the time we finish up the debate and the interview in another half an hour time, so that we can, in panel, we can take the questions and discuss and elaborate. And my co-chair, Professor Mohanty, has joined. So quickly we'll move on to the debate. And debate is on conservative medical management versus renal replacement therapy in CKD. And we have Dr. Manisha Shah, who is the professor head, Department of Nephrology and Osmania General Hospital, and the consultant nephrologist of Aditya Hospital, Hyderabad, and there are many accolades to her ability. She is an executive committee member of ANIO, SARB, TTS, and then the country knows her as a very, very efficient nephrologist, and especially in a diabetes scenario, because of the family background and because of the association, diabetes and the kidney diseases, I think she is one of the best in the country. So I welcome Dr. Manisha Shah to NUCD, and Dr. Georgie Abraham is at MGM Healthcare Chennai now. He is the author and co-author of 338 articles, 267 abstracts, and 30 book chapters edited. The Distinguished International Award by NKF USA, and an Eminent Medical Teacher Award. Now he's out of India, and he may join during our panel discussion. We have contacted him, but Dr. Manisha is with us, and I'm sure for all your nephrology queries and also non-nephrology queries, Manisha ma'am will guide us in the panel discussion. Without much delay, I would like to go for the debate that whether it's a conservative medical management or a renal replacement therapy. I request my co-chair, Dr. Mohanty, to put his views before we start the debate.
Thank you, Professor Jayant, for giving me this opportunity. And actually, you have made everything clear whether renal replacement or conservative medical management is the mainstay of treatment in patients of CKD. And we are there with us, one of the renowned nephrologists, Dr. Manisha. I would request her to start the talk and the discussion also. Please, Dr.
Good afternoon, everyone. Today I'll be talking about conservative treatment for the management of chronic kidney disease for the motion. So I have three challenges in front of me. The first challenge is I'm a nephrologist and I'm debating against RRT. Generally, I'll be speaking in favor of RRT. The second challenge is I'll be debating against Dr. Georgie Abraham, who has been my senior teacher, mentor, and guide as well. And third challenge is I have to finish it in 8 minutes only. So let me start. Do we need RRT for all stages of CKD? We have 5 stages of CKD. What about the first stage, this individual diabetic, hypertensive, no symptoms at all? Do we need to start RRT for him? Definitely not. Early stage, what do we need to do? We need to screen the individual. So should we screen all individuals who come to our clinic? No, we should screen only the high-risk groups, diabetic patients, hypertensive patients, elderly patients, obese patients, those who have a family history or those who have past history of AKI. And the screening test should be urine albumin and creatinine and GFR. So stage 1, no RRT, only screening. What about stage 2 to stage 4 CKD? What should we do here? All guidelines, whether they are American guidelines or international guidelines or Indian guidelines, they say one thing: no RRT for stage 2 to 4. We have to adhere to 7 renoprotective principles. The first principle is diet. So this is a healthy diet plate where half plate should be uncooked food and 1/4 plate should be protein, which can be plant protein and not animal protein. 1/4 plate can be carbohydrates, which are complex carbohydrates, whole grains, etc. Avoid sweetened sugars. Salt, half teaspoon for hypertensives, otherwise 1 teaspoon per day for all CKD patients. And remember, decide along with the patient whether he wants a North Indian diet, South Indian diet, and adopt accordingly. So this is very important. The second important renoprotection strategy is exercise, 3 days cardio and 3 days resistant training. Do not be sedentary. Walk most of the times. The third renoprotection strategy is control of blood pressure. And if there is a high cardiovascular risk, target is 130/80. Otherwise, if low cardiovascular risk, 140/90 is adequate. Use RAS blockers, either ACE inhibitors or ARBs in full tolerated dose. Telmisartan, for instance, 40 mg is not correct. Go for 80 mg, full dose for renoprotection, and continue the RAS blockade even in stage 4 CKD. If the BP is still not controlled, you can use calcium channel blockers, diuretics, MRAs, minoxidil, hydralazine, or clonidine. So target the blood pressure correctly for renoprotection. The next important fourth strategy is for control of glycemia, maintain HbA1c between 6.5 to 8. We all know that. But landmark trials, what do they show? Use correct drugs for glycemia control. Metformin you can use if the GFR is more than 30. But remember the nephroprotective drugs, the SGLT2 inhibitors, they should be the drugs of choice, followed by GLP-1RA. They are renoprotective as well as cardioprotective, apart from being controlling the glycemic control. The next important thing is insulin, sulfonylureas, gliptins, etc. can be used for control of sugar. But do not forget SGLT2 and GLP-1RA. Use if the GFR is more than 20 or equal to 20. Reduce the dose of diuretics when you are starting these drugs. There may be a slight dip in GFR. Explain to the patient. Practice genital hygiene and follow sick day rules. Stop these drugs if the patient is sick, but otherwise use them for all CKD patients because they can delay or avoid dialysis. If you start them early at a GFR of 85, they can delay the dialysis, prevent the end-stage kidney disease by almost 26 years, and you start them around 20 GFR, they can still delay the dialysis for 2 years. So very important drugs. That was for diabetic CKD. You may ask, what about non-diabetic patients? They are very helpful in non-diabetic patients also. IgA nephropathy, FSGS, all glomerular diseases, they are very, very helpful. Fifth renoprotection strategy is finerenone in all diabetic CKD patients if the GFR is more than 25 and if they have albuminuria. Dose is 10 to 20 milligram. Remember, the only risk is hyperkalemia that you have to be careful about. The sixth renoprotective strategy is correct the acidosis, use bicarbonate, maintain serum bicarbonate about 20. You have tablets, you have powders available. Avoid if the patient is overloaded or hypertensive. The seventh renoprotection strategy is avoid nephrotoxins, NSAIDs, vancomycin, gentamicin, contrast studies, unnecessary contrast studies, and indigenous medicines. So 7 strategies for stage 2 to stage 4, not RRT. This figure shows that majority of Indian patients are in stage 1 to stage 4. Stage 5 is only minuscule. So most of the CKD, no RRT. Now stage 5, the patient directly comes to you with stage 5. What do we do here? Even in stage 5, try to give symptomatic treatment. If the patient is overloaded, oliguric, breathless, give diuretics and restrict the fluids. If the patient is having vomiting, you can give ondansetron. If the patient is having itching, give pregabalin, gabapentin. If the patient is having weakness, anemia, correct the hemoglobin. Give iron therapy, give erythropoietin. And if the patient is having hyperkalemia, you can use potassium binders, furosemide, restrict the potassium. Only if in CKD5 the symptoms are not controlled with medications, go for RRT. The other indication for RRT is if there are no symptoms, but the GFR has fallen to 5 to 7 ml per minute. So that is the only indication for RRT. And here I will agree with Dr. Georgie. If you start RRT for younger, fitter individuals, RRT may be the only option. And here you prefer transplant as compared to dialysis. But remember, here again, even in stage 5 with these conditions, RRT may not be for all. For example, dialysis in elderly, there is no benefit for quality of life. They have more hospitalizations. Some of them may even die after starting dialysis, more deaths. This is what not I am saying, what the papers are saying. Remember, dialysis is a lifelong commitment. Ask the family, consider the family's wishes. Do they want to go on dialysis or do they want to stay at home and have quality life? It is finally individual's choice. Do you want a life between pipes, among pumps, among ventilators, or a comfortable life at home? It's your choice. So I'll sum up saying Georgie's words: do all efforts to prevent ESKD. RRT only if mandatory. Respect the patient's wishes. Empathize, sympathize, and then only decide. So thank you, ladies and gentlemen, for a very patient hearing. I rest my case. CKD 1 to 4, conservative management, not RRT. Thank you for a very patient hearing.
Thank you, Dr. Manisha, for a succinct presentation in your favor. And we'll wait for Dr. Georgie to give his put his field. Dr. Georgie is there, sir?
Yeah, RX events. We have a record.
Dr. Georgie Abraham from Chennai. I'm a practicing nephrologist for 43 years. And I would be talking about renal replacement therapy in CKD. So any treatment strategy which involves chronic kidney disease, there are three main issues. The three main issues are cost, accessibility, and quality. So cost is a very important issue in chronic kidney disease renal replacement therapy, because renal replacement therapy consists of three main modalities. The three main modalities are peritoneal dialysis, which is home peritoneal dialysis, which is presented as continuous ambulatory peritoneal dialysis, which is a continuous process being done by the patients at home, or in simple terms, it is called bloodless dialysis. And next you have the hemodialysis, where the patients are dialyzed through an artificial dialyzer with the help of a machine, and this is called hemodialysis. And the third alternative is an organ transplantation, which is a kidney transplantation, is the best treatment for end-stage kidney failure. So when do we start renal replacement therapy in any CKD patient? CKD is classified as 5 stages for uniform definition of the kidney disease. So stage 5 is an estimated GFR of less than 15 ml per minute. And these are the patients who would require renal replacement therapy. And it is not that every patient with a stage 5 kidney disease should undergo renal replacement therapy, because they may be totally asymptomatic and they may not require renal replacement therapy just by looking at stage 5 or an eGFR of less than 15 ml per minute. So renal replacement therapy may be started at a GFR of anywhere between 15 to 0 ml per minute. And most of the time in our country, the renal replacement therapy is initiated when the eGFR is somewhere between 8 and 5 ml per minute. So these are all planned renal replacement therapy. So I will dwell upon the advantages and disadvantages of it. When you have renal replacement therapy, the major renal replacement therapy is hemodialysis, which we call as maintenance hemodialysis. This is usually done either 3 or 2 times a week, and the patient will require an access. The best access is an arteriovenous fistula made in the distal arm, either the right or the left, and less than that is an arteriovenous graft. And a lot of the patients who has no arteriovenous fistula or graft, they have a permanent catheter implanted in the side of the neck, which is called a PAM cath. So these are the main 3 accesses for dialysis in maintenance hemodialysis patients. However, one should also take into consideration that patients with diabetes, it is a blood vessel disease, both microvascular and macrovascular disease, and thereby their blood vessels have atherosclerotic changes, and it becomes sometimes extremely difficult to create an arteriovenous fistula. And even if you create a fistula, because the abnormal hemorrheology of diabetes, these fistulas may clog. So then you are left with either arteriovenous graft, which also has same issues regarding blood vessels, and the next option is a PEM cath. However, the problem with PEM cath is that as it is seen externally, and the external part is on the anterior chest wall, there could be infections, and these infections can lead to septicemia, and if not appropriately diagnosed and treated, it can lead to death. So the disadvantage of PEM cath is infection and sometimes non-function. So these are the issues which has to be looked into when we decide about the access. So if a patient has poor veins and poor arteries, the chance of having a successful fistula is very low, and hence these patients may have to depend on the next form of renal replacement therapy, which is called home peritoneal dialysis. The advantages of home peritoneal dialysis are these patients can have a permanent peritoneal dialysis access in the peritoneal cavity, and they don't need any vascular access. And the other advantage is that when you do hemodialysis, you have to heparinize the blood to prevent clotting. So those patients with retinopathy and active proliferative retinopathy, they may bleed inside the retina because of the use of heparin as an anticoagulation, and also microvascular disease in the retina of the eyes. So this doesn't happen with the home peritoneal dialysis. And the third thing is that the diabetic control. So a low sugar will kill a diabetic patient rather than a high sugar. So diabetic control in a substantial number of patients who require dialysis, they may not require either oral hypoglycemic agents or insulin. But if they require that, the control becomes extremely difficult because of the varying food intake and also the lack of exercise or suboptimal exercise. And then there is gross fluctuation in the blood sugar. It is better to maintain the blood sugar at any point in time between 80 and 170 milligram. This can only be done with the help of continuous glucose monitoring, which is not practical in our country for the large majority of patients with diabetes mellitus and chronic kidney disease. So you may need to choose the drug or molecule which is safer to be used in a patient with end-stage kidney disease and on dialysis. So this has to be done with the help of your nephrologist, and this nephrologist will guide you how to manage the blood sugar in hemodialysis patient. There are two ways of managing the diabetes in peritoneal dialysis patient. In type 1 diabetes with end-stage kidney failure patient who require insulin all the time, in developed countries, they infuse insulin along with the dialysis fluid into the peritoneal cavity. What they do is they add measured insulin, usually the short-acting insulin, into the peritoneal dialysis fluid before initiating the fluid in the peritoneal cavity. And then when it is drained out, some of the insulin and also the glucose is drained out. So this way you can get a 24-hour glucose control, which is probably better than a hemodialysis patient. The blood pressure, systolic blood pressure, should not exceed 140 millimeters of mercury at any point in time in CKD patients who are on dialysis. There are a number of molecules which can be used for blood pressure control, including centrally acting drugs, beta blockers, sympathomimetics, calcium channel blockers, RAS blockers, and also vasodilators. And also, if you have some residual renal function passing 150 cc of urine or more, high-dose Lasix, the range of 100 to 500 milligram as a single dose, these patients to produce salt loss and also to control the water accumulation in the body. So hypertension control is better achieved in peritoneal dialysis patient because of the 24-hour removal of salt and water, and hence it produces less stress on the cardiovascular system. However, one should also think that whenever we are doing hemodialysis, a large number of patients, there is a phenomenon called myocardial stunning, STUNNING, which happen. So in those patients with heart failure, either diastolic or systolic heart failure, mostly with systolic heart failure, this myocardial stenting produces more damage to the myocardium and hence worsening of the heart failure, which does not happen with the peritoneal dialysis patient. So it looks that peritoneal dialysis is a better heart protective mode of therapy compared to hemodialysis. Now, the other thing is whether will the neuropathy improve with peritoneal dialysis? Since peritoneal dialysis is a continuous process, 7 days a week, 24 hours, there could be some improvement in the neuropathy compared to hemodialysis. However, this is not seen uniformly in all patients. The next thing is that hemodialysis can also lead to sometimes during hemodialysis, they can develop because of the use of heparin. The blood pressure is not controlled. I have seen a number of patients developing intracerebral bleed and which could be fatal in a few patients. This does not happen with peritoneal dialysis because peritoneal dialysis, your blood pressure is better controlled. You don't use systemic heparinization, and these are advantages of peritoneal dialysis in patients who has cerebrovascular accident or stroke. That transplantation is the best treatment for survival and for taking care of comorbidities in kidney failure patients. So the transplantation can be either a live transplant or a disease transplantation. Both have been being done in our country, and we have published data on patients on transplantation who are younger and who are older. In the younger age group, we found that 43% of them were diabetic, and in the older age group, above the age of 60, we found that 59% were diabetics when we looked at the data. And a successful transplant gives best quality of life for a diabetic patient. So diabetic control becomes much more important after transplantation to prevent the diabetes-related complications in a chronic kidney disease patient. So some of the chronic kidney disease patients, although they were not diabetic before transplant, after the initiation of immunosuppressive therapy and also weight gain, they develop post-transplant diabetes mellitus. And this should be kept in mind when we look at that, because post-transplant diabetes mellitus also is associated with the molecules we use to prevent rejection. The molecules we use to prevent rejection are steroids, then calcineurin inhibitors, and rarely mTOR inhibitors. All these can either give rise to new onset diabetes mellitus or make the diabetes mellitus control worse. So this should be taken into consideration. Hence, the lowering the steroid or steroid-free protocols are available. But when you do steroid-free protocols, be careful that you do not take the patient into a rejection episode, which is an acute and lead to accelerated use of steroids again. So I think that I have covered most of the things with the renal replacement therapy, both peritoneal dialysis, hemodialysis, and transplantation. So thank you very much.
So it's a excellent exposition on favor of renal replacement therapy, and I hope all of you have listened Dr. Georgie Abraham, and unfortunately he's not here with us. He's out of the country in a CME. We have approached him to join in the panel, but at present I'll request Dr. Manisha for a quick rebuttal in this topic in favor of conservative medical management. Dr. Manisha.
So I think there is no need for a rebuttal because Dr. Georgie Abraham exactly said what I said. So the debate was conservative treatment or renal replacement therapy. So my message, strong message to the physician would be one. The management of stage 1 to stage 4 CKD lies in the hands of not the nephrologist, but the physician. And conservative therapy is the way to go for all stages of CKD from stage 1 to stage 4. If you fail in your duty to provide conservative therapy, stage 5, some part of stage 5, you end up with renal replacement therapy. And that's what exactly Dr. Georgie Ibrahim said. Dr. Georgie Ibrahim discussed about all the modalities of renal replacement therapy in stage 5 CKD. But 90% to 95% of patients in India need conservative therapy. And 5 rules of conservative therapy, in fact, I would say 7 rules of conservative therapy should be used by all physicians. If the physicians, the practitioners, the diabetologists, endocrinologists, all of us, even the nephrologists work together and use the 7 rules, you may not need the renal replacement therapy. There is a saying that what does a good doctor do? A good doctor does dialysis. What does a better doctor do? A better doctor does transplant. And what does the best doctor do? He prevents the patient from going in for dialysis or transplant. And that would be my rebuttal. So work well, work together, use all tools to prevent progression of the patient to end-stage kidney disease where he needs renal replacement therapy. And the final word is, see, even in those patients, 5B, the last stage, if you have an elderly patient, be choosy about renal replacement therapy. Renal replacement therapy is not to make money. You have to give holistic care to the patient. And what do you mean by holistic care? A patient of 80, 85 years comes to you. He is frail, sarcopenic. Do you advise dialysis for him? No. You give him the option to decide. Many of the times, what happens is we put them on pumps and pipes and dialysis. That's not correct. You should worry about the quality of life. Ask what the patient's wishes are. The patient may want a comfortable quality of life, symptom management, and he may live for 6 months, 1 year comfortably within his own household, instead of shuttling between hospital and home and going on ventilator, multiple hospitalizations. So even in those patients who need renal replacement therapy, for the younger patients, try to advise transplant. And if transplant donors are not available, try for cadaver transplant. If even that is not available, choose between dialysis, peritoneal or hemodialysis only for select group of patients. Otherwise, very elderly people not fit for renal replacement therapy, try to give them a comfortable life. So that would be my answer. 90% patients are in your hands. If we all do our jobs properly, strictly, renal replacement therapy will be required only in minuscule, not in all the patients. So that's my rebuttal to Georgie sir's debate. He presented very well all modalities of renal replacement therapy, but I am here to tell you, use renal replacement therapy, what Dr. Georgie said, only in 5% of the patients, and you'll need to use it if we fail in our primary goal of managing the patients properly. So that's it. I rest my case, and I want the jury to take over for comments. Thank you. Thank you for the
very well concluded, Dr. Manisha. And because Dr. Jaji is not here, I'll go with your conclusion only. And conservative medical management is the answer, as rightly you have told, from stage 1 to stage 4. And that stays with the physician's hand to make the patient efficient, not to go for requirement of the renal replacement therapy or stage 5. And that's also the line of argument of Dr. Jaji Abraham, and that's also the right approach, that put our best effort for the right lifestyle, for the right drug, and put all the available measures so that our patient will not require a RRT. So this has been rightly concluded. And with this, I request you to stay down for the panel where we can have more questions for our viewers. But quickly, we'll finish up an interview. And interview is taken by none other than Professor Ashok Das. And he has interviewed none other than Professor Subrat Acharya. You know, Padma Shri Subrat Acharya is a doyen in gastroenterology and hepatology. And the concept of MASLD, the metabolism associated steatotic liver disease, is a new designation for NASH. And in the setting of diabetes, and other metabolic illness, especially obesity, hypertension, dyslipidemia. The MASLD is a big risk factor and a game changer in a life and the direction and the comorbidity of a diabetic patient. So without much delay, we'll go to the interview by Professor Ashok Das of Dr. Subrat Acharya on MASLD 2023 State of the Nation.
Very, very good afternoon. And I'm delighted that I am with one of the most important, academically superb, clinically absolutely fabulous, and research-wise highly impactful in many areas, liver cancer, NAFLD, many areas, hepatitis, Professor Dr. Subrat Acharya, the Pro-Chancellor of the Kids University in Bhubaneswar, and the head of the digestive disease and hepatology department of the entire, I'm extremely in the Fortis Hospital, and I am delighted to be with a person who has made impact in the country and the world, from the word go, from MBBS to MD in Chandigarh. They're doing his DM and then not looking back, progressing without any, non-stoppable progression with the God's grace. Subrat, I'll call you by first name. We are so close to each other. And I'll just start by asking to you, tell me, Subrat, don't you think that non-alcoholic steatohepatitis, we'll discuss about the name change. Don't you think it's the most important contemporary challenge in front of the diabetologists, the metabolic physicians?
Well, not only diabetologists, sir, it is probably important across the population in every discipline. It was first described as non-alcoholic fatty liver disease because way back in 1980 in Mayo Clinic, there was a brilliant pathologist called Ludwig. He got a biopsy of liver which was laden with fat. And then they used to see such fat-laden liver histopathology in alcoholics. But when he saw the histology form, it was written he is a non-alcoholic, middle-aged male. So he rang the clinician and shouted, "You don't know how to take history." The clinician shouted back and told, "I know what is the history." And hence the term started non-alcoholic fatty liver disease. And it was in 1990, NIH, National Institute of Health, officially told, okay, let us call it non-alcoholic fatty liver disease. As the time progressed, we realized, people all over realized, non-alcoholic fatty liver disease is a manifestation of systemic metabolic dysfunction. Now, this group of people are more prone to develop many metabolic disorders like type 2 diabetes mellitus, cardiovascular morbidity and mortality, chronic kidney disease, polycystic ovarian syndrome, and so forth and so on. So then when multiple studies, it became very apparent that this is a disease which is prevalent in about 30% of global population.
Great. I think it's
a global epidemic. And there is no...
Can you tell us why they changed the name and what the current definition of this MA?
That's what I am coming to. Actually, what happened when people started seeing fatty liver disease all over the globe, and they found there are various metabolic dysfunction associated with it. So they knew it is a systemic disease. It's not focused to a liver disease or to a cardiac disease or to hypertension or to endocrinologist. It is a systemic disease.
Correct.
And liver disease is a manifestation of the systemic disease. And subsequently, as the plot thickened, a group of people from Asia started seeing fat in people who were non-obese. And it was seen in obese people. And obesity was a risk factor. Diabetes was a risk factor. And lo and behold, these Asian doctors who started looking at fatty liver disease by doing simple ultrasound. So there are lean people and this bloody definition of BMI more than 25 as overweight, right? and more than 30 is obesity, right? Doesn't exist in that. And they told, well, they are not, they are lean fatty liver disease. But when the further evaluation was done, indeed it was found they have also metabolic dysfunction. Metabolic risk factor exists in them. Their visceral obesity is more because they don't have subcutaneous adiposity. Hence, last year, a world's expert from all over the world sat down together to define metabolic fatty liver disease and change the term to MAFLD, the metabolic dysfunction associated fatty liver disease.
Good.
And they clearly define, if you are over obese, by classical definition, for Caucasian that BMI more than 25, or for Asian BMI more than 23,
Correct.
or if you have frank diabetes mellitus, right, and you have fatty liver disease, okay, fine, that is obviously metabolic dysfunction associated liver disease. But in between those who have a BMI less than 25 or 23, they have also fatty liver disease. So they describe these are lean fatty liver disease, but they must fulfill 2 of the 7 criteria they define, which you define as a metabolic dysfunction. And these 7 criteria, Ashok Babu will tell you, one is waist hip ratio. You know, in Asians, the waist abdomen bulge. So they define if the waist hip ratio for male more than 0.9 and female more than 0.8 for Asians, right? Or if they have dyslipidemia, you know that triglyceride and low HDL. Or if they are pre-diabetic, you know that also very well, the fasting more than 100 or postprandial more than 140 or hemoglobin A1C more than 5.7. And also, you know, metabolic dysfunction is associated is an inflammatory state. So they told CRP more than 2 and HOMA-IR more than 2.4. Out of the 7, 2 criteria in a lean individual is also metabolic associated fatty liver disease.
Absolutely fabulous, Subrat. That was my next question. What is lean FLD? And you have appropriately, very clearly, and absolutely crystal clear what is MAFLD and what is lean FLD. Now, Subrat, just a minute. What do you think about the global and the Indian prevalence of this malady?
So we are in much more trouble, Ashok Babu, as Indians. Global prevalence obviously is increasing because of sheer obesity and sedentary habit and fine sugar dietary habits, which are actually causing insulin surge. And insulin is lipogenic. You people know better than me.
Yes.
But in India, all the people in diabetic associations has been students. Now remember in your school, did you see a young boy with a tummy, bulged tummy?
No.
They were all thin.
No.
Right? Now you go and the survey shows in Indian school, 30 to 35% of children in class 10 are obese because of the change in dietary habits. Now, that too should be the focus of, I think, endocrinologists, gastroenterologists, and other people, that school children should be avoided to take these cokes, this aerated drinks, this pizzas, this noodles, these burgers, and this is causing high insulin surge, and insulin is lipogenic, and they are getting deposited.
Yeah.
And this is also, I will tell you, we have studied that childhood obesity is a risk factor for liver cancer.
Absolutely.
So that's the problem. What we are seeing as an epidemic, and Indian population studies revealed that about 25 to 30% of Indian population above the age of 18 have fatty liver disease.
Now, Subrat, is there the effect of genetics? Because I just searched and I found some PLMP, 3X, etc. I'm not an authority on this. Do you think genetic has an influence? And the second question, is there any drug derived from the genetic aberrations? I mean, okay,
it's a very good question, Ashok Babu. These genes which you are reading, PNPLA3, this is patatin-like phospholipase dependent protein 3, is nothing but is actually a lipoprotein hydrolase enzyme. So what it does, it hydrolyzes triglycerides. Now, if you have And all enzymes in human beings are polymorphic. We are polymorphic actually. We are human beings, but we are different.
Yeah.
So the enzymes are also polymorphic. And if you have a functional enzyme, because of mutation in the gene, it is in chromosome 22, and if there is a mutation, which has been also identified as RS708439 mutation, they are less functional, so they cannot break triglyceride, and triglyceride become glycerol, and glycerol get accumulated, what is called de novo lipid synthesis in the liver.
See, good. Now it is very clear. Very
Now
clear.
there are other enzymes also in the process of hydrolysis, right?
Correct.
They are called, say, ABTL. This is another triglyceride hydrolysis, or ABCD 15H13. This is another form of hydrolysis. So if these enzymes which hydrolyze triglycerides are deficient, they will store fat into the liver. Problem is we don't have a target to change these genes.
No.
Because these genes are inherited.
Yeah.
So some people are prone to keep the fat in the liver, provided the environment helps. Environment is sedentary habit, dietary habit, right? Bad diet.
I get it. I get it.
To have a clinician
My question is a very critical one now for the physicians, Subrat, is how do we simply diagnose, and what is new in the diagnosis? And the final thing, today we are told that ordinary ultrasonography of the abdomen might miss quite a number of NAFLD. One must do a fibroscan. I want to collect, the collected opinion on all these points, because diagnosis is one of the very important things for us.
That's correct. You see, when liver contains more than 5% of fat by weight,
yes,
or if histologically, if 5% of hepatocyte has fat, that is increased fat. It should be less than 5%.
Correct.
Now, an ultrasound will detect fat if the fat deposition is about 30 to 33%.
Oh, 30, good.
Because the sound waves will not penetrate, so the image you will look as white, more white. Because once it penetrates, the sound waves will not come back, reflect back, which is the energy. So unless 30 to 33% fat is there, you may not detect a fatty liver disease. So, but it is a very good, easy, simple screening step, because this fat, if you detect in ultrasound, is reversible. Now, to detect accurate fat, the other imaging techniques are MR, or there are other imaging technique which you call a fibroscan, which is nothing but vibration controlled transient elastography. We call it VCTE, or ultrasound related elastography. Yes. Now, MR can actually detect, depending upon their nuclear changes or spectroscopic changes, right, small amount of fat, which is called PDFF.
Yes.
Proton density fat factor, because these are proton, right? And also similarly, fibroscan defines two things: the stiffness of the liver, which you palpate in your hand. So this is a machinery way of palpating the stiffness, because it throws these waves in a shear fashion, in a tangential fashion. So depending upon the stiffness of the surface, the amount of energy reflects back is more. So if there is a scar, it will be more stiff. So more shear wave will come back. So we can assess both fat as well as fibrosis in a fibroscan. So that's why it's very popular.
How do you interpret the fibrosis in the fibroscan? The simple message for the physicians. How to interpret? They said grade 2, grade 3, grade 4, beyond grade 2, take it positive. How do you interpret? So
no, they call it, sir, F1, F2, F3, F4 of fibrosis, right? That is fibrosis score. You see, normal fibrosis score, which is based on doing thousands and thousands of normal population, it should be less than 6.
Less than 6? I see.
6. Between 6 to 8, right? You may have various reasons, but more than 8 is definitely fibrosis. If it is more than 8, and you are in trouble. If it is more than 12, it is cirrhosis. It is already high scar. So, in fact, it avoids invasive tests like liver biopsy. But liver biopsy, it has been correlated very well with liver biopsy in fatty liver disease, in hepatitis C, and hepatitis B. In fact, using it, we can avoid liver biopsy in about 70 to 75% of patients.
Good. Subrat, we know the stages of hepatocyte injury, inflammation, and fibrosis. I'm giving simplistic approach of a physician. Hepatocyte injury, inflammation, fibrosis. Is there any way of diagnosing early without liver biopsy?
You have absolutely put a finger on a spot. There are three elements. One is fat, one is inflammation, one is fibrosis. Right. Now it has been seen patients with liver fat who has inflammation and some fibrosis, they progress.
Correct.
But who has simple fat, they have other risk factor like cardiovascular risk factor or developing type 2 diabetes mellitus and other problems. So
and
we
also,
say
and also, Subrat, they die of the cardiovascular disease.
They can die of cardiovascular disease.
Correct.
If you follow fatty liver disease, about 20 years, 20% will die of cardiovascular disease, 20% will die of cancers, 20% will die of liver-related death, and 20% will die of other form of chronic disease like kidney disease and other problems.
Great way of teaching. 2020. Fantastic. Now, Subrat, tell me, I'm coming to a very important issue. Does liver enzymes, ALT, AST, namely, greatly help in diagnosis?
Actually, no. Liver enzyme, if you see a simple fatty liver disease with inflammation or even scar, can have a raised liver enzyme. Liver enzyme, if you see what is earlier called SGOT, SGPT or GGT, we call it AST and ALT. Name indicate aspartate and alanine transaminases. They are enzymes for amino acid transfers.
Correct.
For metabolism of protein and carbohydrate.
Correct.
They can be also leak out with little fat to the blood. So just raised transaminases make you suspect that there is liver injury, but not well correlated with liver injury.
Yeah.
Therefore, you need additional tests.
Yeah. Very important question, Subrat. When will you see, the liver biopsy gives the final court of appeal, no doubt about it. But where will you say the liver biopsy is a must?
You see, there are many non-invasive tests today, therefore.
Yes, exactly.
The non-invasive test based on clinical scoring simple, there are clinical score.
Correct.
Now I will give you some very basic clinical score. Like say, one score is very popularly known as FIF4. It is age, AST, ALT, and platelet. And there is a discriminant equation. It is available in your hand computer with the discriminant equation, it will calculate. If FIF4 score is more than 1.5, suspect fibrosis.
Correct.
Right. There is a test called APRI, AST platelet ratio. If it is more than 0.5, you suspect fibrosis.
Correct.
There is a NFS, non-alcoholic fatty liver disease score, NFS score, which consists of advanced age, male sex, right? AST, ALT, platelet, albumin combined together. So it also gives you a score. Besides this clinical score, there are blood tests also. Say extended liver fibrosis, ELF score we call.
Yes.
Which actually measures the various parameters of collagenization in the blood. And they are essentially TIMP, tissue inhibitor of matrix metalloprotease. When you have a scar as a GOV in your body has a mechanism to also dissolve it.
Correct.
And those enzymes called matrix metalloprotease.
Matrix, yes. MMM.
And you can inhibit, body also tries to inhibit. So fibrosis is a dynamic process. Yeah. So TIMP, which is inhibits matrix metalloprotease, will go up. If you withdraw the cause, MMF will come down, but TIMP will stay for a longer period of time.
Correct.
And you have hyaluronic acid and procollagen type 3 peptide, which are dynamic changes which are causing collagenization or fibrosis generation, which you can measure in the blood. And we have identified if the value is more than 7.7, right? There is moderate fibrosis and more than 9.5 quite advanced. So these are non-invasive tests.
When will you do real biopsy? For
Well,
research purpose or for the purpose of treatment?
No, fibrosis may be sometimes very important. We do liver biopsy. You see, when you have a borderline score, these scores have a sensitivity and specificity of, say, 70-80%.
Borderline score, correct.
So if you in between score and you are very suspect that there is a fibrosis and you want to have a supervised treatment, and most important treatment, supervised supervision is necessary, because no drug till now, Sosab Gabu, has been able to do magic except weight loss, right, and exercise.
Yeah, I rightly said medical weight loss or surgical weight loss and lifestyle. I have one question because we have last 5 minutes, Subrat. I want to ask you, do you think, I'll just name the drugs. You give your frank opinion about it. Metformin, I think leave it. Pioglitazone.
Well, pioglitazone is a PPR delta, right, receptor. You know the role of PPR delta, which will increase stem cells of fat stem cells and for large amount of hepatocyte. That's why they cause weight gain. But that store fatty acid. Once they store fatty acid, right, fatty acid stored to the liver decreases. Once the fatty acid direction or
channel
road to liver decreases, well, that helps. And pioglitazone helps actually. It has been
vitamin E.
But metformin has not been shown to be of helpful.
What about vitamin E? Before I come to the drugs
again, vitamin E, long-term vitamin has in randomized control trial as an antioxidant, because increased fat metabolism in beta oxidation of fat in mitochondria, generating a lot of reactive oxygen species, causing liver damage, causing cell necrosis, which upregulates fibrosis, is the scavenging. And it is shown to decrease the inflammation, that is enzyme, not fibrosis.
Correct.
Right.
What about the newer drugs, Subrat? Are they going to change the scenario like GLP-1 RA? You are involved with so many trials. You are doing biopsies in the trials, and also SGLT2 inhibitors. Well, GLP-1 RA, except one, Revelsys, all are injections, and SGLT2 inhibitors.
Yeah, there has been a trial. You know, GLP-1 obviously will decrease postprandial glucagon secretion and increase insulin secretion.
And weight also will come down.
It delays gastric emptying.
Correct.
It also works in hypothalamus and satiety centers.
Satiety centers, absolutely correct. I'm amazed, Subrat, I'm amazed at your mastery over the subject. And wish and pray for your further academic. Fantastic answer. How do they help? Are they going to change? Are they going to bring reversibility to this MAF?
That evidence has not come, but the clinical trials has shown both lira and semaglutide definitely has improved the fibrosis score and inflammation, right, to some degree. But question is, they're very expensive. Lira is an injection. Semaglutide, you go up 3 milligram per day to 14 milligram per day. And some people don't tolerate. I don't know whether you have noticed it or not.
Yes, I have noticed. Nausea, vomiting is a big issue.
Very big issue. So even though there are trials now, and very expensive, if you see my patients, where I used to work in a public sector hospital like AIMS or in a KIMS.
Yes.
Most of the people come back to me.
I'm delighted to learn, my dear friends, Subrat is the emeritus professor there. I'm delighted to announce this to the audience.
But they say, sir, we cannot afford this.
Yes, exactly.
Right. That's a big problem, even though clinical trials. Also, some trials done in the United States or Europe, if you cannot use it in my population, I don't consider it as evidence.
Exactly. After every journal club, you remember, Subrat, while 4 months I spent with you, Badri will ask whether it's adaptable to Indian population. Remember, the journal club. Otherwise, it's useless. Treatment adaptation to India was his concern, your teacher, my teacher.
It's a very important thing, Ashok Babu.
Yeah.
So just telling that.
Last question. Does caffeine help? Because there are so many things around caffeine. Does caffeine help?
It will be very interesting that there are 13 clinical trials now on caffeine.
Oh, really? Good.
Black coffee, scientific clinical trial.
I see.
And shown 3 to 4 cups of black coffee definitely actually has been claimed to prevent fibrosis, not fibrosis reversal.
Okay, prevent.
Right.
That's enough. That's enough. That's enough. And you know, Subrat, you are also in charge of the division of human nutrition in AIMS. Whenever I visited you, a great interest. Now this Mediterranean diet, which is very difficult to practice now. Only the olive oil is 500, 800 rupees per kg. So you know,
not available.
Mediterranean diet. In any semblance of it that we can adapt
You
in
see,
our
Mediterranean, what is Mediterranean diet? It is green fruits,
yeah,
olives,
yes,
right, and sea fish, which has a lot of omega-3 fatty acids.
We have plenty in Pondicherry.
That will be helpful. Omega-3 fatty acids,
yes,
right? Not omega-6.
Yes,
Omega-3.
What about Muffa? Muffa?
Polyunsaturated fatty acid will be protective, right? But I will say it is more of omega-3 fatty acid which will help you much more, right? And omega-3 fatty acids are plentifully available in, say, seafood like salmon, like mackerel, trout, tuna, which are not available in India.
Correct.
I don't know in Pondicherry whether you get it or not, but it's also available in akroat, walnuts, and flaxseed.
Correct. Yes. Last question, Subrat, before I go, is about the bariatric surgery. We are not great protagonists. With the available new drugs, bariatric surgery has definitely come down. You must have seen. Now, what is the role of
It's a big area in our subject. Endoscopic bariatric surgery. People make money. Surgeons become bariatric surgeons by doing not only gastroplexy, but they are doing bypass.
Yeah.
No doubt, studies, if you ask me about literature evidence or study evidence, it decreases insulin resistance, it decreases fatty liver disease, it decreases weight, it decreases insulin requirement.
But does it go back to the norm, to back to square one after a few days if one doesn't maintain the lifestyle?
If you are going gastric sleeve resection, stomach, making stomach small, stomach is elastic organ, it expands. And the diet lies here, sir. Problem lies here in the brain.
In the mind.
So that's why you have, but they are doing a bypass. They are doing gastrectomy and putting jejunum straight into the remnant of stomach, right? So you don't have a stomach, right? That is probably helping, but that is a nutritional problem again. A lot of micronutrient deficiency, which you have to monitor continuously, makes life difficult.
Subrat, thank you very much. I think last 27 minutes have been absolutely prophetic. On behalf of the thousands of people, last year we had about 10,000 hits. The thousands of people pan India who have joined this to listen to you, I thank you, convey our sincere gratitude and thanks, and also congratulate you for your mastery over this subject and the way you have made it very simple. Bolte usko pranjal, you have made it very simple, crystal clear. And on behalf of all of us, Subrat, thank you very, very much. But on behalf of all of us, I offer my sincere thanks, gratitude, and I know, and benedictions, because goodwill, our love and greetings for your continuous improvement. All the best to you, my dear friend Subrat. Tuina, who is the source of inspiration for Subrat, and the lovely children.
So it was an excellent interview, and I congratulate Professor Dash and Professor Acharya on MASLD or Metabolism Associated Steatotic Liver Disease 2023, the state of the nation. So many information have come firsthand from the mouth of the horse, and you have heard about the MASLD related metabolism, related interventions, and complete spectrum of the problem. And two doyens were discussing, and it was a very clear exposition. So with this, we'll move on to the last part of the complication. And it's my pleasure to invite the best people in this scenario for this panel discussion. We have Dr. Ghanshyam Goyal, who is a physician dedicated in the field of diabetes, especially diabetes foot, for last 4 decades. And his works and his publications are enormous, part of the IDEA, part of the RSSDI, part of all diabetes groups of the country. And Dr. Goyal is with us. We have already heard to Dr. P.K. Shahu, I request Dr. Shahu to surface and take part in this panel discussion. We have Dr. Manisha, who discussed you during the debate time and also conveyed her views on the picture regarding the renal replacement therapy and the conservative management. Dr. Manisha Shah, who is with us. And you have already heard Dr. Shubrat Acharya about MASLD. With this, with Dr. Goel, and Dr. P.K. Shahu, Dr. Manisha, I welcome all of you to this panel discussion on complications. We'll try to give you a glimpse of diabetic complications and its approach. I also welcome Dr. Shumit Chakravarti, who has joined. And now we'll move on, starting from Dr. Goel. Dr. Goel, you have been working very extensively on diabetic complications. You have seen so many vasculopathies, diabetic foot, nephropathies in your practice. My first question to you will be ischemia, neuropathy, and infarction. We know the precipitated diabetic foot. So how the link can be interrupted, broken, and a diabetic foot can be prevented. How do you think during health or during good control, a person's behavior should be there, which will not complicate him with a diabetic foot? What will be your message to him?
Thank you, Jayant, and thank you, Dr. Kanungo, for inviting me. And as I was listening with Dr. Acharya and Manisha and Dr. Sahu, excellent presentation. So we all know the infection, ischemia, neuropathy, and infection. This is a triple jeopardy. And primary risk factors for diabetic foot is one is neuropathy, of course, and then the ischemia. And top of that, there are second risk factors, the deformities, calluses, and then you can say previous history of amputation, chronic renal failure or chronic kidney disease, we call it. And as there is a renal foot, if there is a CKD with the diabetic foot, then there is a renal foot. So all these non-compliant patients, all these are the secondary risk factors. So about the nexus, what you have asked, link can be broken and diabetic foot can be prevented. So we all know, initially you have to diagnose which patient is in high risk foot by doing a comprehensive foot examination once in a year. It's a high risk, mid risk, low risk. Like that, you have to identify the foot. And to break the link, you have to have A, B, C. A means HbA1c less than 7, we all know, without producing hypoglycemia even 6.5. Blood pressure less than 130/80. And the LDL cholesterol in less than 100, or in the high risk it should be less than 70, and taking the care of the foot. If a patient who is identified to have a high risk feet, means having loss of protective sensation, then yearly comprehensive examination, prevention of identification of the high risk feet and prescribing the foot wears, and then the education is very important. If we educate these patients that if you take care, then you are not going to develop diabetic feet, or you are not landed with the emergency. So if high risk feet, the simplest thing is never walk bare feet even at home. If you are in neuropathy, loss of protective sensation is there, then you have to walk at your home or even at indoors. Without footwear, you should not walk. Means you have to walk, that does not walk bare feet even, that is there. And about the management of the risk factors which are there, if somebody is in peripheral vascular disease, then as we all know, we have to control again diabetes, then control the LDL cholesterol, control the blood pressure, and stop smoking, the tobacco in any form. And believe me, I'm yet to see a patient who is not using tobacco in any form and having a peripheral vascular disease. I think Dr. Sahu and others, Dr. Manisha might agree with it, because I yet to see a patient. This is very common. So we just ask our patient to quit the smoking, and we just enforce. And education, repeated education, repeated. Whenever a patient of diabetic foot comes, suppose he came just 2 weeks back,
we have given a diabetic education. We always say, we repeatedly, our educators give them repeated education that you should do this, do's and don'ts, that you do this, and all that. And these are going to go in a big way, and it is going to break the link. It will break the link between all these three: ischemia, neuropathy, and infarction, and the diabetic foot can be prevented. That is the message.
Very well spoken, Dr. Goel. We know in smokers, even non-diabetic patients, we get Berger's disease, which causes diffuse thrombosis and at times need amputation. So tobacco and smoking definitely precipitate the risk, and also the lifestyle and the early food assessment that you told are equally important. We'll move on to Dr. Shahu. As I told, he's the clinician, the cardiologist with a right analysis of the problem. We have heard about salvaging a diabetic patient with acute coronary syndrome from him recently. Sir, my question will be diabetic with myocardial infarction, how they behave differently from non-diabetic, and what symptoms to look for in diabetic to suspect myocardial infarction.
Thank you, Professor Jayant. In fact, this is a very important aspect, because most of the times what we do is that we miss ischemia in diabetics. So it is exactly like Dr. Goel had said, that patient education is most important, awareness is most important. Most of the time, because of neuropathy, various types of neuropathy, they do not complain of any chest pain. They just will come to your OPD or will present to you with a very simple complaint, which I am sometimes surprised. Ghabrahat ho raha hai. Now, what is this ghabrahat? That's the whole thing. They feel panicky. There is some amount of sweating. There is just tachycardia. When you do an ECG, you'll be surprised to see that the patient has got a MI. And if you do a biochemical markers, if you do the biomarkers, you'll see that enzymes are raised. So in diabetics, even if there is an iota of doubt of MI, you should investigate a little bit further. Because these are the people who really fool you. They're like ladies, actually. Most of the time, they'll tell you something, but the reality is something. So be very careful about this patient. That is what I say. Any diabetic patient with any untoward complaint, which does not fit to the clinical picture, which even maybe just easy exhaustibility, that is also a question or a distinct chance that this patient might be having coronary artery disease or maybe having ischemia. So we have to be very careful in examining and evaluating these patients. That is most important. Or else we'll be missing these patients because they may not be having any ECG changes, but maybe having very subtle signs. And easy fatigability is one of the earliest signs in heart failure or with ischemic heart disease. So we have to be very careful in examining them.
Very rightly told, sir. The diabetics behave differently from non-diabetics. And if you have this thing in your mind, you can suspect and take right step for the assessment. The another question for you is, are diabetics to be treated differently than non-diabetic patients with MI?
Yes, the diabetics usually have small vessel disease. They have multiple blocks. So those concepts should go that diabetic patients should be subjected to any intervention. See, multivessel stenting has not shown to be very beneficial in diabetics. Bypass surgery, CABG, is the right option for them. Because most of our diabetic patients say that, why should I undergo a bypass surgery? Because my sternum has to be ripped open, it will get infected. But we have to reinforce the confidence in them that a lima is an artery which is like which can only marry a LAD. A rima can marry a RCA. So if you do get a good arterial graft done, even as a cardiologist, I say surgeries are more important and very helpful in these patients. The small vessel disease, and these vessels sometimes are not amenable to percutaneous interventions. Surgeries, if the patient has multiple blocks, has got multiple problems, in an acute stage, just open the culprit artery, leave it, and do a hybrid procedure of a surgery in the second sitting. But no one can beat a lima and a rima in the long-term results so far as angioplasty is concerned.
Very rightly suggested, and we have to keep it in mind when approaching a diabetic in comparison to a non-diabetic. Now we'll move on to Dr. Manisha Shah. You have heard how befittingly she argued in favor of conservative management in CKD and proved even from Georgia Abraham that the conclusion is what we took last is stage 1 to 4 conservative, and the RRT is the last option. Ma'am, we learned a lot about the microalbuminuria, about the urinary protein assessment since our undergraduate, postgraduate days. But of late, we know the estimated GFR, urinary albumin creatinine ratio have come to the picture. So in early detection of diabetic kidney disease, what importance should be given to microalbuminuria, and whether the UACR and eGFR is must for every patient at detection and yearly?
Yes, so Dr. Pandas, you have raised very valid points, and I would say that I showed in my slide all high-risk patients. In fact, in some countries, for all patients, they do it. In India, at least for all high-risk patients, diabetic patients, hypertensive patients, cardiovascular disease patients, elderly patients, more than 65, obese patients. So those patients who are on long-term painkillers, it is very important that we screen them for kidney disease, because the whole problem in India now is the medicines are available, dialysis is available, transplant is available, but still we are having an epidemic of chronic kidney disease. That is because we are missing it in the preventive stages. So all high-risk groups should be screened, and screening tests are only two, which you mentioned: urine albumin creatinine ratio and the EGFR. EGFR is nothing, you know, that we calculated from the smartphone. All of us are smart. All the physicians are smart. Practitioners are smart. We all have a smartphone. We just have to put the creatinine value, age, gender, and you have the GFR report. So my message to all the physicians or neuro or nephro or endo or whosoever, every doctor worth his or her salt should have a GFR app in the smartphone, and a urine albumin should be done in the lab. And please write it on the prescription, because a day might come when the patient may sue you. Doctor, I'm a diabetic, I'm a hypertensive. I've been coming to you for such a long time, and there is no documentation of either a urine albumin or a GFR. Now people get confused. I mean, whether to do albumin or albumin creatinine ratio, urine protein. Remember, the best is the early morning urine albumin creatinine ratio. But having said that, that is available in many of the tertiary hospitals, but may not be available at the peripheries. So what do we do there? There also, there are two methods. You can straight go for a urine protein as well. Even protein positive should make you suspicious. And now we have formulae which can convert the urine protein to urine albumin. They are all available on Google. Even if you don't convert, if you have urine protein plus, be wary. So don't worry if albumin is not there. Now, another important development, we have point of care albumin testing also, where in the clinic you can have that machine, take the patient's urine, and you have the report immediately. So point of care albumin testing, but again, it comes with a cost. So my message to your answer is, it is mandatory. And if you don't remember the high-risk groups, no problem. Screen all, screen whatever patients you see in the clinic, because urine albumin and creatinine doesn't cost much. It's just 100 rupees. And can't a patient spend 100 rupees on himself or herself once in a year? Surely. So it will protect you. And the moment you have this positive, we have 7 therapies, which I request, implore all your prescriptions, whether you are a foot surgeon or whether you are a neurologist or a cardiologist or a nephrologist, cross your heart and tell me how many of us are writing all the 7. We may know it in our head. I liked Dr. Sahu's last slide. The important thing now is implementation of whatever we know. That's most important. So remember, from this day, this point onwards, only message which goes across from me is 7 points on your prescription before the patient leaves your clinic. So ensure that they are all there. That way you'll remember to write everything. And that would retard the progression of CKD. I have shown in one of the slides, SGLT2 inhibitors are that important. You can get 26 years of dialysis-free life. SGLT2 inhibitors, I heard in one of the previous talks also, all over the world, global usage, even in US, 8% of the patients who really need them. And in India, luckily, because of the generics, the usage is a little bit more maybe, but it's not ideal. So I think urine albumin and GFR ensure. Are you writing it on the prescription? If not, start today.
Very rightly told, ma'am. They are not very costly, and if done timely and detected, save the kidney and bring a change in the patient's life in long-term follow-up. Now we'll move on to Dr. Goel again. Sir, many patients come with an advanced state of diabetic foot with infection, with necrosis, with lot of slaw and swollen limbs that we have seen because of our lack of awareness. People do some local therapy, country therapy, alternative medicine. So, how should you evaluate a very bad food that you receive, and what is the commonest organism that you isolate in an infected feet? Because in many rural setups they are not able to do a proper culture and decide about antibiotic therapy, and which antibiotic you think should be empirically started after detecting till we have got a culture sensitivity report.
It's a very pertinent question. And as we all are aware, before you start any antibiotic therapy in diabetic foot infections, DFI, first you have to take a deep tissue culture. Always remember, never take a superficial tissue or never take the pus for culture sensitivity. It should be debride the wound and take a deep tissue culture and send it. And we can divide the diabetic foot infections into mild, moderate, or severe. Or you can another classification, non-limb threatening, limb threatening, or life threatening. So empirical, because most common organism in diabetic foot is staph, Staphylococcus aureus, and then comes a streptococcus. But as the grade of the ulcer, if you take the simplest classification of diabetic foot ulcers, the Wagner's classification, that is grade 1 means no superficial ulcer. Grade 2 deep ulcer means ulcer more than 3 millimeter. Then grade 3 means ulcer or diabetic foot with osteomyelitis. Then the grade 3 localized gangrene is grade 4 and extensive gangrene is grade 5. So if the grade of the infection increases, the anaerobic bacteria or anaerobic and especially the gram-negatives will come. One study which has been done by Ashu from PGI Chandigarh and Professor Bhansali at the time, and they have shown around 25% of their patients were having the Pseudomonas. So I was really surprised. I had a lot of discussion with Professor Bhansali and Ashu also, that how come it's so, because when we come to see the data, I've read the paper properly, it was all were very high grade. Because the patient doesn't come, as Jayant, you have rightly mentioned, that patient came very advanced stage. So as the advanced stage there, the microorganisms or microbiology has been changed. So it was Pseudomonas was more common in more than 25% of the patient. But if it is a mild infection, start with co-amoxiclav plus a quinolone. It might be ciprofloxacin or levofloxacin you can start with. And if it is a moderate infection, and if it's a deep infection, in that situation, you have to start with a combination of either you can start with, I can say clindamycin, plus you can put these patients on, if you are suspecting gram positive only, then you can put them on we always sometimes give a combination of both gram positive, linezolid plus clindamycin. Otherwise, we start with piperacillin, tazobactam plus linezolid. And if it's a life-threatening or severe diabetic foot infection, take the deep tissue culture. Start with the meropenem plus teicoplanin, and according to culture sensitivity reports, you can de-escalate or you can escalate the antibiotic therapy. That's the simplest way we can do, and every center should have a antibiotic policy. So we are following this policy and we find very good results with this, and according to culture sensitivity report, we escalate or de-escalate the therapy. And second question, Jan, yes.
You can complete, sir.
Now, so second question, very bad foot, how you evaluate? So you see, if you have to evaluate the diabetic foot, because is it a ischemic foot? it's a neuropathic foot or neuropathic infected foot. So at one conference just 15 days back, I was showing 3 cases looks alike, gangrene of great toe. One was having ischemia, there's a peripheral angioplasty has been done. One was having osteomyelitis, so that was the re-amputation has been done. And one was simply just infection, and which has caused that caused the gangrene, and it has been just amputated simply. So that depends. So you have to identify it's a ischemic foot or it's a neuropathic foot. So it's very simple. Just by putting your fingers, if the pulses are palpable, it means it's a vascularity is adequate. If it is on plantar surface, then you can say it is neuropathic, because in plantar surface ulcer on the high pressure areas and a lot of callus is there, it means a neuropathic ulcer. But if it is on the margins and painful, then it looks to be ischemic. So by that you can decide and you go ahead. Yeah.
Very, very rightly told. And if we give that much of time to look to the foot of every patient, we can detect early. And if you have an idea of organism, sensitive antibiotic and intervention policies, you can shape the foot instead of amputation. We'll move on to Dr. Shahu again. And I request Dr. Shahu to surface. Dr. P.K. Shahu, are you there?
Yes, I'm there. Yes, I'm there.
Yeah, sure, sir. So the next question is to you. We know you also talked about a lot of physicians who are in the rural area, and they face challenge of detecting acute myocardial infarction, acute coronary syndrome in a diabetic. So how you will teach a physician in a rural setup to suspect and detect AMI in a diabetic, and when to refer the patient where?
See, the basic thing is that whenever you get a patient with chest pain who is having angina, etc., first of all, the clinical symptoms are very important. Next, if you have a suspicion, now ECGs are available at every district headquarters or in subdivisional hospitals, and ECG has to be done. Once now this is the age of WhatsApp era and everything, you can immediately send it to a cardiologist or a senior physician or a physician who is well accustomed to the ECGs, and they can interpret with you. But I will always tell my peripheral physicians not to be in a hurry to send the patient to a tertiary care center, because you may not know. Supposing a patient who is coming from around 15-20 miles away, so or say 100 kilometers away, he might die on the way. So it is better that you first give the loading dose, and always see that ticagrelor is given, atorvastatin is given, and aspirin is given. 180 milligram ticagrelor, this thing that is 80 milligram atorvastatin or 40 milligram rosuvastatin, and a tablet of 150 milligram of aspirin. These 3 are essential. After you give these 3, then if you feel that the patient is having a escalation MI, you please start thrombolyze him. Nowadays, the state government is giving thrombolysis to every nook and corner. I see thrombolytic agents being wasted. So it has to be such that the patient, if you thrombolyze, you will save a lot of lives. And next, if the patient can afford, give a third generation thrombolytic. Once the patient is stable, you can shift the patient. Do not be in a hurry to shift the patient unless the patient has a complication. Now, the practical issue is that the peripheral doctors, they are not keen on thrombolyzing. Now, why? Because they're afraid of the patient's relatives. Suppose it may bleed, the patient may bleed, but I always encourage them, please take a consent before thrombolysis. If they even do not give a consent for thrombolysis, you're on the safe side. And if they give a consent for thrombolysis, please thrombolyze them. And that makes our job easier, because if the artery is recanalized partially, it is very useful for the cardiologist and makes the job much easier. That's the whole thing. So do not shirk your responsibility by telling that I'll shift the patient to a tertiary care hospital, my job is over. No, you are the main person who is in touch with the patient. So you should deal, you should know how to do it, and they have to be educated. And that is the way how we should treat. And it is like the hub and spoke model. The hub is the centers where we are placed. The spokes are all these peripheral centers which have to be connected. So this is very important.
Very rightly outlined, sir. The next thing I'd like to know from you is, what is the best for a diabetic? It's a surgery or a angioplasty?
See, it all depends. Actually, we go by a syntax score. The syntax score has been developed by the surgeons and the cardiologists in collaboration. And if the syntax score is anything more than 25, then definitely surgery is the first choice. If the syntax score is anything less than 22, Angioplasty does better. Now, what happens actually, it all depends because the patient is first in the hands of the cardiologist. So naturally, they try to first open up the culprit artery. Then I believe in doing more of a hybrid procedure. See, if I do the angioplasty first of one vessel, which is a culprit, I save the myocardium. Once you save the myocardium, the surgeon is always there to operate for the second stage. After 3 months or 6 months, they can operate. But if the patient has a typical left main or a severe triple vessel disease, it is better to send it to a surgeon who can do a better job. It is not, we have to see what is the patient benefit most of all. Next, many patients do not agree to get a surgery done. So then we naturally do an angioplasty, complex angioplasties, and can be done. Now, you see in most of the countries, most of the places in US, no one prefers to do a surgery these days because we are getting the disease, very young patients, etc. So why not do a stenting first and try to buy some years and then go for a surgery in the long run? So it has to be a very individual decision based on the syntax score, and be very judicious to your patient. Just don't enforce on him that angioplasty is a choice or surgery is the choice. See what the patient wants, the family wants, what the patient's anatomy determines, and then take a choice. That's the whole thing.
Rightly you have told, sir. The syntax score will help deciding the surgery or angioplasty.
Exactly.
And then we in diabetic especially, we have to be very quick for the detection and the referral so that we can shave part of the myocardium. We'll move on to Dr. Manisha. Ma'am, probably it is last question for you because we are approaching our time. You'll agree to me that the SGLT2 inhibitors have brought a revolution not only in the field of coronary artery disease but also in diabetic kidney disease. So, how do you place SGLT2 inhibitor in a diabetic and also in a non-diabetic in reversal of the renal involvement? And what about the newer drugs like Fendrinon and the Galaxia, because we are trying to prevent RRT and put the patient on the conservative treatment. So after lifestyle, what are the drugs you keep in your basket?
So as I have mentioned in the 7-point agenda in my presentation, SGLT2 and GLP-1 receptor agonists, they both stand high when we choose a drug for a patient for management of diabetes. And then I'll talk about non-diabetic as well. So diabetes, the remember is that now it's not a glucocentric approach. We just don't treat the glycemia and forget about it. Patient, whether with the nephro, cardio, endo, patient is patient, and we need to treat the patient. And it should be a holistic approach. Holistic approach means you need to worry about the glycemic control. Apart from that, you have to be having renoprotective, cardioprotective strategies, good quality of life, all those things. So SGLT2 have shown without a doubt, and especially in the landmark renal trials as well, Credence, EMPA Kidney, DAPA, we are fed up of hearing those trials now. Seminars, webinars are on those trials since last 2-3 years. They have very well established that SGLT2 inhibitors are renoprotective. And as I said, remember, if you start them early at 85 ml per minute, you can think about stage 2 CKD. Many of us on this panel have a GFR maybe around 80 to 90. And none of the Indians has a GFR above 90, very few. So in fact, if you start them at 85 in a patient with diabetes and proteinuria, you give 27 years of dialysis-free life. So that is your responsibility. You are saving your country a lot of cost for dialysis, and you are saving the patient the whole trouble of going through dialysis. Even if dialysis is free, somebody is paying. Even if dialysis is free, the patient is suffering. You have a lot more complications on dialysis and renal replacement therapy. So SGLT2, it is criminal, it is unethical if somebody says that we will stick to the older therapy and not use SGLT2. We have to be informed, and we have to use SGLT2 for all patients unless they are contraindicated. Contraindications are very few, and you should know how to use them. They follow the sick day rules, and you have to take care of the genital hygiene, explain to the patients properly. Right now, GFR of 20, now cutoff has gone to 20. And you start SGLT2, and even if the GFR drops below 20, you keep on continuing the SGLT2 till the patient goes on dialysis. Now, trials are going on SGLT2 and dialysis as well, transplant as well. But as of now, till the patient goes on dialysis, you can put the patient on SGLT2. This is about diabetic patients. And even after SGLT2, if the proteinuria is not controlled, you can add GLP-1 receptor agonists. They are also nephroprotective and renoprotective. Now, once you have done that, still, if the diabetic patient has proteinuria, you can add finrenone, which is also shown to reduce the progression of chronic kidney disease. Finrenone is expensive, and only thing you have to be a little bit careful about hyperkalemia. It is a mineralocorticoid receptor antagonist, but luckily does not have the side effects of spironolactone. And again, it is cardioprotective as well. You have Figaro trial for cardioprotection, and you have the Fidelio trial for renoprotection. But finrenone is for diabetic CKD. As of now, studies on non-diabetic CKD with finrenone are not there. SGLT2, you have studies in diabetic CKD and non-diabetic CKD. So go ahead. Please use SGLT2 in all your CKD patients, where diabetic or non-diabetic. Finrenone, restrict to your diabetic patients. So that would be my take on this. And this message, see, the beauty of such webinars is we learn a lot from each other. We are otherwise having a tubular vision. I'm in nephro, cardio is in cardio, but remember, patient is ours. We have to treat holistically, and all this should be done right from the primary care to tertiary care. It should be a hub and spoke model, as the previous speaker already said. In dialysis, we have a hub and spoke model. So now what we want to suggest is a hub and spoke model for preventive care as well. So the SGLT2 as of now are not available in the peripheries. What's the point of talking about SGLT2 when they are not accessible in the periphery PHCs? So the RAS blockade, the SGLT2 inhibitors, the GLP-1 RA, and finrenone should become a part of the government system and should be available. There's no point in talking if 70% of patients do not have access to that drug. So that's my take on it. And it is what is evidence-based medicine, not expert opinion.
Rightly told, ma'am. And your golden rule of 7 is really very useful for the physician in briefly remembering our approach to the problem. So I think we have taken our time, though there are many questions left. I've been asked to stop at 5:45, which is again 15 minutes ahead of the schedule. So with this, I thank our panelists, mainly Dr. Ghanshyam Goel, who has taken a very efficient answer, remembering the team and also the thousands of people attending. The message is given. And also I thank Dr. Manisha, who has taken important time, so energetically she has participated in the debate and also summarized all the questions in the panel. And Dr. P.K. Shahu is a asset for the patients as well as for the students and practicing doctors in the field. He has told the gist of approach to a patient with different complications. So in panel discussion, we have taken many golden rules in the micro and macrovascular complication management. Few things are covered in the neuro session, the brain session. Few are covered in the MASLD session with Dr. Acharya, and regarding acute complications of hypoglycemia, diabetic ketoacidosis, and HHS in due course will be completing. And I must thank Dr. Alok Kanungo and Professor Ashok Das for this opportunity and fantastic interaction. And I thank everyone and hand it over to the organizers for the next session. Thank you all.
Jan,
Thank you very much. Thank you all.
Session.
Thank you, sir. Thank you all.
And let us thank Ghanshyam.
Thank you, sir.
Thank you very much for joining us. Manisha, jawab nahi. Thank you. Single word. Manisha says, don't go. I mean, she's our daughter, country's daughter. Manisha, all the very best. And now we'll hand over the session to Alok for a very important session. The session is titled, very catchy title, The Future of the Oral Anti-Diabetic Drugs. And it is a very fabulous session. Over to Alok and Professor Bijay Mishra. Professor Alok and Bijay Mishra. Over to them. Alok, we can start.
We can.
Thank you, Ashok Bhai. for this excellent remark. Now I invite our co-chair, Dr. Vijay Misra, and to take the things ahead. And all the faculties are joining. So without delaying, Vijay sir, you introduce the topic little and then invite the guests, the faculties.
Thank you, Dr. Kanungo. Actually, this is the last session of the day probably, and
We have one more
future
after
of oral
this.
anti-diabetic.
We have one more after this, but this is the last big session.
Last but one.
I welcome Nilakshay. Thank you,
Yes.
Nilakshay, very much.
That's it. This is the future of anti-diabetic drug, because the future of anti-diabetic drug is always bright, and that is what is our comment. And we will be discussing on 3 drugs, and on this dapagliflozin, and then Vildagliptin and Pioglitazone will by our speakers. And this first speaker is Dr. Sumit Chakrabarti, and she will be talking and the beyond glucose control, elevating diabetic care to metabolic care with dapagliflozin and its combinations. So where is the Dr. Chakrabarti's biodata? Anything? Acha. Dr. Sumit Chakrabarti.
Hello. Yes. Am I audible, sir? Hello.
Yes, you are audible.
Okay.
Because audible, you are presently working as professor, because you just 1 minute. Professor in Department of Medicine in North Bengal University, Darjeeling, under the West Bengal Medical Education Service. So he is has a lot of publication, and he is examiner in MD. So naturally, we welcome you, Dr. Chakrabarti, and go ahead with his presentation. You are not audible.
Can you hear me?
Yes, now.
Yes, sir. Thank you. So at the very beginning, I would like to thank the organizers for giving me the invitation. And without wasting much time, let us begin our discussion. One second, sir. Yes. So today we shall be discussing beyond glucose control, elevating diabetes care from a glucocentric approach to metabolic approach with dapagliflozin and its combinations. We start with a case vignette, 53-year-old man who is a diabetes for more than a decade, hypertensive, smoker, as well as having obesity. A1C is 8, eGFR 55 amounting to CKD stage 3, having dyslipidemia and BMI more than 29, and USG abdomen showing fatty liver grade 2. His present medications includes metformin, sitagliptin, rosuvastatin, and telmisartan. So if you look into this patient, only as far as glucose is concerned, hyperglycemia is rather to be considered as a narrow view of a vast field. And glucose excess is only one of the phenotypic expression of a plethora of linked metabolic perturbations. So now we should switch from glycemic-based care to metabolic care that will address the liver, heart, kidney, as well as the body weight. So when a person, healthy people, becomes less exercise prone, there is low energy expenditure, have bad food habits kind of things, he accumulates fat. And the fat cells, so the adipocytes, are active endocrinally, and they secrete a number of important mediators like pro-inflammatory cytokines, leptin, adiponectin, TNF-alpha, free fatty acid, ROS, etc. So together, it culminates into insulin resistance, lipotoxicity, dyslipidemia, fibrogenesis, and whatnot. And that brings about obesity and other associated diseases. So if you first look at the fatty liver or NFLD, type 2 and NASH, they goes hand in hand. They are basically partners in crime. If you have type 2 diabetes, it increases the risk of NASH. And if someone has just fatty liver disease, non-alcoholic, it increases the risk of diabetes as well. We can really rename the non-alcoholic fatty liver disease as metabolic dysfunction associated steatotic liver disease or MASLD. And when this steatosis gives way to inflammation or hepatocyte injury, this can be MASH in spite of NASH, that is metabolic dysfunction associated steatohepatitis. So these things need address apart from glycemic control. Now, what are the drugs we have to address these issues? The age-old Pioglitazone is definitely our first preference or number one choice, keeping in mind that it helps to control your insulin resistance at different levels, as well as a good effect or positive effect on fatty liver disease. But my next speaker, Dr. Dekha, will be talking on this Pioglitazone in greater detail, so we are skipping it. So what about the other molecules, namely SGLT2 inhibitors that are the current talk of the day, and they can help us in managing the diabetes patients in a number of ways. How? The SGLT2 inhibitors, first of all, reduces hyperglycemia. There is reduction of glucotoxicity and improvement of insulin resistance. There is loss of calories, loss of body weight, and it also reduces the hepatic de novo lipogenesis, hepatic inflammation, apoptosis, the endoplasmic reticulum stress, and oxidative stress. So together, it increases the hepatic metaoxidation and reduces the amount of inflammation or steatosis in the liver. So it can be very healthy, it can be very handy in our armamentarium to start this molecule, particularly the persons who are having the NFLT thing or body weight is increased. So for our case vignette, we can really think about this kind of molecule. Now, what about the cardiovascular disease? This is not talked about. Every person present here knows a lot about this diabetes and cardiac agglomeration. Globally, about 1/3 of patients with type 2 diabetes have cardiovascular disease, and they have an increased risk of other complications like myocardial infarction, stroke, heart failure. We know all of these things. So CV disease occurs early and the leading cause of death. So what are the drugs we have really that actually prevents or improves the cardiovascular mortality? The SGLT2 inhibitors, the GLP-1 receptor agonists, obviously tops the list. So what about the SGLT2 inhibitors? I'm just stating a data regarding the importance of early use of SGLT2 inhibitors. Using data from AMD annals, about 2.5 lakh population that has been included in the study. And what they are using, they are starting the dapagliflozin molecule of the SGLT2 at a very early stage. It is starting from the 0 to 1 year. And they have actually tried to show that the sooner you introduce the SGLT2 inhibitors, the better is the outcome. This is one plot that is showing the hazard ratio is increasing with your duration of diabetes and with increment of the A1C. Very simple to understand. Significant trend towards increasing risk of CVD with increasing level of A1C, fine. But what happens when we introduce dapagliflozin early? The black colored boxes represent the cohort using dapagliflozin. And here we can see that initial part, 1 year or 2 year exposure, the hazard ratio is reduced, and that too statistically significant way. So early introduction of SGLT2 inhibitors in 0 to 1 years or 0 to 2 years reduces the association of glycemic control, better association of glycemic control and control of cardiovascular diseases. This is terrific. Whatever we talk about the management of cardiovascular diseases in patients with type 2 diabetes, whether they are having only atherosclerotic cardiovascular risk factors, whether there is established atherosclerotic cardiovascular disease with some amount of heart failure, be it with preserved ejection fraction, moderately reduced ejection fraction, or reduced ejection fraction. Whatever it is, we have been enlightened by a number of studies that as a class, SGLT2 inhibitors, they are beneficial in maintaining these things to a large extent. Highly prevalent undiagnosed complication, this is heart failure. Between 25 to 40% of patients have these, and about 70% of patients, they show even sign of asymptomatic LV dysfunction. Even in the ESC guideline also, there is recommendation that SGLT2 inhibitors are very much recommended in patients with type 2 diabetes with multiple risk factors or established atherosclerotic heart disease, and they all show to have a class 1 level of evidence. We can consider different liflozins, IMPA and DIPA. They have robust backup studies behind them, and the other molecules are yet in the pipeline. This is a focused update of ESC, and they also recommend as a class 1 level that SGLT2 inhibitors, they are very much useful in the patients with heart failure with mildly reduced ejection fraction as well as preserved ejection fraction. So these are the options we have for heart failure patients. And here, apart from these usual cardiovascular drugs like diuretics, ACE inhibitor, ARB or ARNI, so DAPA and IMPA, these are definitely belongs to class 1 management product, class 1 drugs in our armamentarium. Okay, so this is how actually SGLT2 comes to be beneficial in heart failure. It actually shifts the metabolism in the heart from a glucose-centric to fatty acid-centric energy expenditure. And it enhances the expression of between one HIF, that is hypoxia-inducible factors, as well as AMPK, and reduction of the mTOR expression. So together, the restoration of autophagy and removal of cardiac remodeling, that is the pathological explanation for this benefit. Okay, this is just a gruesome picture showing the prevalence of diabetes, that is 2021, more than 537 worldwide, and the incidence of chronic kidney disease is also increasing as a pandemic of diabetes is really killing us. So what happens in the diabetic patients with CKD? Our case had an eGFR of 55, so he has already entered CKD stage 3. So he should have the usual things like incorporating healthy lifestyle, physical activity, cessation of smoking, as well as weight management. And the KDIGO guideline states the first line drug in your type 2 diabetes management patients, though it is metformin, but we should also try to initiate an SGLT2 inhibitor, particularly when the patients are obese and there is no obvious or overt contraindication. And it can always think about GLP-1 receptor agonist if needed to achieve the individualized glycemic target. So let us come to the case again. This patient who had an uncontrolled glycemic status, CKD stage 3, dyslipidemia, hypertension, BMI, and fatty liver. So usual medication, metformin, sitagliptin, rosuvastatin, and telmisartan, just an addition of a SGLT2 inhibitor, maybe dapagliflozin, can do miracle for this patient. These are the parameters that have been really shown to a lot of improvement after 3 months of therapy with dapagliflozin. Early intervention, it can prevent or delay different complications. What about the combinatorial approach in the diabetes management? All the guidelines have stated if the initial A1C is more than 75, combination therapy with 2 agents may be needed. And for those with an A1C or more than 9 or 1.5% above the goal, then 2 or 3 anti-hyperglycemic agents should be initiated concomitantly. This is also the AAC algorithm. All of you know that this picture is so bright and vibrant and informative as well. What about the different combinations with dapagliflozin? What about the DAPA and metformin combination? This definitely improves glycemic control. A1C reduction can be up to even 2%. It has a positive impact on systolic blood pressure, helps to control the blood pressure. It reduces HOMA-IR and insulin resistance and CV events. And mostly, and most importantly, there is reduced incidence of hypoglycemia because mechanism-wise, these two drugs do not induce hypoglycemia. So these two drugs together combine and can do very good for the management of our patients. Now, what about this SGLT2 along with the DPP-4 combination? Say, for example, sitagliptin. We know about this molecule, sitagliptin. This is one of the earliest gliptins discovered. And it has its own CVOT trial published in 2015, the TECOS trial, that showed its non-inferiority as CV mortality or heart failure hospitalization is concerned. It has become, it has established itself as a safe CV safety agent. So what about if you combine your dapagliflozin with sitagliptin? Again, the duo can be dynamic. It reduces, the better glycemic control is achieved. There is cardioprotection, DAPA plus CETA. There is enhanced renal protection. It improves the atherosclerotic cardiovascular risks, and it might help to decrease the genitourinary tract infection. So together, the duo can work dynamically because of its synergistic mode of action. They also have shown to reduce the glycemic variability. Compared with the control group, patient with DAPA group exhibited reduction in 24-hour mean blood glucose excursions, and the different studies can also be quoted regarding the glucose excursions in respect to sitagliptin. Well, this SGLT can also be combined with other gliptins as well. Say, for example, Vildagliptin. My next speaker will be talking about Vildagliptin, so I'm just skipping the much about Vilda, though it does not have a so-called CV outcome trial, but a number of RCTs, number of field trials have proved it to be cardiac safe, and dapagliflozin can jolly well be combined with Vildagliptin to give almost the similar efficacious result when combined with DAPA and CETA. So what about if we combine these three medications together, metformin with dapagliflozin along with sitagliptin? We can get a fixed dose combination of DAPA with CETA and metformin. Yes, the pills burden can be reduced. And a patient with diabetes is usually forced to take so many number of medications because of all these complications. So combining these three essential drugs into one fixed dose combination can really reduce the pill burden while keeping all the beneficial effects intact. And obviously, two drugs are more beneficious, and three drugs, triple FTC, definitely will show a betterment in the different parameters as far as reduction of A1C and other fasting BP, etc. are concerned. Three-drug combination is obviously more efficacious. So we should conclude by stating that now our approach should be a more holistic metabolic care apart from a glucose-centric care. So there is a transition to a more holistic approach. And what multidisciplinary care that covers the cardio, renal, as well as metabolic profiles, which include obesity and fatty liver disease. And SGLT2 molecule has been proven to improve glycemic parameters for long, as well as its other comorbidities like heart failure, CKD, NFLD, established atherosclerotic cardiovascular disease. All points, there is a notable benefit from the use of dapagliflozin and its combinations. So thank you for your patient hearing.
Thank you, Dr. Chakravarti. So please wait for the panel discussion. And actually, you have covered the subject very nicely, and the entire Indian market is full of with all combinations with dapagliflozin, DAPA with the DPP4, DAPA with the double and triple combination, and it is being widely used. And your talk definitely has given strength to our viewers to use it early and to have the benefit. So our next speaker is Madam Lakshmi Nagendra, and she is going to talk on Vildagliptin, and that is she is MD in medicine, MRCP medicine, and DM endocrinology and DNB endocrinology. She is in the Department of Endocrinology in the JSS Academy of Higher Education Center, Mysore, and University Gold Medal for highest mark in DM endocrinology, and many other laurels with the madam. So, madam, kindly talk. You can give your talk on the exposing the Vildagliptin.
Thank you, sir. Thank you for that kind introduction. I hope I'm audible.
Yes.
Am I? Yes. Okay. Just sharing my screen. And a big thank you to the organizers for having me in this amazing conference. I've been listening to some of the talks, and just before this, we had the talk on complications of diabetes, and that was quite insightful. And I learned a lot of new things with the cardiology and nephrology teams as well. So thank you so much. And today I'll be speaking on delving into recent updates of Vildagliptin, the fourfold advantage of Vildagliptin. So today we'll be talking in the next 15 minutes the relevance of DPP-4 inhibitors in Asian Indians. Vildagliptin as a pioneer gliptin, why it's really the pioneer gliptin, and what it has been, the trailblazer and the group of gliptins. Update on the recent US FDA guidance on CVOT for anti-diabetic drugs. Cardiovascular safety data of Vildagliptin, and also we'll be talking a little bit on the newer Vildagliptin 100 mg SR once daily therapy, and of course summary and conclusion. So we know that there is an increased DPP-4 enzyme activity in non-obese Indian patients with type 2 diabetes. This has been well established, and we know that this increased DPP-4 enzyme activity correlates with various aspects of obesity, like, it can correlate with presence of diabetes, it can correlate with triceps fold thickness, and a lot of variables of obesity. Now we know that there have been so many studies that the efficacy of DPP-4 inhibitors is higher in Asians than non-Asians. This is partly explained by the thrifty phenotype of the Asians, which they're not really obese, but have a lot of metabolically unhealthy characteristics with higher DPP-4 enzymes. So the DPP-4 inhibitors work better in Asians than non-Asians, and we know this from a lot of studies and meta-analysis. And Vildagliptin is really the pioneer gliptin. It was the first study demonstrating that DPP-4 inhibition with Vildagliptin increases the GLP-1 analog, which translates as a durable first-line therapy for diabetes. So Vildagliptin as the pioneer gliptin is a durable first-line therapy for early control in diabetes. There is no harmful weight gain or weight loss associated with Vildagliptin, and low risk of hypoglycemia. We have cardiorenal hepatic safety, which I'll be talking about. And also now we can reduce the pill burden with once daily preparation. Now we've spoken about Vildagliptin as a durable therapy for type 2 diabetes, but what about Vildagliptin as a first-line therapy? So what happens when you use Vildagliptin as the first agent in type 2 diabetes? And there have been a lot of trials, the initial trial, test trial, and most recently, the Verify trial, which has been in news, because in Verify trial, when we used Vildagliptin with metformin, initially, in the first few days of initial monotherapy versus early combination therapy, we reduced the relative risk of treatment failure by a staggering 49%. So you use Vildagliptin with metformin early in the course of the disease, you reduce treatment failure by almost 50%. So this has been proven to be a durable first-line agent in the treatment of type 2 diabetes. So it is a better DPP-4 inhibitor with less hypoglycemic events, which makes it a good therapy even in the elderly or those prone for higher hypoglycemia, has a better HbA1c reduction, and also gives a better time in range to the patient. So when the time in range with Vildagliptin was studied, patients on Vildagliptin spent an additional 13% in time in range. So this translates to a 3-hour increase in time in range when patients were on Vildagliptin compared to other oral anti-diabetic drugs. And Vildagliptin not only increased the time in range, but also did it at the risk of fewer hypoglycemia. So Vildagliptin was associated with good glycemic control and fewer hypoglycemic episodes, and also the weight control was better in Vildagliptin patients. Now, when we talk about any oral anti-diabetic drug, the first thing that we see today is the CV safety. So is this drug safe as with respect to cardiovascular events? So this is a meta-analysis, a huge meta-analysis of about 17,000 patients. And this said that Vildagliptin was not associated with increased risk for adjusted major adverse cardiovascular events compared to the comparator. And it also did not find a increased risk of heart failure. Now, I say heart failure because there's been quite a controversy of DPP-4 inhibitors that can cause heart failure. But we have many studies now which say that sitagliptin or allogliptin or vildagliptin is not associated with an increased risk of MACE. And based on all these published CV outcome trials, except saxagliptin, all other gliptins can be considered CV safe. So it's not really a class effect that you say that saxagliptin causes heart failure. So the other agents in this class can also cause heart failure. This is limited to saxagliptin and does not extend to other agents. Now, why are the DPP-4 inhibitors so different from each other? Can the mechanism of action explain this difference in clinical activity of the DPP-4 inhibitors? Now, when we look at vildagliptin versus sitagliptin or even linagliptin, vildagliptin has a substrate enzyme blocker activity to the DPP-4 as compared to the competitive enzyme inhibitor activity of the sitagliptin and even the linagliptin. So this translates to elevated levels of increasing hormones which are maintained for a much longer time. And this translates again to less glycemic variability, more time in range, and also potent blood glucose lowering in our patients. So when vildagliptin was compared to the other gliptins, they produced a significantly meaningful reduction in HbA1c as compared to sitagliptin and linagliptin. They were superior in HbA1c reduction and also in renal safety. Now, we know many of our patients have these comorbidities of diabetic kidney disease, and we are always at a loss of what oral anti-diabetic to give. And now the good news is vildagliptin is approved at all stages of renal insufficiency. So if you have an eGFR of up to 60, you can give the 50 mg BD dosage. But if the GFR is less than 60, you switch to 50 mg once daily dosage. But it can be given in all stages of CKD and can be considered as an effective oral anti-diabetic drug, even in patients with diabetes and CKD. Now, there are so many studies to give us a wealth of clinical evidence with a vast pool of patient data of vildagliptin, comparing the safety, cardio safety, the renal safety, the hepatic safety, and also studies during fasting in patients. So when we look at the recent US FDA update for type 2 diabetes, we know that there are certain stringent criteria, the drugs that need to pass to be approved for patients with diabetes. Now, when we look at any drug, it has to have 4,000 patient years, 1,500 patients exposed to the new drug for 1 year, and 500 patients at least exposed to the patient for 2 years. And we have data with vildagliptin for all of this. And again, the US FDA mandates that at least 500 patients with stage 3 or 4 CKD should be exposed to this drug, at least 600 patients with CV disease, or at least 600 patients older than 65 years of age should be exposed to the new drug before the drug is marketed. And we have enough data with vildagliptin for all of these patient populations. Now, what about long-term cardiovascular outcome trials with DPP-4 inhibitors? Now, we have the T-Course trial with sitagliptin. It met the primary safety objective. Saxagliptin met the primary safety objective, but there was an increased risk of hospitalization for heart failure. We have the Examine for alogliptin, and we have the Carolina, which looked at linagliptin versus glimepiride, and again said that the safety, the long-term cardiovascular safety with DPP-4 inhibitors is good and should not be worried about. So again, I want to emphasize that it's not a class effect, and based on all the published CV outcome trials, except saxagliptin, all other gliptins can be considered CV safe. Now, what about heart failure? There was again no significant difference in risk of heart failure hospitalization with vildagliptin in diabetic patients who had systolic chronic heart failure. And this was a study which looked at the cardiovascular safety of vildagliptin in patients with type 2 diabetes, and it looked at a European multi-database, and it looked to see if vildagliptin was associated with an increased risk of CV events compared to other non-insulin anti-diabetic drugs. And again, you can see the forest plot that vildagliptin was not associated with any risk of CHF or any other major adverse cardiovascular events. Now, DPP-4 inhibitors have been extensively evaluated for their CV safety, and the cumulative evidence has demonstrated good CV safety with respect to major adverse cardiovascular events. And this data is from more than 12 lakh patients, which shows the robustness of these studies. So we are talking about data of lakhs and lakhs of patients which have been studied to come to this clinical conclusion. Now, we've spoken about how good vildagliptin is in the management of type 2 diabetes, be it patients with renal failure or hepatic failure. But we have a need for newer therapies in diabetes management, which will increase the patient compliance and lead to a better adherence, also help in inpatient management, and is also economic and affordable by many of our patients. Now, this should be done without compromising the safety and efficacy of the drug, and this is where the Vildagliptin 100 mg OD dosing comes into picture. So this is a sustained release formulation which provides a quick achievement of a drug plasma level, which remains constant at a value within the therapeutic range for a significant period of time. So this assures the control all day long in our patients. It is actually bioequivalent to a BD dosage, and there is a 24-hour control with a 90% inhibition of the DPP4 enzyme. Now, this has a polymer matrix system which avoids the peak to trough fluctuations in the fluctuations of the drug, and it's also not significantly affected by gastric pH and hydrodynamic conditions, but fewer side effects. So when the DPP4 inhibition was compared with the standard that we have now, that is the Vildagliptin 50 mg BD dosage was compared. The Vildagliptin sustained release given once a day achieved almost the same percentage of DPP4 inhibition while you're giving the drug BD as compared to while you're giving the drug once daily. So there was no compromise in the DPP4 inhibition, even though you're giving it only once daily. Now, they also compared the Vildagliptin given twice a day compared to Vildagliptin given once a day, and there was no significant difference between the two therapies with regard to HbA1c reduction. It was the same, but then you give it once a day or twice a day. The study also confirmed weight neutrality. So patients who are on once a day Vildagliptin did not gain more weight as compared to BD dosage, and there was also no change in liver enzymes or other safety parameters were also similar between these two groups. So Vildagliptin 100 mg once a day reduced HbA1c in a similar fashion when given once a day as compared to given twice a day. So again, this was a study which looked at Vildagliptin 100 mg OD given, and this was presented at the research retreat recently. And when Vildagliptin 100 mg was added to patients after a week of metformin monotherapy, there was a significant increase in proportion of patients in time in range, and there was also an increasing trend for time in range in patients. So I would like to conclude that, Vildagliptin really stands apart, and what really makes it stand apart is that the plethora of clinical evidence to prove its efficacy and safety, assurance of an earlier and better glycemic control given earlier in the course of type 2 diabetes. You are better off rather than waiting for the patient to have treatment failure. Start it early in your patients as verified by the verified trials. And there are benefits of durability, low hypoglycemia risk, and also no body weight gain. So we are struggling with obesity, which is a major, difficult to treat comorbidity in patients with type 2 diabetes. So this is also weight neutral, offers more opportunities to address individual patient needs, and also improves patients' adherence to treatment, especially in the OD dosing. Thank you for your patience here.
Thank you. Thank you, madam. Exposing Vildagliptin with much up-to-date information. And now, because the combination is available widely in India, so naturally, your talk will definitely strengthen and our viewers' mind for the use of the drug. So since it is a pharma-sponsored symposium, so it should be that the drug is well exposed by you. Thank you. Our next talk will be Pioglitazone in non-alcoholic steatohepatitis, and the talk will be by none other than Dr. Nilaki Dekka. So where is her biodata? Achha, madam is MD in general medicine and then DM in endocrinology, consultant endocrinologist, Apollo Hospital, Guwahati, consultant endocrinologist, Disipur Polyclinic, Guwahati, speaker in various national and international forum, best graduate of Dibrugarh University in 2002, A.V. Gandhi Award, the best thesis topic in endocrinology in 2011, I think, and publication in national and international journals. And madam, the floor is yours. Kindly talk on Pioglitazone in the management of non-alcoholic steatohepatitis?
First of all, thank you for the opportunity. A very good evening, respected seniors, Dr. Bijay sir, Alok sir, and AK Das sir. We are very fond of AK Das sir. He treats us like his daughter. Like in the last, you saw last talk when Dr. Manisha was giving a talk, he said she is the nation's daughter. So likewise, thank you so much, sir, for all the affection you have shown towards us all these years. Thank you, Alok sir, for giving me this opportunity to be in this forum, in this respectable forum. And this is namaskar to you. Just give me a moment, I'll share my slides. So after the discussion about, yes, SGLT2 inhibitors in diabetes, and then Vildagliptin in the role of diabetes and NASH, we now have Pioglitazone, which is one of the age-old molecules. And when we compare it with the newer class of molecules, so this has been a molecule which has been there with us from a number of years. Some years back, it went into disrepute for its for the controversy related to bladder cancer, but now we must say that Pioglitazone is clear of all the myths that has been associated with it, and we now have this molecule which is there with us and is available at a very cheap, lower cost for the treatment of not only diabetes, but it also has a proven role in the treatment of non-alcoholic steatohepatitis. Now, there are very few molecules which are effective for the treatment of non-alcoholic fatty liver disease. Lifestyle modification is one of the most important factors which improves non-alcoholic fatty liver disease and is one of the key management factors to address non-alcoholic fatty liver disease. Other than anti-diabetic agents, so apart from lifestyle modification, there is nothing much, I would say, for non-alcoholic fatty liver disease. It becomes more of a metabolic disease, and hence it belongs more to the arena of endocrinologist and diabetologist rather than gastroenterologist. Why we say so? It is because now there's this common soil hypothesis where we believe that most of the metabolic diseases, they kind of appear in the same individual because of the ingredients which are required, which are same for the individual who also has diabetes. He's also more likely to have hypertension, he's more likely to have cardiovascular disease, and he is more likely to have non-alcoholic fatty liver disease. So with the newer medications and with this age-old molecule, Pioglitazone, we now have, as diabetologists, we now have more weapons with us to address non-alcoholic fatty liver disease than actually gastroenterologist. So we have Pioglitazone, we have GLP-1 receptor agonist, we also have SGLT2 inhibitors, which are new molecules which are in the pipeline. And there are small studies which Dr. Chakravarti has shown to show the role of SGLT2 inhibitors in non-alcoholic fatty liver disease. One of the oldest molecules being Pioglitazone. So we know there's a rising prevalence of non-alcoholic fatty liver disease and NASH. And there is a key connection between type 2 diabetes and non-alcoholic fatty liver disease. What are the contributors to non-alcoholic fatty liver disease? It is the lifestyle, the level of activity which a person has, that is whether the patient has a sedentary lifestyle or a more active lifestyle, food availability, exercise availability, dietary factors, and also genetic polymorphisms, gut microbiota, and dietary intake of saturated fat versus polyunsaturated fatty acids. They play a key role in determining the existence of non-alcoholic fatty liver disease. Now, when we see what is the algorithm for evaluation for patients who are at risk for non-alcoholic fatty liver disease, one of the most important algorithms is measuring the BMI of the patient, finding out whether he has central obesity, the waist circumference can help, the neck circumference can help. So as Dr. Lakshmi had said in the previous talk, that we Asians have a thin fat phenotype, where though we have a lesser BMI, we have central adiposity, and hence we are more at a risk of cardiovascular diseases as well as non-alcoholic fatty liver disease. So a simple physical examination where we find hepatomegaly, a simple screening test like ultrasound which can show fatty liver, and the patient's BMI can be quite indicative that this patient also has hepatic fibrosis, which is a serious issue. Now, FIB4 is a important and is an easy tool with which we can assess fatty liver. So depending upon that, non-invasive testing for fibrosis, that is a FIB4 score, we can classify patients as low risk, intermediate risk, or high risk. If the patient is in the intermediate risk or in the high risk group, then we can ask him to do a elastography or a fibroscan, which can give us the fibrosis score. Now, the initial evaluation, the most important initial evaluation of a patient with non-alcoholic fatty liver disease would be his BMI, the medical conditions which he has associated, the current medications, family history of diabetes, a family history of non-alcoholic fatty liver disease or cirrhosis, alcohol use, the amount he is using, the pattern of use, and also obstructive sleep apnea. Why we have to inquire about all these conditions? It is because these metabolic diseases are frequently associated with non-alcoholic fatty liver disease. Physical examination would give us an idea about the body fat distribution, whether he has central obesity or he has peripheral obesity. And certain simple laboratory tests, like doing a liver function test, which would give us the SGOT, SGPT levels, doing a platelets test, these will and would give us an idea about the fatty liver in the patient, that is the steatohepatitis. Screening is recommended in type 2 diabetic patients in metabolically complicated obesity. NFLD in the context of moderate alcohol use, we also have to keep in mind, because having isolated NFLD is also sometimes, it can be difficult. And then first degree of a relative of a patient with cirrhosis due to non-alcoholic fatty liver disease or NASH. Now, what are the parameters for non-invasive assessment of non-alcoholic fatty liver disease? Imaging like ultrasound, a fibroscan, MRI can be done, which is more specific for fatty liver. And then when we look into the potential medicines which are available for treatment in patients with non-alcoholic fatty liver disease, one of the molecules which is known to everyone is vitamin E at a dose of NASH without diabetes or cirrhosis, but there is a risk of hemorrhagic stroke and the risk of prostate cancer. Pioglitazone at a dose of 30 to 45 milligram per day is effective for non-alcoholic fatty liver disease, and we'll be going into the scientific evidence part of pioglitazone in this disease. It can be used in patients with NASH with or without type 2 diabetes. It leads to improvement in steatosis, the activity score, NASH resolutions, and also fibrosis resolution has been seen. Non-liver related fronts includes improvement in insulin sensitivity and CV risk reduction and also stroke prevention. It does have a cardiac benefit, though we do not see a cardiac benefit with vitamin E. Of late, GLP-1 receptor agonists have been one of the forerunners in the treatment of non-alcoholic fatty liver disease because they also lead to a weight improvement in steatosis, liver steatosis. It doesn't have a proven impact on fibrosis. Non-liver related improvement in insulin sensitivity, weight loss, cardiovascular risk reduction is seen. And as we heard in the previous talk, these molecules like liraglutide, GLP-1 receptor agonist, can slow the progression of medical renal disease. So pioglitazone in NASH, let us look into the clinical evidence which this molecule has. So in this New England, in this study which was published in NEJM in 2006, this study was done with 55 patients with IGT or type 2 diabetes and liver biopsy proven or confirmed NASH. This treatment was of 6 months duration with a hypocaloric diet along with pioglitazone at a dose of 45 milligram per day. There were 2 arms, one with a diet modification and pioglitazone and other with a hypocaloric diet plus placebo. And these patients were evaluated for hepatic histologic features and hepatic fat content by MR spectroscopy. In this study, the revelations were quite encouraging and it was quite good. There was a decrease in the plasma AST and ALT levels, and there was a decrease in hepatic fat content by MRI, and it was significant with pioglitazone compared to placebo. There was an increase in the level of adiponectin, and when you look into the placebo and healthy control and pioglitazone, you see that pioglitazone, the adiponectin levels reached almost similar ranges as healthy control after use of pioglitazone compared to that of placebo. When we look into the liver-related front, there was improvement in inflammation, there was decrease in ballooning necrosis in the biopsy, and that was all seen in biopsies. There was improvement in steatosis and there was improvement in fibrosis also. If you see, all these scores are clinically significant where the P is less than 0.001. So inflammation, ballooning necrosis, steatosis, as well as fibrosis. So it was seen that diet with pioglitazone improved the glycemic control, acted on the glycemic front. It normalized the AST, ALT values. It decreased the hepatic fat content, improved hepatic insulin sensitivity, and also improved histologic findings like steatosis, ballooning necrosis, inflammation. And there was greater reduction in necroinflammation, 85% compared to 38%. Again, in another study, which was done for 18 months, and then it was continued for 3 years. It was the long-term effect of pioglitazone treatment was seen in patients with NASH and pre-diabetes or type 2 diabetes. In this, also biopsy-proven NASH were recruited. And the patients were prescribed a hypocaloric diet and then randomly assigned to pioglitazone 45 milligram or placebo for 18 months. The primary outcome was reduction of at least 2 points in non-alcoholic fatty liver disease activity score in 2 histologic categories without worsening of fibrosis, and secondary outcome was histologic outcomes along with hepatic triglyceride content measured by MRI and metabolic parameters. Now, when the outcomes were seen, it was seen that in the primary outcome, more than 2-point reduction in non-alcoholic fatty steatohepatitis score, it was seen that pioglitazone brought about significant reduction in more than 2-point reduction in the score in 58% compared to 17% in placebo, which was statistically significant. And when we looked into the secondary outcomes, steatosis, there was more than 1 point improvement, which was again greater in the pioglitazone group compared to placebo. Inflammation was again reduced to a greater extent with pioglitazone, and ballooning was reduced to a greater extent, and fibrosis was also reduced to a statistically increased extent, ballooning, inflammation, and steatosis. And there was an improvement in fibrosis, which was, however, not statistically significant. But the numerical value of reduction in fibrosis was greater in pioglitazone group compared to the placebo group. So it was seen from this study that long-term treatment with pioglitazone was safe and effective in patients with pre-diabetes or type 2 diabetes and NASH. Along with improvement in the liver profile, the weight was similar in the placebo and the pioglitazone group. So after treatment, after 18 months or 1.5 years, fasting plasma glucose decreased in the pioglitazone group. If you see in the placebo, it was 119 after 18 months, and it was 110 in the pioglitazone group after 18 months when they studied. 2-hour PPG was reduced from 216 in the placebo and 173 in the pioglitazone group. Likewise, there was a reduction in HbA1c. There was improvement in the fasting insulin level, free fatty acid, liver fat content, AST, ALT levels. Triglycerides were also reduced with pioglitazone, the blood triglycerides, serum triglycerides. And LDL cholesterol was almost similar between placebo and the pioglitazone group. And when you look into the HDL, that was also similar between the pioglitazone and the placebo group. Now, in this study, they also studied the liver fat and insulin sensitivity before and after 18 months of pioglitazone. Liver triglyceride was statistically significantly reduced. Hepatic insulin sensitivity improved. Muscle insulin sensitivity also improved, and as well as adipose tissue insulin sensitivity. The plasma AST, ALT score improved, HOMA IR score improved, and adipose tissue IR score also improved. So from this study, it was seen that 3 years of pioglitazone treatment was associated with long-term metabolic and histologic improvement in patients with pre-diabetes or diabetes and NASH. Results suggest that NASH progression may be halted and natural history of the disease can be modified with the use of pioglitazone in these patients. A systematic review and network analysis, meta-analysis, where they did a comparative efficacy of pharmacologic therapies for fibrosis improvement in and resolution of NASH, showed that for NASH resolution, sema, liraglutide, and vitamin E plus pioglitazone had the highest probability of being ranked the most effective intervention for achieving NASH resolution. Pioglitazone and vitamin E were significantly better than placebo in achieving at least more than 1 stage improvement in fibrosis. So what do the ADA 24 recommendations suggest? That pioglitazone or GLP-1 receptor agonists are the preferred agents for treatment of hyperglycemia in adults with type 2 diabetes and biopsy-proven NASH, or for those with clinically significant liver fibrosis using non-invasive test. Statements from ADA also states that early diagnosis and treatment of non-alcoholic fatty liver disease offers the best opportunity for cirrhosis prevention. Pioglitazone and some GLP-1 receptor agonist like liraglutide, semaglutide, tirzepatide have shown to be effective to treat steatohepatitis and may slow fibrosis prevention and progression, and also have a beneficial effect on the cardiovascular risk profile, which is the #1 cause of death in patients with type 2 diabetes and non-alcoholic fatty liver disease. So these molecules, like pioglitazone and GLP-1, they not only address the non-alcoholic fatty liver disease axis in type 2 diabetes, but they also have a positive influence on the cardiovascular disease. Pioglitazone improves glucose and lipid metabolism and reverses steatohepatitis. Fibrosis is also improved in some trials. A meta-analysis concluded that pioglitazone treatment results in resolution of NASH and may improve fibrosis. It halted the accelerated pace of fibrosis progression in type 2 diabetes and NASH. So, what is the take-home message? We see that NASH, from the previous discussions, we see that the cause of non-alcoholic fatty liver disease is multifactorial, and treatment still remains challenging because none of the drugs have a full effect or 100% effect in reversing non-alcoholic fatty liver disease. The major factor in causing non-alcoholic fatty liver disease is the increase in liver triglyceride content caused by chronic release of free fatty acids from insulin-resistant dysfunctional adipose tissue. Pioglitazone targets insulin resistance, adipose tissue dysfunction, and inflammation that promotes hepatic lipotoxicity. In several clinical trials in NASH, pioglitazone was effective and very well tolerated. Thus, pioglitazone can be a more suitable alternative, more economical alternative, and more widely available alternative for treating steatohepatitis in patients with NASH, because as of now, GLP-1 receptor agonists still remain out of reach of the vast number of patients who have non-alcoholic fatty liver disease. So along with lifestyle modification, which plays a key role in reducing non-alcoholic fatty liver disease, amidst the drugs, especially drugs which are also effective in type 2 diabetes, we have age-old pioglitazone, which is not only available, is economical, but is also backed by scientific evidence and is recommended by guidelines. With that note, thank you for the patient here.
Thank you, Nilakhi, for a wonderful talk. Yes, Mr. Sir.
Then Dr. Kanungo, please take over for the panel discussion.
Ashok Bhai, any opinion on these three talks?
I think the presentations have been fabulous and has been complete and has clearly established beyond doubt the role of the molecules that we're discussing today. We can pass on to the panel discussion and the Q&A. Pramila has joined. I can see Pramila. And
good evening, sir.
Good evening, Lakshmi. Of course, she presented the data on the Vildagliptin. She's here. And so I think we can start the discussion. Dr. Chakravarti is here. Please, let us start.
Thank you, Professor Das. Excellent session. By now, DAPA, Pio, and Vilda has been so exclusively detailed and discussed that I think there are very few questions left, but still we'll discuss it a little further. I welcome Dr. Sumit Chakravarti.
Yes, sir.
Dr. Lakshmi Nagendra, Dr. Nilakhi Deka, and Dr. Pramila Kalra to the panel. My question is, first question to Nilakhi. In the context of pioglitazone's use for NASH, is there any specific patient education or monitoring that should be done to optimize treatment efficacy and safety?
This is a molecule which we have been using for quite a number of times, but the only issues associated with pioglitazone are its potential to cause to increase the chances of hospitalization for heart failure, because in spite of having the good actions of pioglitazone, we also see that there is a bit of fluid retention which occurs with pioglitazone. Hence, in those patients who are having macular edema, this molecule should not be used. Those patients having a risk of heart failure, this molecule should not be used. So, which are the kind of patients who are most suitable for pioglitazone? They would be those patients who are relatively young, who have non-alcoholic fatty liver disease and type 2 diabetes. So early in the course, before the patient actually develops the cardiovascular complications or has a change in the cardiomyopathy profile because of long-standing diabetes. So these patients can be offered this pioglitazone molecule, which improves insulin sensitivity, improves non-alcoholic fatty liver disease, and reduces cardiac atherosclerosis as well. So it would have an improvement in the cardiovascular outcomes. But the only issues will be those patients having macular edema and having potential for heart failure. So in those patients, we should be a bit careful.
How do you place pioglitazone in a young, newly detected diabetes who doesn't have this NASH or any other complications? When giving metformin, do you want to add it?
Yes, sir. So in fact, this is one of the molecules of choice, and this molecule is again, there has been a resurgence in the use of this molecule, and we see that this is a very good molecule. Even Defronzo has widely, who is responsible, who is the person who is the researcher who has told us about the ominous octet or the pathophysiologic defects. He places a lot of interest in these class of molecule. So in his articles, in his review articles, he has stated that pioglitazone may have a disease modifying role as well as GLP-1 receptor agonist and SGLT2 inhibitors, which characteristically affect those pathophysiologic defects, which are one of the key factors in causing type 2 diabetes. So early in the course, I think these molecules would be agents of choice because we can actually improve insulin sensitivity and also not cause in later stages, elderly individuals, long-standing diabetes. So there'd be a chance, there'd be a risk. But as you said, Alok sir, this would be a molecule of choice, especially in those patients who are newly diagnosed with type 2 diabetes, who are relatively young, irrespective of whether they have non-alcoholic fatty liver disease or they don't have fatty liver disease.
And if there is ankle edema that we face
Yes,
in amlodipine, and we discontinue amlodipine. So also if in pioglitazone therapy somebody develops ankle edema, we can always discontinue it. But he will get the benefit in the early intervention. My question to Dr. Lakshmi, how do you see the role of oral anti-diabetic drugs evolving in the next few years, especially in the context of emerging biotechnologies and digital health intervention? Where do they stand?
Speaking about oral drugs, we now have oral forms of injectable drugs as well, so which is coming up in a big way. So I think that oral drugs are going to come up with in a big way, especially because of their weight neutrality. We know the various, the patient stigma associated with insulin, and also the risk of hypoglycemia, and also, obesity, which we cannot, tackle effectively with insulin. One of the major drawbacks that patient can actually have weight gain. I think that drugs which have weight loss properties are also coming up in a big way. And also now we have oral anti-diabetic drugs which have CV and renal beneficial effects as well. So I think that oral drugs are even in non-diabetics. I think now everyone says we have the cardiologists, nephrologists, and also endocrinologists fighting over whose drug is really SGLT2 inhibitors. Everybody is saying that it is our drug. I think it's shown to improve renal disease, cardiac disease, NASH, everything. So I think that oral drugs are the they are, of course, be a big cornerstone in the management of type 2 diabetes. And I think they are also going to expand their indications from a glucose-centric approach to, treating actually the comorbidities of diabetes like obesity, renal disease, or cardiovascular disease. I think it's going to become more personalized.
80% or more people are taking oral drugs and they are very happily controlled. And in an economy like Southeast Asia, even glimepiride will stay all time to come. DAPA will come, price is going down. Other OHAs are coming, and other higher class of drugs are also going to stay. Pramila, ma'am, Dr. Pramila, I have a small question for you as we move towards more personalized medicinal approach. Dr. Pramila, are you there?
Yeah, I'm there. I'm very well.
So as we move towards more personalized medicine approaches, how do you foresee the integration of genetic and lifestyle factors in tailoring oral anti-diabetic therapy? Because now you mark that many companies are coming that will do the genetic profile of your patient and you can know whether he is metformin sensitive, he is pioglitazone sensitive or not. Those things are now coming to place. How do you see it, ma'am?
Yeah, because this is a very important question. Like we are discussing about multiple drugs and the use of oral versus also injectables, which we use for type 2 diabetes. So when we talk about genetics, we all know that diabetes and type 2 diabetes, when we talk about, has a polygenic inheritance. But we also know that now with new things coming up, and we are aware that there are some genes which tell us that this patient may better respond to SU. This patient may have a more predisposition for complications in future, like nephropathy. This patient may have a more propensity to get further cardiac problems early. So these all can be done. But just to add that at the moment, rather than just going on with the genetics, we can say that we should have more of what we say. We are now following a cluster classification, and we are following the phenotype classification. Like we say, okay, this patient has more of insulin resistance. Like we are talking about pioglitazone. We just spoke that Dr. Nilakshi said that if a patient is younger, not gaining weight, normal weight, that could be and more insulin resistant, maybe a better candidate for pioglitazone. So in a way, we are trying to make a cluster sort of a thing, and we deciding on the basis of phenotype. So yes, personalized therapy and personalized medication is going to come. We are definitely going to talk about the genetics and see that, okay, this patient may respond better, but that is not the only criteria. And I don't think that would be the only criteria for type 2 diabetes management in the future as well. It will always be a phenotype with a genotype correlation. So just saying a genotype will decide, I would say no. It will be an amalgamation of the patient's lifestyle, the patient's other factors, the patient's comorbidities, and alongside with that, the genotype as well. And alongside with that, the phenotype as well. Because patients who are like more insulin resistant may respond better to maybe metformin and pioglitazone. A patient who is obese or overweight may respond better to SGLT2 or GLP-1s. Patients having a higher propensity to get renal disease would be better off if they are put on SGLT2 from the beginning. So this is how it should be. So I think it has to be an amalgamation of all three rather than just the genotype for deciding treatment for type 2. That's how I put it.
Thank you, Pramila, for this wonderful answer. Whatever we may say about science, genes, and everything, affordability, accessibility, and availability will remain the cornerstone of drug prescription or oral prescription in India or any other country. Here I find Vildagliptin is gradually not getting its relative position. Lakshmi, I have a question for you. You presented Vildagliptin and told it is the best molecule. But in any CME we go, they say Vildagliptin not much evidence. But it is the highest prescribed drug. It is the best hypoglycemic drug among gliptins. If you give 3-4 gliptins, Vilda does the best hypoglycemic effect. And tell our viewers clearly the Vilda in role of liver, cardio, and renal diseases, where they will prescribe and not prescribe.
So, the data that I presented was over 12 lakh patients, actually, and now we have the US FDA mandates, which I said, it should be 4,000 patient years or 1,500 patients exposed for 1 year, or 500 patients exposed for 2 years. So actually, we have more data than what is mandated for a drug to pass the barrier set by the FDA. So there is more data with more than what is required with Vildagliptin. And also there was a meta-analysis which looked at almost 12 lakh patients. So the data, I would say, is robust. And when we talk about CV safety, again, I would like to emphasize that it's not a class effect. And Vildagliptin definitely has a good CV. I mean, it was shown to be non-inferior compared to other gliptins, and only saxagliptin had an increased risk of heart failure, and it is definitely not a class effect. I think much of the confusion stems from the fact that, you read somewhere that saxagliptin causes heart failure. You tend to think that, all the other gliptins might, have similar, because mostly we talk of class effect, right? Be it GLP-1 analogs or DPP-4, but this is one area where it is different, and CV safety has been established. And compared to, for the renal safety, again, like I said, if the GFR is up to 60, we can use it in a BD dosage, 50 mg BD. And GFR less than 60, I would say we use 50 mg OD dosage. And again, its safety in renal disease has also been well established. And it's in fact the only gliptin that we can give in patients with in all stages of renal failure.
Up to what EGFR you will prescribe it? 62?
More than 60, we will give 50 mg BD, sir. And if it is less than 50, we will give OD dosage, which is shown to be faster. And also it has been studied in EGFR of less than 15 also. Like renal replacement patients have also been on Vildagliptin with a lower hypoglycemia. I mean, when in CKD, we are always worried about hypoglycemia risk. So hypoglycemia risk was not very high with OD dosing in patients with compromised renal function, that is EGFR less than 60.
Regarding liver enzymes,
yes,
what
so,
enzymes level will you think prescribe?
So we have the Child-Pugh classification for liver disease, and in Child-Pugh class A, it has shown to be it is safe and it can be given. But if the patient is in Child-Pugh class B or C, it has not been very well studied in the severe stages of liver failure. So I would say that if the patient has a class A, that is Child-Pugh classification, class A, then I would give Vildagliptin, but class B and class C, there is not much robust data with Vildagliptin.
Thank you. Dr. Sumit, what do you think will be the impact of dapagliflozin in preventing or delaying the progression of diabetic kidney disease, and how this is changing the standard of care in diabetes management? DAPA.
Yes, sir. DAPA has been proven by a trial called DAPA CKD, where in patients with advanced renal impairment patients, dapagliflozin proved the composite endpoints appeared at a delayed time. The better is obviously with use of dapagliflozin. It prevents the albumin creatinine excretion. It prevents the falling of GFR. It prevents the doubling of creatinine time, and so on. So I believe that in patients of CKD, until and unless they are below 20 possibly GFR, you can and you should use a gliflozin SGLT2 molecule that has got so much of proven data as far as their safety or efficacy is concerned in managing diabetes and CKD.
Thank you. Nilakhi, you had a discussion on Pioglitazone, NASH, and all those things. What are the implications for patients with co-diagnosis of NASH and type 2 diabetes? Are there any particular considerations or contraindications? Nilakhi, are you there?
Yes, sir.
Please. My question is, what are the implications?
I understood. I got your question, sir.
Yes.
So, any contraindication to NASH with type 2 diabetes and without type 2 diabetes with pioglitazone? Is that your question, sir?
Yes.
So, when there is NASH without type 2 diabetes, we can perhaps start with a lower dose of pioglitazone and then increase the dose to the accepted dose where it causes reversion. But the newer studies with pioglitazone, in the earlier studies, the dose that was used was 45 milligram per day, 30 to 45 milligram, where it showed an improvement. But with the newer studies which are available with pioglitazone, it has also shown to be effective even at a lower dose of 15 mg. So contraindication would again be a patient having a history of heart failure, or a elderly, say a female who's in the postmenopausal age group with already established osteoporosis. We should be a bit careful in prescribing pioglitazone, because we know pioglitazone can actually modify the stem cells to more of adipose, towards more of adipose tissue, rather than from the bone they can concentrate more on adipose tissue. So as a result, there may be, because of the stem cell modification, there may be osteoporosis in those patients who are using pioglitazone. So in patients with heart failure, in those patients having osteoporosis, those patients having macular edema, I think we should need to exert caution in prescribing pioglitazone.
Thank you. My next question is to Dr. Kalra, Pramila Madam. What do you think about the potential role of combination therapy with newer oral antidiabetic drugs with traditional agents. How do you foresee this impacting treatment regimens in the future?
So we all know that the combination therapy is definitely needed for the treatment of type 2 diabetes, because we have understood over many years that diabetes has multiple pathophysiological defects, and these defects are to be targeted by different medications. And that's the basic concept of combination therapy. And if you see, we have data now, even like from the Verify trial, where initially the patients who had diabetes, who were drug naive initial period, and if they were put on metformin and vildagliptin, they had a better durability also of the action along with a better control. So that's why it's very important that we target multiple pathophysiology in diabetes. And when we talk about combination therapies, not only it helps in targeting multiple pathophysiologies, it helps to take care of the glycemic control better. It gives a better durability of the effect, and the patient is controlled on medication for a longer period. And like if you see previously, the approach used to be a stepwise approach, but now we say that hit early and hit hard, and that is what we actually have to do. This not only prevents the complications, keeps the glycemic control in range for a longer period, and actually, because the glucotoxicity is reduced, the beta cell apoptosis is also retarded to some extent. So in a way, that way, one way combination therapy is better. And along with that, when we talk about FDCs for a few of the combination therapies, it actually helps for compliance as well, because if the FDCs are used, which are acceptable and scientifically acceptable FDCs, those actually help to keep the glycemic control better, because the compliance is also good with those medications. And also now we have drugs which have very less propensity to cause hypoglycemia. Previously, if we see 15, 20 years before the DPP-4 inhibitors came into the Indian market before 2006, the drugs which were available mostly were SUs and metformin. But with SUs, we were always worried about hypos. But now, in the initial combination therapies, we have options of metformin, DPP-4 inhibitors, and SGLT2 inhibitors, which not only give a good glycemic efficacy, have a weight loss benefit with the SGLT2 and a weight neutrality with the DPP-4, and with a cardiorenal protection, and also a good durability with the least risk of hypoglycemia, and with also multiple other pleiotropic benefits as well. So that way, combination therapy is the need and is the scientific way to treat diabetes at the moment.
Very nice. Ma'am, how do you envision the integration of digital health tools like CGM and AI driven predictive analytics with oral anti-diabetic drug regimen?
The AI is the future. So all of us are aware that AI is the future of treatment, and with everything there is an integration now. So talking about the CGM and all may not be needed obviously for every patient on oral anti-diabetic drugs, but maybe few group of patients where obviously we know the indications where we would definitely opt for a CGM or a AI driven tool to monitor as well, because we know that patients who are on oral anti-diabetic drugs and are having hypoglycemias which we are not able to catch, and patient is complaining of some symptomatic or asymptomatic hypoglycemias as well, or is having some symptoms attributable to hypoglycemia, or patients where the HbA1c and the glycemic profile which the patient is getting is not matching, or if the patient is having a lot of glycemic variability, because we know with drugs like we discussed Vildagliptin and many more drugs, SGLT2s, we can take care of the glycemic variability as well. So CGM would be needed for some of these patients, may not be for all, because for on oral anti-diabetic drugs, we don't recommend for everybody. But as I alluded to, the few indications where we would be recommending once in a while CGM for the patients who are on oral agents. And AI-driven tools are very important, because the digital therapeutics is the future. So we know that for everything now, the patients are also more interested if things are done digitally. So I think that is going to help the doctors as well. It saves time. Our nurse educators can help us to do the thing, and we can save a lot of time and give better benefit to the patient as well.
Thank you, ma'am. We have 5-6 minutes left. Dr. Sumit, given the increasing use of combination therapies in diabetes management, how does the combination of metformin and dapagliflozin compare in terms of efficacy, safety, and patient outcomes, especially in the context of long-term diabetes control and reduction of cardiovascular risk?
Yes,
Dr.
sir,
Sumit.
definitely. Yes, sir, definitely. These two drugs, if combined, metformin and dapagliflozin, are going to have a very much positive impact on the long-term management of diabetes. because as I stated, it's a holistic approach. Diabetes patients are bound to have some degree of renal impairment in next coming up 5-10 years. So what about about some preventive things against their kidney involvement, against their cardiovascular involvement? So metformin can very well be combined with DAPA, or for that matter, any SGLT2 inhibitors, and they can bring about good glycemic control. They prevent the different complications like nephropathy, like cardiomyopathy or cardiac involvements in future. They have a synergistic mode of action, bringing together glycemic toxicity as well as weight reduction, as well as CV protection, as well as renal protection. So I think all these things are very positive, going to have a very positive impact on the further future.
Thank you. I'll ask 1 minute each, all the honorable faculties, to give the message on their topic of interest to our viewers. Dr. Chakraborty.
Yes, sir. My message is what I talked about. Diabetes nowadays should not be thought about only about glycemic control. You must take care of all the other associations: cardiovascular health, body weight, fatty liver, renal health, eye checkup, everything. So a holistic approach is the call of today. That is my message.
Dr. Lakshmi, please.
Yeah, just to add on to Dr. Chakraborty's message, I think we should be, person-driven treatment rather than a glucose-centric management. Like Pramila ma'am said, that there are many clusters which we now recognize within type 2 diabetes as well. There are so many different subtypes of patients whom we recognize, whom we know that will need insulin from the start, or an obese subset who will require weight-modifying drugs. So we should be actually tailoring our therapy to suit the need of the patient and not a blanket treatment imposed on all. So that would be my.
Thank you, Lakshmi. Dr. Pramila, please.
Yes, just to, in continuation of what everybody spoke, that we have to hit early and hit hard. The glycemic control from the initial years of diabetes is very important. We have to start from the beginning. We have to target multiple pathophysiology and do a patient-centered approach with a shared decision-making. And also we have to see that whatever the patient's comorbidities are, according to that, we have to decide the anti-diabetic drugs and do the treatment on time, and enough counseling of the patient is also needed. Because if we counsel the patient properly, then they will understand the need of monitoring and follow-up. So is also a very, very important aspect of treatment of diabetes.
Very nice. Dr. Nilakshi.
Again, sir, it is the caregiver or the physician who is the person with the first point of authentic information to the patient. So when a patient comes to us with diabetes, non-alcoholic fatty liver disease, it is important that we pass on the message that there are better medications which can treat diabetes as well as non-alcoholic fatty liver disease. Then other drugs which are there, but they are very expensive. Now we know a molecule of ursodeoxycholic will cost close to 30-35 rupees, and that is prescribed 3 times a day. There are other molecules also which are prescribed in non-alcoholic fatty liver disease by many gastroenterologists, which we know do not have a proven effect on non-alcoholic fatty liver disease. Also, the newer class of molecules which had a very good role, like obitocolic acid in non-alcoholic fatty liver disease, it was widely used, but then it has dyslipidemia as a side effect and pruritus, for which it has earned disrepute. So it is important for us to convey to the patient that these molecules, which are very currently, they are very economical, because if you look into the cost of dapagliflozin, they come at twice the cost of a metformin tablet. So around 8 to 10 rupees. Pioglitazone would come at a cost of 6 rupees to 5 rupees. So these molecules can be used for the treatment of diabetes and as well as fatty liver disease, because these also have a disease modifying effect because of their action, which is independent of the beta cells. So they do not pressurize the beta cells to cause more and more secretion in a patient who already has a dwindling insulin reserve in the beta cells. So they address other pathophysiologic defects, which can go a long way in modifying the natural history of diabetes. So I think that information we can pass on to our patients so that they can continue on these important medications rather than spending unnecessarily spending on other molecules.
Thank
so
you
that is
so
one
much.
frequent thing I have noticed
Yes.
while
Thank
treating
you so
patients.
much, all the beautiful panelists and gentlemen, Dr. Chakravarti, my co-chair, Vijay sir, and our mentor, Professor Ashok Das. What we gathered from this discussion, that dapagliflozin is a well-tolerated, acceptable molecule. Vildagliptin is extremely well prescribed with a lot of scientific evidence and very good glycemic control by Vilda plus metformin. And Pioglitazone, the newborn baby who was second time birth, and it is extremely good. For no fault of it, it was sent to prisons and now he is released. So we have experienced its good qualities during its first birth. Now all the younger generation must experience it during the new innovation therapy of pioglitazone, a wonderful molecule. Last word from Professor Das, and we conclude in a minute. You are muted. You are muted.
It's been a very revealing session from the word go. The topics discussed are very contemporary, and all the issues that that haunt us have been very well discussed. I have very minimal comment to say. That very updated discussion. And yesterday we are looking through the data of the aggregate, where they're giving this for the seed variety of type 2 insulin, for the mild variety, very mild drugs, from the IROD, which is more of resistance, both pio and metformin, and the results are very encouraging. Precision therapy and you know, the views of Lakshmi, fantastic Lakshmi. I hope you had a beautiful training on the bone trabecular space since we met last about 3 months back. Did you go and come back from
Yes,
Europe?
yes,
Yeah.
yes, sir.
I
Right.
congratulate
Thank
you.
you.
Thank you. And Relaxi, as usual, very unusually fantastic presentation. And nothing has been forgotten from pioglitazone to, I mean,
Thank
no
you.
bio has been forgotten. And Professor Chakrabarti, it is absolutely fabulous to say about dapagliflozin and its many avatars in combination.
We have now the other
Ability
session is waiting, and the speaker is in a hurry.
Yeah.
So we have the last session.
Just wanted to say, like metformin was with everything. Dapa today, which with all the drugs can be combined. Over to Alok for
Yes.
next session. Yes.
Our next session
Thank you
is a
so
very
much.
important talk on clinical talk organized by About Healthcare. They are very prominent international group, and their product is they want to discuss on again on pioglitazone uses in modern era, myths and facts, by none other than Dr. Gaurav Bhaduri, excellent consultant, Department of Diabetes and Endocrinology at ILS Hospital, Calcutta, and Apollo Sugar Clinic, Salt Lake, Belghata, and Newtown, previously attached with Medica Super Specialty Hospital. He has done his MBBS, MD internal medicine, SC endocrinology and diabetes, PG diploma in clinical endocrinology and diabetes, Royal College of Physicians, UK. Awards are gold medal in MD medicine, Subhash Chandra Maitro Memorial gold medal, Saroju Roy Memorial silver medal, and Dr. Bidhan Chandra Rai Memorial Prize, and faculty in various national and regional conferences, and conducted multiple insulin workshops and the state to empower physicians deliver better insulin care across the state, and member of ASE, RSSDI, API. Welcome, Dr. Bhaduri, for your talk.
Yes, thank you, sir. So, sir, can I share my screen now?
Yes, please.
So the screen is visible, sir?
Yes.
Okay, thank you so much, sir.
It needs.
Yeah, so can I start, sir?
Yes, sir, please proceed.
Yeah, thank you. So welcome all the delegates for joining me in this evening session, and I'm going to talk about pioglitazone. the adverse events and the myths and the facts related with this particular molecule. In the previous session, Dr. Deka has already talked about this, agent very well, but I'm going to take a little bit, in-depth message regarding the Pioglitazone. So we'll have 4 sections in the talk. The section 1 will be a little bit overview regarding the Pioglitazone as a molecule. In section 2, we'll go into the depth of the myth versus facts. In section 3, we will look at whether Pioglitazone is able to outweigh the benefits, is able to outweigh the risk. And in section 4, we'll talk about the key take-home messages. So as an overview of this agent called Pioglitazone, what we know about it is that Pioglitazone is an extremely potent insulin sensitizer. There is a preservation of the beta cell function, and it works independent of the beta cell function. And there is a very, not only durable, but a very significant reduction in HbA1c. It corrects multiple components of the metabolic syndrome, and there is also improvement in NAFLD and NASH. So this is just an overview of the, molecule. So insulin resistance in muscle and liver is at one of the more core physiologic defects of type 2 diabetes. Now we know Pioglitazone works through the PPR gamma activation at the nuclear level. So sometimes there is a little bit lag in the effect that the Pioglitazone starts showing in our patients. So we need to be a little bit patient while dealing with this agent because it's working through the nuclear receptors. And it improves the insulin sensitivity via multiple mechanisms, and that is through the stimulation of the insulin signal transduction. It improves the glucose transport, glycogen synthesis, and glucose oxidation. It also works at the level of the mitochondria and improves the overall mitochondrial function. It also reduces the plasma-free fatty acid levels, and thereby reversing the lipotoxicity that happens in our diabetic patient. Now, as I was talking about, that Pioglitazone 15 milligram per day can reduce the HbA1c in around 0.92%, whereas Pioglitazone 30 milligram per day can reduce by more than 1% HbA1c. And this reduction is also not only significant, but this is durable in the course of time. Now, if we go into the section 2 of our talk, that is the myth versus the facts. Now, in the myth versus fact 1 related to weight gain. So the myth is that Pioglitazone causes weight gain. Now the fact is that Pioglitazone actually does cause some fat weight gain, but there is also a lot more in depth regarding this. So we know Pioglitazone increases body weight by stimulating the PPR gamma receptors in the hypothalamus to augment appetite. And then Pioglitazone simultaneously stimulates the PPR gamma receptors in the subcutaneous adipocytes to induce genes involved in adipogenesis. So there is adipogenesis at the level of the subcutaneous adipocytes. And these newly formed small fat cells take up the free fatty acid that is, running in the plasma, thereby reducing the plasma-free fatty acid concentration. And the decreased flush of this free fatty acid into the liver will happen because this small adipocytes or newly formed fat cells are taking up the flush of the PPA and thereby preventing them going into the liver, muscle, and the visceral fat depot. So there is a kind of a fat redistribution that is happening in patients where we are using Pioglitazone. There are some additional mechanisms, like it stimulates the PPR gamma co-activator 1, causes transcriptions of mitochondrial genes involved in the fatty acid oxidation. So not only is taking up the free fatty acid flask from the plasma, but it also increases the intracellular and hepatocyte lipid content. It reduces by inducing the fatty acid oxidation at the level of the mitochondria and thereby reducing the lipotoxicity. Now, weight gain is common with Pioglitazone therapy, which is typically amounts to 2 to 3 kg of fat mass over a 1-year period and is mostly dose related. So if you're using the lower dose, you can expect a little bit of lesser weight gain. If you're using on the higher side, then you will expect a little bit higher weight gain. However, the greater the weight gain, the greater is the decline in the HbA1c and the greater improvement in insulin secretion and insulin sensitivity. Now, weight gain was associated with actually increased survival in the proactive study and mobilizes the fat out of the arterial wall. So this is again very important because this makes it anti-atherogenic. So no specific adverse effect of the fat weight gain has actually been observed in type 2 diabetic patients treated with Pioglitazone for even up to 3 to 6 years. Now, advices what we can talk about regarding weight gain is a dose related and can be minimized by not exceeding a dose of more than 30 milligram per day. And by this point, we expect 80 to 90% of the drug's clinical glucose lowering efficacy. Now, combination therapy of pioglitazone with metformin minimizes this weight gain. And if you're using it in a combination therapy with SGLT2 inhibitor specifically or GLP-1 receptor agonist, it reduces both weight gain and the fluid retention. So such combinations can also take care of the little problems that might arise out of it. And myth versus fact 2 related to edema and heart failure. So the myth is that pioglitazone causes edema and heart failure in all patients. But in fact, the fact is that pioglitazone may increase the risk of edema and heart failure in patients who are at a high risk or already in heart failure. So how pioglitazone causes edema and heart failure? What is the pathophysiology behind it? So the main effect is on the vasculature to decrease vascular tone, and then there is a secondary sodium retention because of the vasodilation leading to an edema. Now, the fluid accumulation happens in a non-compliant ventricle sometimes, and that might lead to a heart failure. However, in the IRIS study, what we find is that the number of patients who developed heart failure was very similar in the pioglitazone-treated and the placebo-treated groups. So per se, pioglitazone causing heart failure is not that well established until and unless the patient is already at a high risk of heart failure or already having heart failure. So probably in those situations, it's better to avoid the agent. The study also did allow for a dose reduction for edema or weight gain, not responding to initial lifestyle recommendation. And probably we can also follow this if a patient is complaining of edema or weight gain. Now, pioglitazone treatment is associated with edema and appears to be dose related. Again, very important. So if the patient is developing some kind of edema, you might try reducing the dose. So when pioglitazone is used in combination with sulfonylurea or insulin, the incidence of edema is increased further. So we should be a little bit cautious in such situation. It is not that it needs to be avoided completely, that you cannot use pioglitazone with sulfonylurea or insulin, but you need to be a little bit more careful in such situation. If more than trace edema is present, treatment with one of the distally acting diuretics should be instituted and the dose of the pioglitazone reduced. And in today's time, we have with us agents like SGLT2 inhibitor. So if we are combining them, then it can also take care of the edema to a certain extent. Myth versus fact 3 related to hypoglycemia. Now, patient's myth is that the patient receiving pioglitazone may be at risk for hypoglycemia. The fact is that pioglitazone is associated with a low risk of hypoglycemia. Now, if you look at the clinical evidence regarding hypoglycemia related to pioglitazone, in the first study, we have shown you an observational study from the UK, where the incidence rate of hypoglycemia was 50 to 100% less in pioglitazone-treated patients, as opposed to those who were on nataclynide or ripaclinide. In study 2, pioglitazone monotherapy was associated with much less hypoglycemia than glyburide-treated patients with newly diagnosed type 2 diabetes, and this was statistically significant. In study 3, pioglitazone-treated patient had significantly less hypoglycemia when used as an add-on therapy to sulfonylurea or metformin as compared to insulin glargine. So from this data, we can understand this pioglitazone per se doesn't cause that much hypoglycemia. It is a very low hypoglycemic risk. But if you're combining this agent with sulfonylurea or insulin, then obviously those patients might be at a higher risk, not because of pioglitazone, because of the other agents. Now, in combination with insulin, the rates of hypoglycemia are higher than in insulin use alone. So sometimes we need to reduce the insulin dose when the patient is also being prescribed pioglitazone. We need to be a little careful in such situation. Reduction in the dose of concomitant agent might be necessary. So either reduction in the pioglitazone dose or reduction in the insulin dose is something that we need to consider. In myth versus fact 4 is related to bone fracture. Now, pioglitazone, the myth is that pioglitazone may increase the risk of bone fracture in all patients. The fact is that pioglitazone may increase the risk of bone fracture in individuals at high fracture risk. So that includes a postmenopausal woman with established osteoporosis or those with prior fractures with low trauma. So low trauma fracture is actually indicative of osteoporosis, and postmenopausal women with established osteoporosis are the areas where you need to be a little careful before using pioglitazone. So if you look at the clinical evidence regarding bone fractures related to pioglitazone from the TOSCA study, what was seen was pioglitazone was compared with active sulfonylurea therapy in more than 3,000 participants with type 2 diabetes for as long as 57.3 months, and no significant increases were noted in fractures in pioglitazone exposed either female or male participants. And myth versus fact 5 is related to bladder cancer, and this has caused a very high uproar, maybe around 10 years back. And the myth is that there is an increased risk of bladder cancer with pioglitazone, and it is very well established. The fact is that although the increased risk of bladder cancer with pioglitazone is not well established, pioglitazone should not be used in type 2 diabetes with an active bladder cancer or a history of bladder cancer. And that is also, because we don't have enough data, right? So because there is some suspicion, okay, so we don't want to use it in a patient with active bladder cancer or with established history of a bladder cancer. But otherwise, pioglitazone causing bladder cancer is absolutely not well established. Rather, the reverse is true. So there was some proposed mechanism that how can pioglitazone cause bladder cancer. So there was some theory given regarding the crystal formation or the bladder irritation hypothesis, and this was believed to be the possible mechanical effect that might cause it. But no pharmacologic effect actually appears to happen through the PPR gamma pathway, where there is through which actually the pioglitazone works. So if you look at the evidences regarding this, so what we see is in the number one, we have a midpoint analysis of 10-year study, and it failed to find any association between pioglitazone and bladder cancer with sensitivity analysis showing that the neutral effect was present irrespective of the dose and the duration of therapy. In the multinational cohort study, the hazard ratio for bladder cancer with pioglitazone and rosiglitazone was absolutely at the unity, and the p-value is non-significant. In the IRIS study, there was no increase in bladder cancer was observed in the pioglitazone group versus the placebo. Now, in the myth versus fact 6, that is related to anemia. Now, the myth is that pioglitazone causes anemia throughout the duration of therapy. The fact is that pioglitazone decreases some degree of hemoglobin in around 2 to 4%, very minimal, and without clinical consequence only within the first 4 to 12 weeks of therapy. After that, it plateaus off. Now, how does pioglitazone cause this anemia? So pioglitazone causes a little bit of bone marrow suppression and has a dilutional effect due to an increase in the plasma volume. If we look at the data from the clinical studies, what we find is that mean hemoglobin values decreased by around 2 to 4% in patients treated with pioglitazone, and anemia usually occurred within the first 4 to 12 weeks of therapy and remained relatively constant thereafter. So rarely been associated with any significant hematological clinical effects. Okay, so these are mostly theoretical issues. Clinically, we don't see much of a problem. Myth versus fact 7 related to liver damage. The myth is that pioglitazone is associated with severe liver damage. The fact is that pioglitazone is associated with metabolic and histologic improvements in diabetic patients with NASH. Now, if you look at how there's glitazones with multiple actions preventing or treating or preventing NASH. So pioglitazone, it improves the histological features, reduces the hepatic steatosis, reduces inflammation and ballooning without worsening of the fibrosis. It improves the insulin sensitivity, as we talked, in the liver, skeletal muscles, and adipose tissue, and thereby helping us to resolve NASH. So one of the very important agents that we use in our patients who have type 2 diabetes along with NASH, and should be at the front if there is no strict contraindications to it. Now, if you look at the risk-benefit ratio of pioglitazone, so just to highlight that it might prevent around 47 non-fatal MIs and 20 strokes, while it could provoke 2 to 3 bladder cancer cancers for every 10,000 individuals treated over a 3-year period. Has a dubious bladder cancer risk? We don't know for sure, but most of the studies has shown that there is actually not an increased risk of bladder cancer with Pioglitazone. Only those who have got active, bladder cancer or a history of bladder cancer, it is a prudent decision to avoid in such situation. And an overwhelming benefit evidence regarding the cardiovascular benefits. Okay, so it's a very anti-atherogenic agent, and the fluid retention that is caused by Pioglitazone is not associated with increased mortality, might respond to diuretics, and is most important, is reversible in stopping Pioglitazone. It improves the glycemic control in patients with diabetes, and thereby its implication, the microvascular complications of diabetes. So the benefit is much more compared to the risk. So if you look at this, diagram over here, you can see the risk over here, and you can see the benefits on the other side, and the benefits indeed outweighs the risk. So the key message in today's talk is that Pioglitazone is a very potent insulin sensitizer, works wonderful in patients with high insulin resistance like Indians, that preserve the beta cell function, works independent of the beta cell function, causes a very significant and a durable reduction in HbA1c, corrects multiple components of the metabolic syndrome, and improves the non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Pioglitazone has an acceptable safety profile, may have beneficial cardiovascular and pleiotropic effects, and is clinically efficacious in patients with type 2 diabetes. Adverse effects like weight gain, fluid retention, fractures must be considered, it must be kept in mind, but I have told you where you need to keep your attention very, very strict, like patients who has active heart failure, patients who have a diabetic macular edema, patients who are having postmenopausal women with established osteoporosis. Maybe these are the areas where you need to be a little bit more cautious in using Pioglitazone, but otherwise, in a vast majority of our patients, it is a very wonderful drug that can take care of multiple issues in our patients. The adverse effects of Pioglitazone are clearly outweighed by the multiple benefits that it offers. Thank you for your very patient listening. I'm here if you have any questions for me.
Thank you, Dr. Gaurav. Excellent presentation, very clear in scientific data. We appreciate your presentation very much. One thing you told, 2 patients in 10,000 may get bladder cancer, but previously you have also mentioned there is no evidence of bladder cancer. So
Yes.
What is this? Is it contradicting?
Yes, sir, because so I have taken the worst of the lot. So some of the studies which has, shown that there may be a possible risk of bladder cancer. So even in the most worst, I have compared the worst possible, outcome that may happen, because most of the data today shows that there is no increased risk. But on the safer side, because we don't know exactly what's happening, so we say that if a patient has an active bladder cancer, then don't use. If you have an active past history of bladder cancer, don't use. So even if I take those cases, those studies where it suggests that there might be an increased risk, even that increased risk is like 2 patients per 10,000 patients you treat over a 3-year period. So even in the worst case, you will be preventing around 47 myocardial infarctions and 20 strokes against the 2 bladder cancer that might possibly you might get after 3 years of treatment with Pioglitazone.
Still, I think, Alok, this is the literature reviewed, and as Dr. Bhaduri said, it is in the person who is prone to develop bladder cancer, having a relative or having hematuria or past bladder cancer, and the dose is more than 28,000 milligram. There, the possibility is as low as 2 for 10,000. So it's a negative prediction that one should not be scared of the bladder cancer at all. And I think it rules out that one should not be scared about it. But I
have the last question, Dr. Bhaduri.
Yes, sir.
Regarding osteoporosis in ladies,
Yes,
we
sir.
should not give. How our clinicians in the rural places or those who do not have much facilities will establish that the lady is having osteoporosis?
So, sir, what is a very straight cut from the history, but that will be a secondary, action call. So I would, that is not usually suggested, but if a patient has a low trauma fracture history, so that can prompt us to understand that probably the patient has a osteoporosis, and there you can avoid it. But otherwise, if the patient doesn't have a low trauma history, and if the patient is a post-menopausal woman, very difficult to clinically establish whether the patient has osteoporosis or not until unless you go ahead and do an DEXA scan.
But it is about elderly female, Dr. Baduri?
Yes, this is mostly because
elderly female, I think.
yes, the postmenopausal woman is the high risk zone. We need to be a little bit careful in that. But again, the data suggests that even in postmenopausal women who doesn't have osteoporosis, their risk of getting osteoporosis is not much increased with the use of pioglitazone. It is only those patients who are already osteoporotic. We need to keep ourselves away from using this agent.
I think our question was, we are not doing a DEXA, so even from plain X-ray is not available. So I think the better to avoid it in post-menopausal, very elderly female. That's what we do, Alok, in the peripheries.
Right.
Yeah,
Excellent.
though it's a very noble molecule, the PPAR gamma agonist, these properties, what already been mentioned by Dr. Kanungo and Professor Dash, and you have also described, it can precipitate anemia by hemodilution, by fluid retention. It can deteriorate the heart failure. Anybody who is having a impending heart failure. It can precipitate osteoporosis, and the rare possibility of bladder cancer is already discussed. So these are the few things which has to be kept in mind, and otherwise it has the advantage of even working in NASH, working in patients who are having very predominant insulin resistance, and after giving 2-3 drugs, those who are still not willing for insulin, we can take a trial with this molecule, which is very affordable for Indians. But I think, what is your opinion?
Sir, I would like to make one comment over here regarding anemia. The drop is usually 2 to 4%. So even if a patient is having suppose a 10 gram per dl of hemoglobin, and 0.2 to 0.4 will be the drop that we can expect from pioglitazone. So that is very, very minimal. So clinically, the hemodynamics, that's the fluid retention, those are a problem. But regarding anemia, I don't think that is much of a problem in practical world with the use of pioglitazone. It's a very, very minimal drop in hemoglobin, very minimal.
Okay.
I'll request Professor Das to sum up the day and close the day, and followed by Jayanta to give vote of thanks and sum up the day. Professor Das, please.
I think first, coming to this lecture by Dr. Bhaduri, I must tell you that I'm really very much appreciative of your lecture, and it has been really one of the best things that we had at the end of the day, Dr. Gaurav, and with your absolutely majestic voice and the contents that you had, it was good. Thank you, Abbott, for bringing Dr. Gaurav. Now, coming to the day's work, we started on time, and that has been our motto today. And as every time, we had the beautiful inauguration followed by in memoriam of one of our very prominent professors. Then we started on to the session, and the first session was on the obesity, and that was a fabulous session with professors Dr. Sunil Gupta, Briz Makkar, Professor Dr. Nitit Kapoor, and also Dr. Nita Deshpande joined the discussion. It was very good. The impact of diabetes on the brain was another great session with Sambit and Chandan at the Health Affairs. We have Soumya Darshan, Dr. J.B. Kanwar, Arundhati. There's the interview with Sunil Narayan, Professor Head of the Department at JIPMER of the Neurology, and Sambit also conducted a beautiful panel discussion. Alok and Srikant drove the first session on the therapeutic approaches, which was set around the new insulin aspart biosimilar, which is recently launched short-acting insulin aspart by USB, very well taken. Dr. SK spoke about sulfonylurea, and DAPA, the first line of therapy, was spoken by Dr. JJ. Then we had the next session, complications, a fantastic session by Jayant and Tumanti. We had Dr. P.K. Sahu, who spoke extremely well on the very aspect of the diabetic heart disease and what should do. Manisha and Georgie, the debate was superb, and Manisha was very forceful. I really liked the way she presented her points. We had Subrat, who did did an interview, answered an interview for my questions on the MASLD. It was very good, followed by the panel discussion. And we had the last but one session on the future of the oral anti-diabetic drugs. I really like the way Alok was probing the questions. I think the future of the oral anti-diabetics, I didn't have time to point out Alok, but I cannot but say that the advent of oral semaglutide and the technique of having the protein in a pill, I think it opens up newer vistas for all the other hormones, starting with insulin or the whatever hormone you can think, glucagon. And also the future of the oral is very bright for the very, very fact that, we had in the 100 years, 3 injectables. But in 100 years, we had 9 oral anti-diabetic drugs. If the pace of the progress is similar, then we can progress earlier. And the combinations which India's one of the India's pride for the compliance, convenience, and cost cutting has been accepted by the world, so the future is very bright. And I have spoken about Dr. Gaurav's talk, and over to Jayant for his comments. And I must tell you that it has been a fabulous day. Over to Jayant and Alok.
Thank you, sir. And the most important thing I noted on the whole day is Professor Ashok Das' design of the scientific program and implementing it very passionately, session-wise. As he has told, every session of today, starting from obesity, the brain, and the oral drugs, the complications, all were excellent. And all the faculties he has already named had done their best.
A big round of applause for all the faculty.
Yeah, all the faculties, they had done their best. So when we were designing the program, discussing about the tidbits, what all we had thought, we have delivered much, much better than that because of the good effort by the faculties and the vision of Professor Das, our scientific chair. So tomorrow, I'd like all of you to be at 11 because we are starting a little late. We have 5 very interesting sessions starting from insulin and incretin, then exercise, basal insulin, technology, and bone and muscle health. All are very, very important, unusual topics discussed in a meeting, and you'll get best of the faculties of the country discussing there. So don't miss these discussions. Be there tomorrow also. And I'm sure the way the program is designed, the talk, debate, interview, and panel, this is fabulous. This is out of the world. And whenever you take a topic, you listen to the didactic lectures, not longer, just 15 minutes. Then you listen to the controversies in the form of a debate, listen to a key opinion leader in the form of a interview, and then come to the panel where you have a scope of asking a question also and listen to all possible questions discussed. There cannot be anything better than this structure. There cannot be anybody who are better than these faculties and these topics. So wish to see all of you tomorrow at 11. And tomorrow the whole day will be again a day of scientific presentations. And with this, I request Dr. Kanungo to end the day with thanking all our guests, Professor Shamal, Professor Tripathi, and the revered Professor R.K. Das, remembering his contribution to clinical medicine. The day was started, and all the faculties, all the chairpersons, all the moderators, and the panelists, they have done the best. So expecting the same performance tomorrow, we'll be ending the day today. Over to Dr. Kanungo.
Yeah,
Thank you, Jayant.
I'm sorry, Alok. I must tell you that we must give a big round of applause and thanks for the thousands of audience who have joined us. Because of you, we are here. I really appreciate the great number of audience who have joined today. Thank you very much. Alok, sorry, you take over now.
No, thank you. Thank you, Ashok Bhai, Jayant, Dr. Gaurav, Manisha, and anybody who is still in the faculty link, and my dear delegates. This was a wonderful day. Diabetes discussed in a different way. Diabetes discussed in a different platform. Science and clinical medicine merge together to give the best result to the clinicians. We are looking forward tomorrow for insulin and other discussions, GLP-1, and many clinically important topics are there which are not usually discussed. So at NUCD, National Update on Clinical Diabetes, we have our own thought process and we design indigenous and better programs, that we should say. And credit goes to Professor Ashok Das, Dr. Jayant Panda, to all Abhay, Sambit, Dr. Kanwar, Jayasri Swai, and many others, those who have always, Dr. Bijay Misra, and many other, Lalit. So, Devasis Das.
And Alok, I must interfere here. This new format, let the world know, is the brainchild of Alok and Saurabh. Thank you.
Thank you. Saurabh, in fact, designed it. He is a postgraduate from Nottingham University, economist.
Alok's son.
My son, he in fact gave it, no, we should go international. And this is his brainchild. So all credit goes to him and to Professor Das, everybody. We have joined together and we have
For
done
the
it.
first time in the country, I see this structure, and this is so appropriate. I am sure that in future days, many will follow us.
Thank you. Thank you, everybody. Good night. All of you have stayed till this time. Tomorrow, see you at 10:55. Thank you.
See you.
Thank you. Thank you, sir. Thank you, sir.
Thank you, Gaurav.
Thank you, sir.
Thank you,
Nice
Manisha.
talk. Very nice talk.
Thank you.
Very nice. Thank you.
Thank you.
Okay, Stuti, can you close?
Recording stop.